Conference of IMA College of General Practitioners. We will begin with the proceedings right away. One of our senior most IMA members, Dr. N. Vijayan, a very senior psychiatrist, passed away yesterday at the age of 94. Let us all observe a minute of silence in his memory. Thank you. So we'll start the first session. I request the chairpersons to come and assemble onto the stage. I first call upon Dr. Priya Praful, Consultant Physician, ICRA International Hospital. Madam, please take your seat on the stage. Thank you, Madam. I now call upon Dr. Shihabuddin P., Intensivist and Consultant Physician, ICRA International Hospital, to take his place on the stage. These two doctors will be the chairpersons for this session. I now call upon Dr. Shamir V.K., Associate Professor Medicine, Government Medical College, Kozhikode, to deliver the talk. Chairpersons, please take over.
Good morning, everyone. At the outset, I should thank the organizers, especially Dr. Shamsuddin, for giving me such an opportunity to chair the session. Now, our first topic for today is a fever of undifferentiated origin, or short febrile illness as we commonly call it. Now, we all know as physicians, fevers are always a perplexing problem for us. So, and the speaker for the session today is Dr. Shamir V.K. And I'm sure most of us do not require any introduction to him. He is currently the Assistant Professor at Calicut Medical College. Previously worked in the Infectious Department at Thrissur Medical College. And his work during the COVID and Nipah has been recognized by the National IMA and the Kerala State. So let's begin the session. Over to you, Dr. Shamir.
Good morning all, respected senior faculties and my dear friends. At the outset, let me thank the organizers of this wonderful program for giving me such an opportunity. And the topic given for me, as the chairpersons were indicating, is acute febrile illness. And it's often a confusing term. It's not actually the pyrexia of unknown origin. This is a short duration fever, and we usually call it as a short febrile illness or an acute fever, acute febrile illness, acute undifferentiated fever, and acute undifferentiated febrile illness. So many terms are used for the same thing, and I'll be next 30 minutes I'll be trying to discuss on this topic, how to have a rational approach when a patient comes to us with an undifferentiated fever. So we often wake up with such news every day. This type of fevers, it creates headache not only for the patient but also for the doctor who is treating us, because all news every day we come across with fever deaths, and the people worried whether their fever is going to be a troublesome issue for them, or it's going to be a short duration of time. So majority of the febrile illness get resolved in a short period of time, like 3 or 4 days. But very rarely some of such incidents can happen, and so majority of the people are worried, is the cause of their fever and is it going to affect their life, or is it going to create some severe complications? So that's the main worry, and we will try to solve this issue, and how to prognosticate, how to tell the relatives, is it going to be an issue or not, and how to have a reasonable approach when somebody comes with a fever. So the different terms used: acute undifferentiated febrile illness, acute fever, and sometimes you can see discharge cards being issued from medical colleges written SFI. No politics is intended there. They just mean that it is just a short febrile illness. There is no other diagnosis. It was just a febrile illness which got resolved within a few days' time. So in this talk, I will be using this term acute undifferentiated febrile illness, or AUFI. That is the most standard term used all over the world. Most of the literatures call this febrile illness as acute undifferentiated febrile illness. So when do we call the fever as acute undifferentiated febrile illness? It's actually fever of less than 2 weeks. That makes the big difference between a pyrexia of unknown origin and then acute undifferentiated fever. So the duration kept is less than 2 weeks, and there is no organ specific clinical features. So I'll go to the details. What is this organ specific clinical features? Just remember that the duration of fever less than 2 weeks period. So what is this organ specific symptoms? So you can see majority of the fevers, especially in this season, come with such symptoms: cough, upper respiratory tract symptoms like sore throat or rhinitis. The symptom itself tells us that the infection most probably is in the respiratory tract. So that is the one of the most common. Another one is the abdominal symptoms: abdominal pain, diarrhea, vomiting, etc. So the symptom itself directly localizes the infection to gastrointestinal tract. Sometimes patients may come with skin infection like this, some cellulitis or abscess. And one of the dangerous localization is the nervous system, as you all know. Patient comes with fever with altered sensorium, seizure, and definitely we look for the signs of meningeal irritation and any of these signs of like neck stiffness, and the infection directly localizes to the nervous system. And one of the commonest infections in females, that is a urinary tract infection. Patients come with dysuria, lower abdominal pain, etc. So all these symptoms are directly evidences which tell us that the infection is localized to the particular system, and we directly start treating accordingly. So our topic, the acute undifferentiated febrile illness, first rules out these organ specific symptoms. So all these symptoms are asked for, and these are absent, and you cannot localize the infection to a particular organ or a particular system. Then we go to the term acute undifferentiated febrile illness. So 2 weeks duration with no organ specific symptom. So the first step, definitely all our patients, they use different terminology. Some come and tell us that they have fever. ചില ആൾക്കാർക്ക് ഉൾപ്പനിയാണ്, ചിലർക്ക് ഉൾക്കിടിലമാണ്. So many things they tell us, and the first step definitely is make sure that the patient is having a fever. So luckily after the arrival of COVID, people are very fond of this thermometer and pulse oximeter. So we can even tell them and ask them to record the temperature at home, and they will definitely come with a temperature recording. If they are admitted, you can do this in our wards, and this is the first step. Make sure that what they are having is a real fever, the temperature is high. And the second step in the approach will be epidemiology. So you cannot have a diagnosis, or you cannot think of a diagnosis without a proper epidemiological setting is analyzed. So when having such symptoms, definitely it's going to be especially in the last 2 years, you can think of an upper respiratory tract, a virus which is fond of an upper respiratory tract, definitely COVID-19 or any other respiratory viruses will be the first thought which come to us, our mind. But even a patient who comes from such a family may come with a prolonged fever or exacerbation of his previous symptoms, like a cardiac patient, a severe LV dysfunction is being admitted in our ward with a severe pulmonary edema, but he tells such a history and he had a very short duration fever. The same virus has precipitated his previous comorbidity. So that is what we gain from such a history. So it can be the family, it can be in a school or it can be a workplace, all the people having similar symptoms, definitely you think of a so you consider the local disease prevalence as a first step. The second one is the seasonality. So we know we have a fever period. Panikalam is well known. എത്രയോ വർഷങ്ങളായിട്ട് Kerala has a pattern. At certain months, everyone at home develop these sort of illness. So during those seasons, we can directly think of infections which are related to that season, like the flood and rainy season. We have to be beware of leptospirosis and definitely the mosquito-borne infections like dengue, malaria not that common in our part, but when we talk about the scenario all over the India, malaria is still a common disease. So all the mosquito-borne diseases, leptospirosis, all these have a seasonal tendency, and also infections like influenza have a seasonal tendency, and COVID-19 most probably it's also going to be we expect a seasonal tendency for COVID-19 also. So if we are not aware of this, the media people will definitely make us aware. Before the arrival of COVID-19, this was a common news in every newspaper and every channel. They used to show like this 2018 or 17, you can think of the dengue epidemic. So this was the scenario just before COVID-19. So the second part of the epidemiology, after the seasonal variation, after the clustering of cases, we think of the occupation of the person, and some people who as a part of their hobby, who do trekking to the forest, etc. So these type of areas, exposure to forest, jungles, etc., make them more prone for infections like scrub typhus. And rarely we know, and also people who exposed to these paddy fields, farmers, all these are more at a risk of developing a leptospirosis. And some specific regions like Wayanad, who are having a more chance of, even though rare, we get a few cases of KFD. And Nilambur, we get, often we had few cases of even Kala ulcer. So all this, depending on their travel history, depending on the area from there they come, and the job they do, all these give us some clues regarding the infections which they might have acquired. So whichever may be the virus, whichever may be the organism, which to what extent benign it may be, but still we have to handle some people with care. So always a pregnant lady and an elderly woman like this, a person who is already having a chronic disease like a COPD or a CKD, CLD, all these multiple comorbidities, and patients immunosuppressed. So all these people, even they develop a very mild infection, it can be dangerous. So the approach we keep in our mind when such a person develops be totally different from a general population. So we have to care them more vigilantly. We have to monitor more closely, and even an infection which can be very benign in a usual healthy person can be dangerous. So we have to have this thing also before starting our approach to a short fertility. And the third step will be, don't misunderstand, he is just doing a proper clinical examination, and this will be his examination. So two things we make out from history and examination at this stage will be, the first and foremost step will be always rule out a severe infection. Is it a life-threatening a problem for the patient? So is there any feature which tells you that the patient is going to have a life-threatening issue? And the second part of the history and examination will be the same thing. Is there any organ-specific symptom or sign which can help us to localize to a specific organ system? So severity, how do we assess? So any person who deals with a fever, especially the juniors, the house surgeons or JRs, they see the fever at a casualty emergency. The first thing they have to look for is the vitals of the patient. Is he having a disproportionate tachycardia? is he having a disproportionate respiratory rate, and if he is having a hypertension. Definitely it's going to be an issue. You have to keep the patient under monitoring, and he has to be hospitalized, because it can be a systemic inflammatory response syndrome. You know what is it? And that means he has such features and he is going to sepsis, or it can be a part of the infection which has some life-threatening complications like ARDS. It can be a myocarditis. If it is a malaria, it can be a severe falciparum malaria, or it can be a hemorrhagic dengue. ARDS, especially in leptospirosis and scrub typhus. So all these things out as the first step. And the second, after these life-threatening signs, you look for other indications for hospitalization. A patient who is severely sick, he cannot he cannot walk alone, or he needs support for walking. He is lying down all the time. Such a patient, even though his vitals are stable, he is so weak, better to hospitalize and monitor. Very high temperature, very low temperature, any patient having a neurological dysfunction in the form of altered sensorium or seizure, it's always mandatory that patient should be hospitalized. And a severe abdominal pain and vomiting. Even in dengue fever, the warning symptom can be an abdominal pain and vomiting, and the patient should be hospitalized, and he is the candidate who can go for other complications. Severe pallor along with anemia, fever, and also bleeding manifestation. So indications for hospitalization. So these are the examination things which we do when we get a fever. We all the general practice, the senior physicians are very well used to do all these things. I need not elaborate on this. One of the most common is the ENT. Then cardiovascular, you look for a murmur and any evidence of infected endocarditis. Abdomen, you look for the liver, any hepatomegaly, especially tender hepatomegaly, any signs of cholecystitis. And abdomen, always look for an renal angle tenderness, any suprapubic tenderness, any localized bone tenderness or an monoarthritis, an swelling and pain in a specific joint. And dental, of course, like dental abscess. And respiratory system, you look for any crackles, any bronchial breath sounds, that's an evidence for pneumonia. And sometimes a unilateral pleural effusion. It can be a part of a pneumonia, or even dengue fever can present with a unilateral pleural effusion. And abdomen, again tenderness and guarding rigidity always makes the condition still worse. And skin, look for cellulitis and all the other evidence of skin infection. Any localized swelling in a specific region will also tell us infection most probably is in the drainage area. So now we have examined the patient, we have looked for specific organ symptoms and signs. So we have ruled out all the organ specific infections, and we are going to undifferentiated fever. Now we have some diagnostic clues again from the examination, and the most important one being an eschar. If you get an eschar in an acute febrile illness, it points directly towards the scrub typhus. But an absence of eschar cannot rule scrub typhus, but presence is a very, very strong clue. Conjunctival suffusion can happen in so many infections, but commonly in leptospirosis, dengue fever. But if it is a conjunctivitis, not just a redness, but an inflammation along with that, it more suggests a Zika virus infection. And also in this context, after the COVID-19, you have a multi-system inflammatory syndrome, MIS-A. It's not, we cannot call it as a direct infection. As a sequelae of infection, you can get a conjunctivitis. Muscle tenderness, the specific, when you go and press the muscles, the patient is crying with pain. It's more classical of a leptospirosis. And fever with rash and polyarthritis, more suggests a dengue fever and also chikungunya when the epidemic is common in that setting. And an intensely pruritic rash, itchy rash, and on the first day itself with a cephalocaudal from head to foot distribution is more suggestive of a Zika virus infection. And rash appearing towards the fourth or fifth day, a maculopapular rash without itching, can be more suggestive of a dengue. So these are typical findings or a diagnostic sign which you get during your examination, but it tells us a as a clue that we may be dealing with infections like this. So this is a typical appearance of a conjunctival congestion with jaundice, and this is the classical eschar which we get in. And when we examine for eschar, we have to be very. Usually we don't get in the exposed areas. It's more common sites like groin, axilla, etc. So a thorough clinical examination after exposing the patient is a must for looking for this. The classical rash we get in dengue fever. And Zika, you can see the rash together with the conjunctivitis. Very mild fever, rash with itching. Conjunctivitis is a classical clinical feature of Zika virus. Zika virus I am repeating because we had an epidemic, we had many clustering of cases, especially Trivandrum, Kollam, those regions. So we can expect Zika, and it is said to be present in Kerala definitely, but what timing we are not sure. So we can expect Zika virus infection any time in the future also. So these clinical signs which I was elaborating were something specific to some infection. Some signs also tell us that is not specific infection. That means some signs are helping us to rule out an infection. Like when a patient presents with a rash and lymph node, you can almost definitely tell that it's not malaria. Similarly, when the patient is having a generalized lymph node enlargement, it's very, very unlikely that patient is going to have an. And we may think a patient is coming with a high-grade fever and a severe, significant jaundice on the first or second day. Patient may have a hepatitis, viral hepatitis, but it's very, very unlikely that patient may have a viral hepatitis, a patient presenting with a fever and jaundice together. So usually viral hepatitis, you get a fever, nausea, vomiting, and jaundice appears a bit later. So fever, jaundice together, patient is coming in the first or second day, or with a high-grade fever and jaundice, etc. It's more suggestive of a leptospirosis or a scrub typhus than a viral hepatitis. So suppose the patient is having a significant symptoms or signs like sepsis, or patient is having an organ dysfunction, you are suspecting a sepsis. So if you are planning for an empirical antibiotic, always remember that take a blood culture and send a blood culture before the initiation of antibiotics, or after a few days we should anticipate a problem in making a diagnosis. So being said all these things, all people do not obey the same rule. We are aware of this in our medicine because exceptions are the rules. So even though these undifferentiated febrile illnesses do not have specific organ symptoms or signs, there are cases, or there are significant percentage of these type of infections, still they come with some organ specific symptoms, like dengue fever. Dengue fever can come with cough and rhinitis, but we won't think about dengue at all when somebody present with a fever and cough. So we have to keep this in mind also. Similarly, leptospirosis diarrhea. We get a quite number of patients with fever, body pain and diarrhea, and finally the diagnosis turn out to be leptospirosis. And lepto and scrub typhus are very well known to produce respiratory involvement. May come with a fever, cough and severe breathlessness on the first or second day, and patient's final diagnosis becomes dengue or lepto or scrub. Similarly, meningeal irritation. Even though patient is having a headache, altered sensorium, we think of a CNS, think of some herpes or TB, meningitis, etc. And finally, the diagnosis can be a lepto or scrub again. So they can come with a meningitis, meningeal signs. Similarly, a warning symptom of dengue is classically described as abdominal symptoms. And expanded dengue, they can have cardiac involvement, they can have CNS involvement. So cerebral malaria also, patient can come with an altered sensorium, and finally. So some of these typical etiologies which can present with acute undifferentiated febrile illness can organ specific symptom also. We have experiences of treating a meningitis, doing all the investigations for meningitis, everything comes out negative, and finally the scrub typhus becomes positive. So that's also possible. So after this, we have a febrile illness, we have ruled out all the organ specific infections, ruled out the severe sepsis or life threatening signs. Then we go for a etiological diagnosis, and the first infection we would like to rule out is a malaria and dengue, because the rapid diagnostic tests are very specific and sensitive in case of malaria and dengue. So malaria, we won't say all patients with this acute febrile illness should undergo a malaria test in our locality, but depending on the epidemiology. So if you are clinically suspecting malaria strongly, you can directly do a diagnostic test for malaria, rule out it, and consider dengue fever, NS1 antigen initially. So these two things we can easily rule out. So first few days, especially for the first 3 to 5 days, when the patient is not having any life-threatening symptoms or sign, patient is not having a definite sign of any bacterial infection like UTI, respiratory, paracetamol only. And we have to be very, very cautious here. No NSAIDs to be given during this period of time, only paracetamol, and maximum you can add is a PPI or ranitidine or something like that, and plenty of hydration. That's the only treatment required other than monitoring of the patient. So next step is, if the patient is still continuing to have fever, you have done all these things, patient is 3 days you have treated with paracetamol, hydration, but continue to have fever, then the next step is again we try to reassess the patient. Again we have to revisit all the symptoms and signs of specific organ infection, as well as again, once again, is he developing any life-threatening symptoms or signs. So the rapid diagnostic tests are negative. That means it's not dengue, it's not malaria. There is no evidence of any sepsis. Then the most common infections which present with that pattern is enteric fever, leptospirosis, or scrub typhus. That's the pattern in Asia as well as Africa. We are talking about the locality which we belong. And some of the viruses like EBV, chikungunya, HIV, hepatitis, influenza, majority of the cases present with respiratory, but there are enough case reports saying that influenza and COVID-19 also without respiratory symptoms, only fever presentation is common. Zika, we can expect. Crimean Congo, I have included the name because it's something equivalent to Ebola in Africa, which can happen in Asia, but we have no much reports, but we have to anticipate all these things, Japanese encephalitis and KFD in some peculiar geographical areas. Some bacterial infections like melioidosis, infected endocardial brucellosis, all these then can come in specific settings. And again, we have reached a situation where we have not solved the issue yet. Malaria is ruled out, dengue is ruled out, patient is continuing to have fever. So we go for other routine investigations, blood counts. You are all aware, the counts give us a very valuable information in this context, because WBC count, if it is high, you think of a bacterial infection like lepto, or low, you think of a viral infection like dengue. Malaria, scrub, enteric fever, all these can have a normal count. Enteric fever can even have a leukopenia. Then thrombocytopenia, again lepto, dengue, very common. Scrub typhus also can present with a thrombocytopenia. Then PCV, hematocrit, you monitor it for dengue fever. And ESR, again, a very valuable clue. If it is high, you think of a bacteria, especially lepto, dengue. In ESR, usually in dengue, usually you get a low ESR. And a prolonged fever with a high ESR, suddenly showing a rapid trend of fall in ESR, you have to be very careful, because you have to rule out something called an HLH, or macrophage activation syndrome. So falling count and falling ESR, you have to be worried. It's not a good sign when the patient is having continuous fever. And urine microscopy, urinary tract infection, even though have some classical symptoms in a young patient, but an elderly or a geriatric patient with a fever may not come with a typical urinary symptoms. They may come with a just fever with vague symptoms, altered sensorium, etc. And leptospirosis can have various types of urine manifestations like albumin, RBC, pustules. It may look like a UTI, may look like a proteinuria. So all different types of manifestation is possible in a leptospirosis. Liver function test, almost all these infections. Time evideya? Time evideya? Shamsu? Evideya kanikkan? Parayo? Ayo? Okay. So liver function test can be abnormal in almost all these infections. And RFT, leptospirosis especially, and hypokalemic renal failure is a common thing. So next is serology. When we go for a serology, we depend a lot on this IgM, lepto, IgM scrub, etc. But we have to remember that it's not that sensitive or specific test. Just depending on the IgM, you cannot diagnose a short febrile illness. So there are a lot of fallacies because major thing is a late appearance of IgM. You cannot wait for an IgM to get positive to treat lepto, scrub, etc. Sensitivity is low. Cross reaction, you can get a lot of cross reaction between these infections. More specific things are like PCR culture, etc. is possible only in very big academic centers, only in the early phase. Not even think about that. And even with a classical clinical picture and IgM positivity, you can call maximum a probable disease. You cannot 100% confirm a disease by just getting a IgM positive. So after this, if you are thinking of a treatment, there is nothing wrong in giving an empirical antibiotic in a patient if you are strongly clinically suspecting an infection like lepto or scrub. So you can think of starting a doxycycline or azithromycin even without getting an IgM positivity, because it's going to be life-threatening. You assess the patient clinically and you have a strong suspicion, definitely you can think of an empirical antibiotic. So after that, you are continuing the investigation. We can be happy that majority of the cases, 95% of the cases get resolved either with our treatment or even without our treatment, and 5% is going to be a pyrexia of unknown origin. So if the fever is persisting, we have to repeat the culture again. Then we go for further imaging like chest X-ray, which may give some clues like a tuberculosis or some lymph nodes in lymphoma, etc. Then imaging of the abdomen, which may give us some clues like liver abscess or a melioidosis and splenic abscess, etc. And if we are not getting any clue from these things, even a bone marrow examination with culture in case of especially like endric, granulomas, etc. And CRP and procalcitonin can be useful. CRP especially to rule out a viral from a bacterial. CRP more in favor. We cannot tell that CRP always gives an indication that it's bacterial. It's more of a negative predictive value. That means if a CRP is low, if a procalcitonin is low, it's very, very unlikely that the patient is having a bacterial infection. So this is the flow chart which I was enumerating. Almost the same thing. First fever, you rule out the life-threatening things, you rule out the organ-specific things. Then you look for rash. Then investigation first, malaria, dengue. Then we observe the patient, paracetamol hydration only. Then again a re-examination, re-history. Look for again signs of life-threatening things. If it is not there, you think of the common infections like endric fever, leptospirosis, scrub typhus. Lot of viruses can also present, but we not worry about them much. Just symptomatic treatment is enough. Then again, if the fever is persisting, we go for a blood culture, a repeat blood culture, urine microscopy, chest X-ray, USG. Empiric antibiotic therapy, when you suspect a sepsis, when you suspect a life-threatening symptoms and signs, or a lepto scrub is in your mind, definitely an empirical antibiotic therapy is justified. Or if it is not there, you can wait for the culture, you can wait for the fever to get subsided. So this is again the summary, the different etiologies, malaria, non-malaria, viral, especially I have enumerated all these things, bacterial and parasitic. So MAESR is the code given for the common etiologies for undifferentiated fever, malaria, arboviral, endric fever, spirochetes, and rickettsial infections. So there can be odd always. I am not enumerating the elaborating the case because of the short of time. This is a young boy who presented with fever and thrombocytopenia with evidence of myocarditis, and he had an altered LFT and very high inflammatory markers, 18-year-old boy in this context. So we suspect all these things. So there is something called a MIS-A, multisystem inflammatory syndrome A, which is a new diagnosis, relatively new diagnosis after the COVID-19. So there can be some presentations like this also. It need not be an infection always. So there is a definite criteria for MIS. So COVID-19, and this is another patient with ecchymotic patches and thrombocytopenia. She doesn't remember a period of febrile illness before that, but incidentally her IgM was positive, and she was being treated as dengue and thrombocytopenia, getting a lot of platelet transfusion again and again. But IgM dengue positive just doesn't confirm a diagnosis of dengue. So it was actually a hematological malignancy. So thrombocytopenia, even with body pain, etc., need not be a dengue always, just because she is having a IgM dengue positive. And this is another patient, COVID-19 positive, and she was having a prolonged fever, and she lost around 10 kg. And COVID-19 was positive, she was again and again reassured it can happen like that, and the chest X-ray was like this, and sputum was positive. So IgM positivity or a serology positivity does not always conclude that disease. Another one, rheumatoid arthritis patient who had rash, itchy rash. She had jaundice, all the organ impairment. She came with the features of multi-organ dysfunction syndrome. Serology, everything was negative, and her diagnosis was drug-induced. So all this can also occur along with the context of this one. So it was just for a curiosity's sake, because ഇപ്പോഴത്തെ കാലത്ത് ഇങ്ങനത്തെ ഒരു സാധനം വന്ന് ഒരു MCQ ചോദിച്ചു കഴിഞ്ഞാൽ everyone is going to diagnose a monkeypox. It's not monkeypox, it's just chickenpox. Monkeypox is not common, and it's not that when you get a fever with rash, always go and diagnose monkeypox. It's very, very rare such a context will come. So now we had a patient who had altered sensorium, seizure, ongoing status epilepticus. She was in ventilator, and initial all the parameters were negative, and she was having an ongoing seizure also. So she was being treated as viral meningoencephalitis, and when she reached there, after 1 week, when we repeated the scrub serology, the IgM became positive. So it was a scrub typhus, and she is improving also after doxycycline. So she got all the antibiotics and acyclovir, but because IgM scrub was negative, she didn't receive a doxycycline. But the repeat IgM scrub is positive. She had a very interesting history of traveling to Wayanad as a part of Scout, NCC or something, and after that she developed these things. So the final thing is acute undifferentiated febrile illness can range from mild to severe organ life-threatening diseases. The overlap of epidemiological and clinical features often renders clinical diagnosis difficult. Laboratory confirmation is often difficult again. Lack of guidelines lead to indiscriminate use of antibiotics. Proper use of clinical judgment with stress on epidemiology and seasonality, and judicious use of investigations will enable to arrive at a reasonable treatment plans. And initial assessment of life-threatening features and triaging, including empirical antibiotic, is of paramount importance to decrease the mortality only in specific cases. Thank you.
Thank you, Dr. Shamir. That is a wonderful insight into the management of short febrile illness. I have a small question. How many days will you normally wait if there is an undifferentiated or a short febrile illness? If there are no life-threatening conditions, how many days will you wait before starting an empirical antibiotic?
If we don't suspect a lepto or scrub typhus by clinical features like severe muscle pain, muscle tenderness, hemorrhagic manifestations, other organ involvement, 3 to 5 days is quite reasonable. Just paracetamol and hydration would be enough. We need not even think of any other specific antibiotic. In case of, if you have a strong suspicion of lepto or scrub like a scar or any other clinical features, we can just empirically start on treatment for those two infections. Other things, if you have ruled out sepsis, you are not thinking in terms of a bacteremia, we need not think of an antibiotic at all.
Okay, thank you. If the audience has any comments or questions, now is the time, please.
Thank you, sir.
Thank you,
Dr. Shamir VK, please accept this memento from the Indian Medical Association as a sign of our gratitude. Thank you, sir. Next, we have Dr. VG Pradeep Kumar, Consultant Neurologist, Baby Memorial Hospital, Kozhikode, speaking to us on stroke management in early hours.
Yeah. Good morning. Next session is on stroke management in early hours. We know the stroke is a very common issue and a life-threatening and debilitating problem nowadays. And its management, the disease-modifying management is only in early hours. And there was a time where there was no difference if you present early or late. But nowadays, last 10 years, the stroke management evolved in such a state that every minute and every hour counts in the management of stroke. And the topic is discussed by Dr. Pradeep Kumar. We doesn't need an introduction for Dr. Pradeep Kumar in this hall because he is a ex-IMA president, state president, and he is the chairman of National President of Indian Stroke Association, and he is a very senior consultant in neurology, and he has done his DM in neurology from All India Institute of Medical Science. And I welcome Dr. Pradeep Kumar. Sir, on to you, sir.
Thank you, Chairperson, for the kind words. I'll be touching upon the management of acute ischemic stroke only, because stroke can be due to ischemic stroke or hemorrhagic stroke. We know that 85% of the strokes are due to either thrombosis or embolism, and 15% by intracerebral hemorrhage or subarachnoid hemorrhage. So there is a lot of revolution has happened in the management of acute ischemic stroke during the last decade, and in the field of IV thrombolysis, in the field of mechanical thrombectomy. When we were students, when we were taught by doing MBBS and MD, like P.K. Shashidharan sir and all, we used to give aspirin, we used to give statin, and H2 blockers, and then some vitamin Neurovan and Fort. And we advise physiotherapy. Most of the patients are discharged because of lack of bed on third or fourth day. Now the scenario has completely changed. It has changed to such an extent, it has advanced much more than the coronary intervention. Can I, which is forward one? Right one. We should the global burden of stroke before coming to the management. The stroke is one of the leading cause of morbidity and mortality, and it is the second cause of morbidity and mortality across the country. And stroke is the prevalence of stroke across the country. We have only crude study. ICMR has initiated a process of collecting the data across the country through an instruct. There is a new program ICMS has initiated. We know that we can see that this red one, Kerala belongs to the red one, that is one of the highest stroke prevalence in the country, to the tune of 625 per 100,000 population, 1 lakh population. And various other states are coming up in the various color codes has been described. So we know that the stroke is causing so much of morbidity and mortality. As far as the incidence is concerned, we have got a very few registry. One is from Trivandrum, one of the best studied registry, which was published in the Stroke Journal in 2009, which shows that about 135 per 1 lakh population. It was from the Trivandrum suburban population, not only from the city, from the suburban population. The study was conducted by Sri Chitra Tirunal Institute. Ludhiana had a few registry under the auspices of Ludhiana DCMC Medical College, Christian Medical College, Ludhiana, which took a 162 per 100,000 population. There was a study from Kolkata which showed about 145. So on an average about 135 to 145 per 1 lakh population is the incidence of stroke per year. And as well as the other registries are concerned, there is a small registry from Mumbai as well as from Vellore. Why we want to analyze the incidence as well as the prevalence? Because of the financial burden on the country. At an individual level, you can see it was in the dollars. It was a landmark article published in the International Journal of Stroke in 2017. Yearly cost in subsequent years, it comes to about 3,000 as far as if the patient is independent on MRS 0 means independent on activities of daily living, it is $3,000, and if all the cost is dependence also calculated, MRS 5, the patient is dependent, you see $40,000 per year is the cost. So that is the burden of the stroke on the individual, family, society and country at large. This is the algorithm of the stroke acute stroke management. We have got various tablet molecules, aspirin for acute ischemic stroke, IV thrombolysis, endovascular thrombectomy, that is arm in the other one, because aspirin if the patient presents outside the window period, IV thrombolysis if the patient presents within the window period for IV thrombolysis, recommended window period is 4.5 hours now. Endovascular thrombectomy up to 6 hours in anterior circulation. In a selected cases, on a selected imaging basis, you can take up to 16 hours and beyond. And rapid TIA access and prevention clinic if the patient has got TIA, and we have stroke clinics, comprehensive stroke care units including rehabilitation and early supported discharge. This is a pattern or the algorithm for stroke care in the country. Why we want to emphasize on this again, I'm sorry for the slide, I don't know whether you can see here, because per minute about 2 million neurons are lost due to acute ischemic stroke. This is regarding the cerebral blood flow as well as you can see the normal blood flow is 54 to 60, may range up to various studies are shown, but 54 to 60 ml per 100 gram per minute. Threshold for synaptic transmission loss is up to 20. 20 should be their minimum. And if it comes to 10, there is stroke or infarct. So our agenda is to have the infarct is in the center. Pointer, please, pointer. You don't have point. The infarct is in the center, and the area around the infarct is penumbra, where there is an ischemic area, and the oligemic area, which is still have more blood supply. So you can see how fast the infarct grows. From the 6 hours, you can see here, to the 24 hours, an established infarct, the large right MC infarct. That is the speed with which an infarct progresses in an ischemic stroke. So time, this is an MRI angiogram. Patient with the TPA, IV thrombolysis was given at 1 o'clock. And up to 1:30, you can see how this MCA, occluded MCA has recanalized to the extent as almost 2/3 is recanalized. So this landmark article, again, initially it was approved for 3 hours, recombinant tissue plasminogen activator, and subsequently it was extended to 3 to 4.5 hours after acute ischemic stroke. And you know what are the downside of IVTPA is recombinant tissue plasminogen activator is given is 0.9 milligram per kilogram body weight, 10% is given as bolus, 90% is given as IV infusion. And can have hemorrhage. That is the only downfall of IVTPA, 6.4% hemorrhage. In our thrombolysis almost 1,200 patients since 2004. And our study shows that 2.9% is intracerebral hemorrhage. The limitation of intravenous recombinant tissue plasminogen activator again is a generalizability. Utilization is only 5 to 10%. The patient is not reaching the hospital on time for IV thrombolysis. And big strokes are very tough, especially the National Institute of Health Stroke Scale score. That is important. Somebody who is thrombolyzing, you can get certification online. If it is more than 10, and mid-cerebral artery M1 occlusion, internal carotid artery occlusion, and basilar occlusion. These are large artery occlusion. They may not respond to IV thrombolysis. They respond only to 40 to 50%. Clot length. We now CT angiogram is a standard protocol where you can estimate the clot length. If it is more than 8 millimeter, again it is a tough case for IV thrombolysis. Large vessel occlusion is a rate of recanalization only 10 to 40%. And again, if at all it is recanalized, sustainability of the recanalization is not sure, there is chance for reocclusion. This is a scoring system. The National Health, NHS score or National Health and Stroke score is very important. It's a clinical score. This is a radiological score. It's called Aspect score. Alberta Stroke Program of Canada, Calgary, they developed this score. It's very useful. We can see that M1, M2, M3 is the middle cerebral artery branches. I is again insula, again internal capsule, C caudate, lentiform nucleus. So there are various M4, M5, M6 again. So there is a scoring system of aspect score. This program is developed by the Alberta Stroke Program by the Calgary group. We can, all the students will be going through, the radiology students especially. So whenever now the acute stroke comes, the CT scan is taken, this aspect score is coming here. Because the aspect score has got very important, higher the aspect score, better the prognosis, lower the aspect score, it's again prognosis different. So again the clot burden score is under one. How much is the length of the clot? The stent is normal, the clot is absent. 0 is complete multi-segment vessel occlusion. So there is 0, the score is low, again severity is high. And increase in the clot burden score is a smaller clot extent, smaller baseline infarct. So if you thrombolize, less parenchymal hemorrhage and a good clinical outcome. So these scoring systems are very useful nowadays. Even before we take up for thrombolysis, you can say that these patients will be benefited out of thrombolysis. This is the collaterals. When we do a CT angiogram, you not only identify the thrombus or the clot, you identify the collaterals. With the middle cerebral artery collaterals on the left side, you can see there is lack of collaterals on this side. Collaterals are less than 50% of the middle cerebral artery territory here, whereas there you can see more than 50%. So if collaterals are more, there is better outcome in these patients. This is a modified TAN system. So various scoring systems are there. Now every postgraduate will be studying this. This is a MITIF system again, based on the number of collaterals, 1, 2, 3. Less score means no collaterals. Higher score is much better collaterals. So the imaging protocol for an acute ischemic stroke in any hospital for standard is CT brain to exclude hemorrhage, followed by CT angiogram to assess whether large vessel occlusion like internal carotid, basilar or middle cerebral artery occlusion, and as well as the assessment of the collateral, how good is the collateral so that the patient will be recanalized after thrombolysis. CT perfusion, CTP means CT perfusion study. Same only, we are injecting the dye with a pressure injector, which will estimate you the core as well as the penumbra. How much is the core of the infarcted area, how much is the penumbra. And again, if the patient is a wake-up stroke, if we do not know the onset wake-up stroke or found unresponsive, MRI may be useful. MRI will give you a diffusion, perfusion mismatch. Diffusion will give you a clear idea about the infarct, and again, the flare mismatch, flare will not show the much signal changes, means there is no edema, that means the infarct has not settled down. So it's an evolving infarct, you can take up this patient. Similarly, posterior circulation stroke is, MRI is very useful in identifying pontine infarct. Many a time we may mimic ataxia hemiparesis, we may think about capsular stroke, it may be a pontine stroke. So whenever we give a patient coming to emergency department, we have to take up this patient for angiogram, CT angiogram. So what about the creatinine value? There are various studies and the meta-analysis shows that you need not bother about the creatinine value for doing CT angiogram. You can take up this patient directly for CT angiogram because that is not going to change the outcome. So this is the aspect score I have mentioned, various score, low score, middle score and high score. That is good scan, fair scan and poor scan, which will give the outcome. Higher the score, better the outcome. So coming to IV thrombolysis patient selection, the patient should be presenting within 4.5 hours of ischemic stroke. And if the patient comes earlier the better. Less than 90 minutes, the best outcome. Again, 90 to 110, modest outcome. And more than 270 minutes, you give conservative treatment, don't take up this. Similarly, patients on double antiplatelet as well as single antiplatelet, doesn't make a difference. Still, it is better if the patient is on single antiplatelet. What about patients on anticoagulation? If a patient is on conventional anticoagulation, if the INR is more than 1.7, don't thrombolyze the patient. Only if it is INR is 1.7, you can take up this patient for thrombolysis. Regarding the newer anticoagulation, which many of the patients are on now, like dabigatran, apixaban, rivaroxaban, we cannot thrombolyze as per the present guideline. There are various guidelines in various countries. I just mentioned that. The minor strokes, like do we treat? low NHS score. Previously, NHS score less than 5. Its maximum score is 42. Less than 5 is considered as minor stroke, and thrombolysis was not advocated. Now the situation has changed. NHS score 3 with severe leg weakness. For example, left ACA stroke, right lower limb weakness alone. That is a severe disability. NHS score 3 with cortical blindness. Similarly, a patient is having aphasia. These three conditions, even though score is less, you should be taking up this patient for thrombolysis. So again, treat if the physician perceives the presentation to be disabling for that particular individual. It's an individual tailored one. And treat if intracranial proximal arterial occlusion present on vascular imaging. When you do a CT angiogram, though the stroke is minor, if you find a intracranial atherosclerosis or significant stenosis, you can thrombolyze this patient. And some people will be going for MRI, and MRI will be showing microbleeds, and they say the radiologist may report multiple microbleeds. So the physician will be reluctant, or neurologist will be reluctant to thrombolyze. But cerebral microbleeds will not affect the outcome of patient. It will not increase the intravascular hemorrhage secondary to IV thrombolysis. You can take up these patients safely because they are due to, even if the patient have cerebral microbleeds. Regarding glomerular filtration rate and symptomatic hemorrhage in IV thrombolysis patient, even the GFR should be normal. If the GFR is less, there is a chance of increase, poor outcome, or there is more chance of hemorrhage in this patient. These are the standard guideline, 2018 American Heart Association, Stroke Association guideline, which was approved by Indian Stroke Association also. We have some modification only. BP should be less than 185 by 1 ton when we thrombolyze, otherwise chance of hemorrhage is there. Blood sugar should be more than 50. Less than 50, the hypoglycemia can mimic stroke, so less than 50 is not indicated. More than 400 again should not be taken up. And aspirin use is not a relative contraindication now, it can be taken up. But the patient is on oral anticoagulant, conventional anticoagulant like warfarin. If the INR is more than 1.7 is contraindication. Newer oral anticoagulant is again a contraindication. So this study versus another molecule has come, altiplase, that is plasminogen vascular, was the only molecule available till 2016. Subsequently, tenactiplase came because the disadvantage of altiplase was this cost. It is costing about, now it is about 60,000. And unfortunately, Government of India has taken that molecule out of the price control. Revision, that's the first molecule which is taken out of price control, which should have been inside much more restricted price control for that molecule. And tenactiplase has come. Tenactiplase you can give only single shot, straight IV single shot. Altiplase you have to give a 10% IV bolus followed by IV infusion. So tenactiplase dose, various doses have been tried, 0.25 milligram and 0.5 gram, 0.4 grams. And it has been found that tenactiplase dose is point. There was a study, a Canadian study, ACTA study, which published last month, 0.25 versus 0.4 milligram per kilogram body. Found that 0.25 milligram is the best dose with reduced intravascular hemorrhage. And the second aspect of the mechanical thrombectomy. In India, tenactiplase is approved for minor strokes as well as TIA, less than 3 hours, as with the Drugs Controller General of India. They have not approved up to 4.5 hours. And in Canada now, they are approved up to 4.5 after landmark trial. FDA has still not approved tenactiplase, but tenactiplase is widely used nowadays, especially after post-COVID. There was a lot of patients with ischemic stroke and embolic stroke. Coming to the mechanical thrombectomy in large vessel occlusion, like internal carotid artery, midcerebral artery, or basilar occlusion. We have mechanical thrombectomy, various devices can be used. Through the catheter, you introduce a device. Mercy retriever was approved 2004. You can retrieve the clot through this retriever. Penumbra device, again, it was approved 2007. And now stent-assisted retriever is 2015, it is approved. So mechanical thrombectomy is found to have much better advantage over IV thrombolysis in large vessel occlusion. Not in lacunar infarct, small or medium vessel occlusion, large vessel occlusion, like internal carotid artery occlusion, midcerebral artery M1 occlusion, and basilar artery occlusion. So various studies are there with mechanical thrombectomy. All have found that there is significant improvement in outcome if the patient is taken up within 6 hours. Only thing is that now the studies have been refined by using various imaging modalities like perfusion studies. Perfusion studies will clearly give you how much is a core infarct, how much is a penumbra, and how much is other aspect of this. So in this study, published in Lancet in 2012, the recanalization was 61% compared to 24% in those patients who underwent IV thrombolysis. Again, endovascular therapy after IV TPA versus TPA alone. So these patients, patients were taken up for mechanical thrombectomy, and before that, before initiation of taking the patient to cath lab, they were given IV thrombolysis, and subsequently some patients were not given IV thrombolysis, they were also taken for mechanical thrombectomy. And this found that there is not much difference between those patients who underwent IV thrombolysis and those patients who didn't undergo IV thrombolysis before mechanical thrombectomy. But the problem is that in a country like India, where the patient cannot afford mechanical thrombectomy because of this cost, if you are denying the IV thrombolysis, that is not pardonable. You can give IV thrombolysis, that is what we used to do, because 10 active plays cost only 16 to 20,000 rupees. Active stores 50,000 rupees. But if you deny that, if the patient cannot afford, you are not giving anything. So if the patient presents within 4.5 hours, please do IV thrombolysis, because many patients may not be able to afford mechanical thrombectomy. So how can we improve systems of care is a crucial time point. So first, medical contact, coming to the emergency department arrival, do imaging plus IV RTPA, then growing puncture, reperfusion. This is a flow chart for mechanical or endovascular treatment. We are using an app designed by our own colleague, Dr. Mohan Leslie Noon. The moment patient reaches a casualty, that's activated. The emergency department, the neurology department, the radiology department, ICU staff, everybody will be alerted. The patient will be straight away, initial assessment going to imaging, and that imaging has got separate pathway. Whatever imaging is pending, this will be given priority, and straight away after imaging, patient will come to neuro ICU or will go to cath lab, depending upon the vessel occlusion. And we had initially, when we started thrombolysis in 2004 and 5, we had about door to needle time. The moment the patient reaches emergency department to IV thrombolysis were about varying about 70 to 90 minutes. But now it is less than 40 minutes. And we are trying to bring it to less than 30 minutes. American Heart Association has set a standard of 1 hour. European Stroke Organization has kept a standard of 45 minutes. Now we are running much less than that. Because earlier you thrombolyze, earlier you reperfuse, revascularize, the outcome is much better. These are the various control trials of the endovascular treatment. All the trials have given positive outcome on a large vessel occlusion within 6 hours. And if you want to do it beyond that you have to have various individual specialized perfusion studies like CT perfusion, MRI perfusion. So overall treatment effect in disability shift is number needed to treat is only 2.6%. Only small number you have to treat, you can prevent disability. And functional independence is, to attain functional independence, only you have to treat only 5 patients. Even in aspirin, you have to treat about 11 patients if you give aspirin. But in a large vessel occlusion, this is a large vessel occlusion only, not for small vessel occlusion. And this is again the guideline for the early management of acute ischemic stroke. I have already mentioned, within 4.5 hours, IV thrombolysis is if it is a small or medium vessel occlusion. If it is a large vessel occlusion, within 6 hours, endovascular treatment. The distal vessels, what we will do if the M2 occlusion and beyond, suppose left MCA occlusion, left M2 occlusion can sometimes present aphasia, very aphasia and right hemiparesis. Studies have not proved beyond M1 now. As of now, internal carotid artery, basilar artery or M1 occlusion. Beyond that, the endovascular treatment is not recommended or approved now, but studies are going on that after some time it may take up that also. This is, I will just conclude by describing 1 or 2 patients. The 50-year-old lady, this patient without any comorbidities, went to sleep at 11 p.m., woke up at 6 a.m. with global aphasia and right hemiplegia, reached hospital at 11:30 a.m. and 12 hours and 30 hours from the last seen normally. So whenever patient is coming to you with a wake-up stroke, when was the patient seen last normally? That is the question. And this NHS score was a very high score, 19. Aspect score was 8. And we can see CT angiogram shows a complete occlusion on the complete cutoff, the left M1 occlusion. With the distal ICA to M1 is completely occluded. Collaterals are very poor here. And the CT perfusion, you have to assess 3 parameters: cerebral blood volume, cerebral blood flow, mean transit time, MTT. Blood volume is again, if it is 30 ml per 100 gram, and blood flow again 30, and mean transit time, if it is 4 seconds. 4 seconds means that the moment you inject dye to reach the dye to analyze, that is a mean transit time. If it is more than 4 seconds, these are the cutoff date. If it is beyond all these, the outcome is poor. You can see various color codes are there, and the blue will show the maximum core infarct and on the left side. So this patient was taken for angiogram and the endovascular thrombectomy. You can see the recanalization within 40 minutes. You can see now the left MCA is completely recanalized and the patient had marked improvement also. After 24 hours, NHS score, which was 13, has come down to 6. At discharge, patient was 0. Patient went walking from the hospital. That is a gratifying result. But only thing is you have to be very selective. The team should be very much aware of the radiology finding, imaging finding. Then only you should take up the patient. Don't generalize all these activities. Only should be done on a selective case basis. So, massive core, if the core is large and penumbra is not there, if you are doing this, it will be doing harm. If there is no penumbra, only core is there, no benefit. If the small penumbra, less benefit. If there is a large penumbra, there is a large benefit. So, how much is large is a penumbra, that is more important. Penumbra is area, an impending ischemia which we can salvage. That is important. So, this rate of growth of infarct, rapid growth of infarct is 15 to 100 ml per hour. Intermediate growth is 3 to 10 ml per hour. Low growth is 10 to 15 ml per hour. So, this is a guideline. Early window period within 6 hours for endovascular thrombectomy is approved. 6 to 24 hours on a case-to-base basic CT perfusion. So, to patients with acute ischemic stroke, within 3 hours of acute ischemic stroke, you can be given IV tenactiplase or actiplase. Both can be given. Tenactiplase has got a less cost, actiplase has got more cost. Patients 4.5 hours as per the Indian guideline, only alteplase is approved now. And patients with large vessel occlusion within 24 hours of onset should have mechanical thrombectomy on a selected case basis. Within 6 hours, it is straight away approved. With 6 to 24 hours, if you have a perfusion study like MR perfusion, CT perfusion, collateral assessment, you can take up. Non-invasive vascular imaging should be done along with non-contrast CT scan. Now, if the patient is coming to the department, emergency department, along with CT angiogram is a must now. It's a must. Should be performed. If it's a large vessel occlusion, immediately you can send the patient to a center where the facilities are available. And stroke system of care should be in place to get the best outcome for patients. Not only the IV thrombolysis, subsequently when the patient is coming to step down ICU or the ward, you should have the patient having a physiotherapist, a stroke nurse looking after prevention of aspiration, infection, bed sores, solo therapist to train this how the patient can be soloed, and speech therapy, they should be initiated. Thank you for the patient listening, and I request all of you, 29th October is Dr. Sandhya is the incoming secretary, and the stroke day is commemorated to make the awareness. You should have to empower the people of the country to identify the stroke. Face, arm, speech, fast, time. This is a slogan now, and the World Stroke Organization has again brought back, the time is precious. So we have to act immediately. The patient should be able to recognize themselves. Many a time you have to empower, patients will not recognize that. So you empower the patient to identify the stroke hospital for a better care or the acute stroke management. For the patient listening, thank you chairpersons and thank you organizers and especially Dr. Venu and the CGP team for inviting me for this lecture. Any questions I can take up. Thank you. Jai Hind.
Thank you, Dr. Pradeep Kumar. That was a wonderful presentation. You have extensively explained it in time, and the topic is open for discussion. Any questions from the listeners? Sir, I have a question.
Yeah.
What do you think about endovascular treatment in basilar stroke?
The basilar stroke, the endovascular treatment is if there is a basilar occlusion, definitely if the facility is available and their expert hand should be there. That is the most important. Somebody who should be able to do that should be there. Now the resources are, now we have facility. Many corporate hospital, even government sector. Tamil Nadu government has, in the government medical, 12 cath labs, biplanar cath lab have been ordered by Tamil Nadu government 3 months before. They have come now, but they don't have resources, human resources to do that. So now, because in cardiology, angiogram is done by the residents. Neurology, that part is not there. Now it is coming up now, but definitely in a basilar occlusion, treatment of choice will be endovascular first.
How the results are?
Pardon?
How the results are?
Results are very gratifying actually, very gratifying. IV thrombolysis will not have. These patients will gradually slip off because if a massive pontine infarct, they will become comatose soon.
Sir, what is your opinion regarding extended windows for thrombolysis?
The extended windows can be taken, that is what I am mentioning. You should have a CT perfusion is the ideal thing, right? CT perfusion or MR perfusion. The perfusion will differently, clearly show how much this area has been damaged or infarcted and how much area we can salvage. If the core central infarcted area is minimal, penumbra is large, definitely you can take up for IV thrombolysis. Not for IV thrombolysis, for mechanical thrombectomy. IV thrombolysis extended window period studies are going on, but recommendation is not there. When individual selected with between 4.5 to 9 hours there is a study, and again 9 to 16 hours there is a study going on now. 4.0 to 9 hours study has a small number only, but they have based on CT perfusion. They found that there is a better result. But CT perfusion is not available in our setup. Many people we don't have, and even the radiologists are not well trained, tuned to have this CT perfusion. Only in selected center where a higher end CT is available, you can do that. But if the CT perfusion is available, if you can demonstrate that the infarcted core area is small, penumbra is large, you can give IV thrombolysis. You are justified in giving an individual based, not on a generalized basis.
Many of our hospitals don't have CT perfusion, so how can it be useful? Because there was
in that case, you can do MRI, diffusion flare mismatch. Diffusion will definitely show an infarcted area. Flare will show only, when the flare is abnormal, that means infarct has settled down. There is an edema around the flare, is a fluid attenuated inversion recovery sequence. So that clearly shows that there is an edema. That means infarct has already formed. So diffusion shows changes, flare doesn't show any change. You can take up this patient for IV thrombolysis, but document all these things in your case sheet, that why you are taking up this patient, explain the benefit and risk to the patient.
Any more questions from audience? Okay, thank you, Dr. Pradeep Kumar.
Thank you, Pradeep, sir.
Continue the session.
I call upon Pradeep to accept the memento from Ima Kozhikode. I call upon Dr. Sabina to hand over the memento to Dr. Pradeep Kumar VG. Thank you, sir. Thank you, madam. I now call upon Dr. Sandhya Kurp, WDW leader, incoming secretary of Ima Kozhikode, to hand over the mementos to the chairpersons. Dr. Priya, and Dr. Shihabuddin P. Thank you, madam. Thank you, Chair. This session is over. We'll have a short tea break, 10 minutes. Kindly come back, everybody come back to the hall in 7 minutes time. Thank you. Tea is served outside the hall.
Check. Hello.
Hello. Check. Hello. hello, check.
postgraduate students who will be participating in the quiz is requested to contact Dr. Mohana Krishnan, so will be available in the office. All the students who are participating in the quiz, please contact Dr. Mohana Krishnan, so will be available in the office. The poster presentation will be after the oration. All please note, the poster presentation will be after the oration. We will move to the inaugural function. I call upon the President of IMA Kerala State Branch, Dr. Samil Koshi, over to the dais. I request Dr. B. Velugopalan, President IMA Kozhikode, to accompany him. I request Dr. Babu Ravindran sir, past National IMA Vice President, to come over to the dais. I request Dr. Benny PV, Director of CGP, to accompany him to the dais. I request Dr. Joseph Benavin, Secretary IMA Kozhikode, IMA Kerala State Branch, over to the dais. And to accompany him, Dr. Manoj Kumar KT, Secretary, CGP IMA Kerala State Branch. I call upon Dr. M. Bhaskaran, Personal National Vice President, over to the dais. To accompany him, Dr. Sabina H. I call upon Dr. Moidu K. over to the dais. To accompany him, Dr. Shamsuddin. I request Dr. Surendra Babu, North Zone Vice President, to come over to the dais. I call upon Dr. Narayanan M., North Zone Joint Secretary, IMA Kerala State Branch, over to the dais. I call upon Dr. Pradeep Kumar VG, Past President, IMA Kerala State Branch, over to the dais. I call upon Dr. Ajita P.N., State Chairperson, MPH, over to the dais. I call upon Dr. Shaji C.K., Chairman, District Committee, over to the dais. I call upon Dr. Aneen Kuti, sir, to come over to the dais. Ladies and gentlemen, the round of applause given is rather inadequate. Please, a huge round of applause for the IMA leaders. Thank you very much. Everybody please stand for the prayer. I request Dr. Joseph Benavan, Secretary, IMA Kerala State Branch, to adorn the Presidential Medal to the President. Thank you. Keep standing for the flag salutation by Dr. Manoj Kumar KT, Secretary, CGP, IMA Kerala State Branch.
We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its cause shall be our cause. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Thank you. All be seated, please. Next, we have the welcome address by Dr. Shamsuddin, Organizing Chairman, IMA CGP Conum.
Thank you, sir. Respected dignitaries on the dais, my favorite teachers, my responsibility is to welcome you all to today's program. And as per the protocol, I welcome Dr. Benny P.V., Director of Studies, IMA CGP, Kerala State Branch, and Dr. Samuel Koshi, President of IMA Kerala State Branch, and today's chief guest, Dr. Babu Ravindran, past National Vice President of IMA, and Dr. Joseph Bevan, the State IMA Kerala State Branch Secretary, Dr. Manoj Kumar KT, Secretary, IMA CGP Kerala State Branch, and Dr. Bhaskaran, IMA past President, National Vice President, Dr. Narayanan M., Joint Secretary, IMA Kerala State Branch, Dr. K. Moidu, past President of IMA Kozhikode, Dr. Surendra Babu, VP, IMA Kerala State Branch. Thank you so much. Then Dr. Pradeep Kumar VG, past President of IMA Kerala State Branch. Dr. Ajita P.N., State Chairperson, MPH. Dr. Aneen Kuti, Convener, District Committee. Dr. Venugopalan B., President, IMA Kozhikode State Branch. And Dr. Sabina, Organizing Secretary of IMA Kerala State Branch. Apart from this, My faculty, my teacher, my mentor, P.K. Session sir is on the audience. I welcome you, sir, for the oration. And other senior faculties whom I know, but I don't remember their names, and colleagues, I welcome you all for today's program. Thank you.
Thank you, sir. Next, we have the report of activities by Dr. Manoj Kumar KT, Secretary, CGP IMA, Kerala State Branch.
Respected State President, IMA Kerala State Branch, Dr. Samuel Kochi sir, Secretary, Dr. Joseph Benavenji, Babu Ravindran sir, Surendra Babu sir, Narayan sir, Bhaskaran sir, VGP, Ajita madam, and all other dignitaries on the dais, and very senior members and professors like stalwarts like PKs, senior members of IMA, and my dear friends. Very happy that I could stand before you on this prestigious occasion of annual conference of IMA Cgp Kerala State Branch. IMA Cgp, as you all know, is exclusively an academic body of National IMA, which mainly focuses on the updation of knowledge, medical knowledge for the rural physicians and family physicians of India. Considering that, and in view of that, IMA Cgp Kerala State Branch has conducted 12 CMEs online for these rurally practicing family physicians to update their medical knowledge for the last 6-7 months. Along with that, we successfully conducted 2 zonal conferences, one at Trivandrum being hosted by Kadakottam branch, and the other at Mid-Zone, hosted by Mulangundathu Kavu branch at Thrissur. All were very good in the area of speakers and audience aspects. It was successful conferences. And finally, today we have annual conference of CGP being hosted by IMA Kozhikode branch. Thank you all team IMA for organizing this and hosting this. I'm not going to elaborate the activities because this is a really concise activity report. Along with this, I think being a CGP faculty, I think I should say something more. CGP എന്ന് പറയുന്ന ഒരു ഏരിയ ഒരു 2 മിനിറ്റ് ഞാൻ എക്സ്ട്രാ എടുക്കുന്നുണ്ട് വിത്ത് ദ പെർമിഷൻ ഓഫ് പ്രസിഡന്റ് ആൻഡ് സെക്രട്ടറി. CGP എന്ന് പറയുന്ന നാഷണൽ ബോഡി, IMAയുടെ ബോഡി നമ്മൾ കോൺസ്റ്റിറ്റ്യൂട്ട് ചെയ്തിരിക്കുന്നത് യഥാർത്ഥത്തിൽ ഫാമിലി ഫിസിഷ്യൻസിൻ്റെ അപ്ഗ്രഡേഷന് വേണ്ടിയിട്ട്, അല്ലെങ്കിൽ അവരുടെ ഒരു ബേസ് നമ്മൾക്ക് ഇന്ത്യയിൽ ഉണ്ടാക്കുന്നതിന് വേണ്ടിയിട്ടാണ്. അത് എത്രത്തോളം സക്സസ്ഫുള്ളായി എന്നറിയില്ല. എങ്കിൽ പോലും നമ്മൾ കാണുന്ന ഇന്ത്യയല്ല യഥാർത്ഥത്തിലുള്ള ഇന്ത്യ. നമ്മൾ കാണുന്ന കേരളം ഒരിക്കലും ഇന്ത്യയുടെ ക്രോസ് സെക്ഷൻ അല്ല എന്നുള്ളതാണ് സത്യം. ഇന്ന് കേരളത്തിൻ്റെ ഗ്രാമങ്ങളിൽ 10, 20, 25 ഡോക്ടേഴ്സ് പ്രാക്ടീസ് ചെയ്യുന്നുണ്ടാവും. ഈവൻ പ്രാക്ടീസ് ചെയ്യാൻ ഏരിയ പോലും ഇല്ലാത്ത സ്ഥലങ്ങളുമുണ്ട്. പക്ഷേ നോർത്ത് ഇന്ത്യയിൽ സിനാരിയോ ഈസ് ടോട്ടലി ഡിഫറെൻറ്റ്. അവിടെ ഒരു ഡോക്ടറെ കാണണമെന്നുണ്ടെങ്കിൽ മേ ബി 100 kilometers ദേ ഹാവ് ടു ട്രാവൽ. അവിടെ സഫർ ചെയ്യുന്ന ഒരുപാട് ഏരിയ ഉണ്ട്. ആ ഏരിയയിലേക്ക് ക്വാക്സിനെ തടയുന്നതിന് വേണ്ടിയിട്ട് പോലും നമുക്ക് നമ്മുടെ ഈ ഒരു ഏരിയയെ ശക്തിപ്പെടുത്തേണ്ടതുണ്ട് എന്നാണ് എനിക്ക് തോന്നുന്നത്. ഈവൻ നമുക്കറിയാം, സെൻട്രൽ ഗവൺമെൻറ് കഴിഞ്ഞ കുറച്ച് വർഷങ്ങളായിട്ട് നമ്മുടെയൊക്കെ സ്റ്റേറ്റ് ലീഡേഴ്സ് ഒരുപാട് സ്ട്രഗിൾ ചെയ്ത് നമ്മൾ സമരം ചെയ്ത് നേടിയെടുത്ത് തൽക്കാലത്തേക്ക് ഫോർ ദി ടൈം ബീങ് നമ്മൾ സ്റ്റോപ്പ് ചെയ്ത ഒരു പാരലൽ, ഒരു BRMS പോലത്തെ ബ്രിഡ്ജ് കോഴ്സുകൾ ഇപ്പോഴും സ്റ്റിൽ ഇറ്റ്സ് ഷെൽവ്ഡ്. അത് അവരുടെ കയ്യിലുണ്ട്. ശരിക്കും പറഞ്ഞാൽ സെൻട്രൽ മിനിസ്ട്രിയുടെ കയ്യിലുണ്ട്. ഏത് നിമിഷവും BRMS പോലുള്ള കോഴ്സുകൾ ഇവിടെ അവതരിപ്പിക്കപ്പെടും, യാതൊരു സംശയവുമില്ല. ഇപ്പോൾ നമ്മളുടെ ഒരു പ്രൊട്ടസ്റ്റിൽ അത് തൽക്കാലം ഷെൽഫ് ചെയ്ത് വെച്ചിരിക്കുന്നു എന്ന് മാത്രമേ ഉള്ളൂ. എങ്ങനെ നമ്മൾ ഇതിനെ തടയണം, അവിടെയാണ് CGPയുടെ പ്രസക്തി എന്നാണ്, നാഷണൽ CGPയുടെ പ്രസക്തി എന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. കാരണം ക്വാക്കുകൾ ഭരിക്കുന്ന ഒരു ഇന്ത്യയല്ല നമുക്ക് വേണ്ടത്. നമുക്ക് റിയൽ ജെന്യുവൻ ആയിട്ടുള്ള മോഡേൺ മെഡിസിൻ പ്രാക്ടീസ് ചെയ്യുന്ന ഡോക്ടേഴ്സ് നമ്മുടെ ഇന്ത്യയുടെ ഗ്രാമങ്ങളിൽ ഉണ്ടാവണം. അവിടെയുള്ള ആളുകൾക്ക് കൃത്യമായ സേവനം നൽകുന്നതിന് വേണ്ടി ഫാമിലി മെഡിസിൻ്റെ ഒരു ബാക്ക് ബോൺ നമ്മൾ ഉണ്ടാക്കിയെടുക്കേണ്ടിയിരിക്കുന്നു. അതിൻ്റെ മുകളിൽ നമുക്ക് സ്പെഷ്യാലിറ്റിയും സൂപ്പർ സ്പെഷ്യാലിറ്റിയും അങ്ങനെയുള്ള എല്ലാ ഏരിയയും നമുക്ക് വേണം. ബട്ട് വിത്തൗട്ട് ഫാമിലി മെഡിസിൻ ഇറ്റ് ഈസ് നത്തിങ് എന്നാണ് എനിക്ക് കൃത്യമായിട്ട് ഞാനും കുറച്ച് 10-20 വർഷമായിട്ട് റൂറൽ ഏരിയയിലും ആ റൂറൽ ഏരിയ പിന്നീട് അത് നഗരമായി മാറുന്നു. ഇപ്പോൾ കേരളത്തിൽ ഗ്രാമങ്ങളില്ല, നഗരങ്ങൾ മാത്രമേ ഉള്ളൂ. അതുകൊണ്ട് ഗ്രാമത്തിൽ പോയി പ്രാക്ടീസ് തുടങ്ങിയ അവസാനം അത് നഗരമായി വളരുന്നതും കണ്ട ഒരാളെന്ന നിലയ്ക്ക് പറയുന്നതാണ്. തീർച്ചയായിട്ടും CGPക്ക് റോളുണ്ട്, നാഷണൽ IMAക്ക് റോളുണ്ട്. നമ്മുടെ നാഷണൽ ലെവലിൽ തന്നെ സെൻട്രൽ ഗവൺമെൻറ്റിൻ്റെ മുന്നിൽ ഒരു പ്രൊജക്റ്റ് അവതരിപ്പിച്ചുകൊണ്ട് നമ്മുടെ ക്വാളിഫയിങ് ഡോക്ടേഴ്സ് ഒരു 90,000-ലധികം ഡോക്ടേഴ്സ് ഓരോ വർഷവും ഇന്ത്യയിൽ പുറത്തിറങ്ങുന്നുണ്ട്. പുറത്തുനിന്ന് വരുന്ന മോർ ദാൻ 30,000-ലധികം 1 ലാഖിലധികം ഡോക്ടേഴ്സ് നമ്മൾക്ക് ഇന്ത്യയിൽ വരുമ്പോഴും എന്തുകൊണ്ട് ഗ്രാമങ്ങളിൽ പ്രാക്ടീസ് ചെയ്യാൻ ഡോക്ടർമാരില്ല എന്നുള്ളതിനെക്കുറിച്ച് സ്റ്റഡി നടത്തുകയും അതിന് വേണ്ടിയിട്ടുള്ള സയൻറ്റിഫിക് ആയിട്ടുള്ള ഒരു ഡിസിഷൻ മേക്കിങ്ങിന് വേണ്ടിയിട്ട് നമ്മുടെ ലീഡേഴ്സ് അതിന് മുന്നിട്ടിറങ്ങുമെന്ന് തന്നെ ഞാൻ വിശ്വസിക്കുന്നു. അത്തരത്തിലുള്ള കാലത്തിന് വേണ്ടിയിട്ട് എല്ലാ സ്പെഷ്യലിസ്റ്റുകളെയും എല്ലാ സൂപ്പർ സ്പെഷ്യലിസ്റ്റുകളെയും അതിൻ്റെ ആവശ്യകതയെ കൃത്യമായി അറിഞ്ഞുകൊണ്ട് തന്നെ ഒരു ബാക്ക് ബോൺ നമുക്കുണ്ടാവേണ്ടതിൻ്റെ ആവശ്യകതയെ ഓർമ്മിപ്പിച്ചുകൊണ്ട് എല്ലാവർക്കും നന്ദി, നമസ്കാരം.
Next we have the presidential address by Dr. Benny PV, Director Studies, Kerala State Branch.
Respected State President, State Secretary, President of IMA Kozhikode Branch, Organizing Chairman and Secretary, very senior leaders of IMA sitting in the dais and off the dais, dear IMA and CGP members. യഥാർത്ഥത്തിൽ CGPയുടെ ആക്ടിവിറ്റീസ് കഴിഞ്ഞ ഒരു വർഷക്കാലം നോക്കുകയായിരുന്നെങ്കിൽ ഓൺലൈൻ മോഡിൽ നിന്ന് തുടങ്ങി ഇന്ന് ഓഫ്ലൈൻ കാലഘട്ടത്തിലോട്ട് മാറി. നമ്മൾ ഇനിഷ്യൽ കാലഘട്ടത്തിൽ ഏറ്റവും കൂടുതൽ വീക്കിലി അപ്ഡേറ്റ് കൊടുക്കുവാൻ വേണ്ടി ശ്രമിച്ചു. പ്രത്യേകിച്ചും ഓൺലൈൻ ആയ സാഹചര്യത്തിൽ എല്ലാ ആഴ്ചയിലും CGP മെമ്പേഴ്സിനും അതേ കണക്ക് തന്നെ ജനറൽ പ്രാക്ടീഷണേഴ്സിനെയും ഓറിയൻറ്റ് ചെയ്തിട്ടുള്ള കോമൺ ടോപ്പിക്കുകൾ എന്ന് പറയുന്നത് നമ്മൾ ഏറ്റവും കൂടുതൽ ഡെയിലി നമ്മളുടെ OPDയിൽ കാണുന്ന ടോപ്പിക്കുകളുടെ ഏറ്റവും റീസെൻ്റായിട്ടുള്ള അപ്ഡേറ്റഡ് വേർഷൻ കൊടുക്കുക എന്നുള്ളതായിരുന്നു CGPയുടെ ആദ്യ ആക്ടിവിറ്റി. ഇപ്പോഴും അത് കണ്ടിന്യൂ ചെയ്തുകൊണ്ടിരിക്കുന്ന, ഇൻക്ലൂഡിങ് ചില ഔട്ട്ബ്രേക്ക് മങ്കി പോക്സ് വന്നപ്പോൾ മങ്കി പോക്സിൻ്റെ അപ്ഡേറ്റ് അപ്പോൾ തന്നെ നമ്മൾ കൊടുക്കുകയുണ്ടായി. അതിനോടൊപ്പം തന്നെ കോൺഫറൻസുകൾ, ഓരോ സോണിലും കോൺഫറൻസുകൾ നടത്തുന്നതിൻ്റെ ഉദ്ദേശം, ഇപ്പം സൗത്ത് സോണിൽ കോൺഫറൻസ് കഴക്കൂട്ടം ബ്രാഞ്ച് ഹോസ്റ്റ് ചെയ്തെങ്കിലും ആ കോൺഫറൻസിൽ എല്ലാ ടോപ്പിക്കുകളും സെലക്ട് ചെയ്തേക്കുന്നത് ഏറ്റവും ഉചിതമായിട്ടുള്ള ടോപ്പിക്കുകളാണ്. അന്ന് അവിടെ എത്തിയ എല്ലാവർക്കും വളരെ അപ്രീഷിയേറ്റ് ചെയ്യാൻ പറ്റപ്പെട്ട ടോപ്പിക്കുകളായിരുന്നു. അത് കോമൺ ടോപ്പിക്കുകൾ എന്തുകൊണ്ട് സെലക്ട് ചെയ്യുന്നതെന്ന് പറയുന്നത് പലപ്പോഴും നമ്മൾ നെഗ്ലക്റ്റ് ചെയ്യുന്ന, നമുക്ക് അറിയാം ഇനി വേണ്ട എന്ന് പറഞ്ഞ് നമ്മൾ അപ്ഡേറ്റ് ചെയ്യാത്ത ചില കാര്യങ്ങളുണ്ട്. അത് അപ്ഡേറ്റ് ചെയ്യപ്പെടുക. ഇനി വരും കാലഘട്ടമെന്ന് പറയുന്നത് വളരെ ക്രൂഷ്യലായിട്ടുള്ള കാലഘട്ടമാണ്. ഇനി പാരാമെഡിക് എന്ന് പറയുന്നൊരു സംഭവം ഉണ്ടാവത്തില്ല. ഇപ്പോൾ ഒരു MLT കാരണം സ്വന്തമായിട്ട് പ്രാക്ടീസ് ചെയ്യുന്നൊരു സിറ്റുവേഷനിൽ പോവുകയാണ്. നമ്മളിപ്പം ഒരു MBBS കഴിഞ്ഞ, ഞാനൊരു പ്രൊഫസർ ആൻഡ് HOD ഒരു മെഡിക്കൽ കോളേജാണ്. അത് കഴിഞ്ഞിട്ട് ഒരു MBBS ഹൗസ് നഴ്സിംഗ് കഴിഞ്ഞിട്ട് ഒരു ഡോക്ടറിൻ്റെ അടുത്ത് ചോദിക്കും, നിനക്ക് ഇൻഡിപെൻഡൻ്റായിട്ട് പ്രാക്ടീസ് ചെയ്യാൻ പറ്റുമോ നാളെ തൊട്ട്? സാറേ അത് പാടാണ്. അതേസമയം ഒരു നാച്ചുറോപ്പതി ചോദിച്ചു നോക്കണം, അവൻ കൃത്യമായിട്ട് പറയും നാളെ തൊട്ട് പ്രാക്ടീസ് ചെയ്തിരിക്കും. ഒരു ഡിഗ്രി ഇല്ലാത്ത വ്യാജന്മാരുടെ അടുത്ത് ചോദിച്ചു നോക്കണം, അവന്മാർക്ക് ഒരു സംശയവും ഇല്ലാതെ പ്രാക്ടീസ് ചെയ്യും. അപ്പം നമ്മൾ ഈ പറയുന്ന MBBS കഴിഞ്ഞ് വരുന്ന ഡോക്ടർ ഒരു കോൺഫിഡൻസും ഇല്ലാത്തൊരു സ്റ്റേറ്റിലോട്ടാണ് നമ്മളുടെ ഈ കാലഘട്ടത്തിലെ പ്രാക്ടീസ് കടന്നു പോയിക്കൊണ്ടിരിക്കുന്നത്. ഫിസിയോതെറാപ്പിക്കാരന് ഇൻഡിപെൻഡൻറ്റ് പ്രാക്ടീസായി മാറിക്കഴിഞ്ഞു. ഡയറ്റീഷ്യൻസ് എല്ലാം ഇന്ന് ഇൻഡിപെൻഡൻറ്റ് പ്രാക്ടീഷണേഴ്സാണ്. ഏതൊരു മേഖലയിൽ നോക്കിക്കഴിഞ്ഞാലും ഇന്ന് ഏറ്റവും കൂടുതൽ MBBSക്കാരെ കാട്ടി അക്സെപ്റ്റ് ചെയ്യുന്നത്, ഇൻക്ലൂഡിങ് നമ്മളുടെ പ്രൊഫഷണൽ ഉള്ള ആൾക്കാർ അക്സെപ്റ്റ് ചെയ്യുന്നത് ഇവരെയൊക്കെയാണ്. നമ്മളുടെ ഒരു CMEക്ക് വിളിച്ചു കഴിഞ്ഞാൽ ഏറ്റവും കൂടുതൽ ഡയറ്റീഷ്യനായിരിക്കും ടോപ്പിക് ഇട്ടേക്കുന്നത്. തെറാപ്പിസ്റ്റിനും ഉണ്ടാവും ടോപ്പിക്ക്. പറ്റുമെന്നുണ്ടെങ്കിൽ നാച്ചുറോപ്പതിക്കാരനെ കൂടെ കയറ്റും. ഇങ്ങനെയുള്ള വ്യത്യസ്തമായ നമ്മളെ ആൾക്കാർ തന്നെയാണ് പല സ്ഥലങ്ങളിലും ഈ ടോപ്പിക്കുകൾ സെലക്ട് ചെയ്യുന്നതും ഇവരെ എല്ലാം കൊണ്ട് CMEയിൽ സംസാരിപ്പിക്കുന്നത്. അപ്പോൾ ആ ഒരു കാലഘട്ടത്തിൽ നിന്ന് നമ്മൾ മാറി ചിന്തിച്ചില്ല എന്നുണ്ടെങ്കിൽ അടുത്ത കാലഘട്ടത്തിൽ പാരാമെഡിക് എന്ന് പറയുന്ന ഒരു സാധനം ഇല്ല. എന്താണ്? കോമെഡിക്സുകളേ ഉള്ളൂ. അതൊരു കോമഡി സിറ്റുവേഷനിലോട്ട് പോവുകയും ചെയ്യും. അതുകൊണ്ട് തന്നെ MBBSകാരുടെ ഡിഗ്രി ഇന്ന് അക്സെപ്റ്റ് ചെയ്യാൻ താല്പര്യമില്ലാത്ത ഒരു കാലഘട്ടത്തിലോട്ട് ഗവൺമെൻറ്റും അതേ കണക്ക് ജനങ്ങളും മാറിക്കൊണ്ടിരിക്കുകയാണ്. ഇവിടെയാണ് നമ്മളുടെ MBBS ആൾക്കാരെ ഉദ്ധരിച്ച് അവരെ സയൻറ്റിഫിക്കലി ഉയർത്തിക്കൊണ്ട് ചെറിയ ചെറിയ ട്രെയിനിങ് പ്രോഗ്രാമുകൾ ലൈക്ക് പല ങ്ങളിലും കണ്ടക്ട് ചെയ്യുന്നുണ്ട്, ഇൻക്ലൂഡിങ് സെക്ഷൽ മെഡിസിനിൽ, അത് കണക്ക് ഡയബറ്റോളജിയിൽ. ഇതെല്ലാം CGP വഴി തന്നെയാണ് ഈ ഡിഗ്രികൾ കോർഡിനേറ്റ് ചെയ്യുന്നത്. പക്ഷേ ഇതെല്ലാം കോർഡിനേറ്റ് ചെയ്തുകൊണ്ടിരിക്കുന്ന ഒരു സാഹചര്യത്തിലാണ് NMCയുടെ ഇപ്പം ശക്തമായിട്ടുള്ള ഒരു ഇടപെടൽ വരികയും ഒരു അലൈഡ് ഡിഗ്രികളും അവൻ്റെ ബാക്കിൽ വെക്കാൻ പാടില്ല. പക്ഷേ ഒരു നാച്ചുറോപ്പതിക്കാരന് എന്തും വേണമെങ്കിലും വെക്കാം. പക്ഷേ MBBSകാരന് ഒരു സാധനം പോലും വെക്കാൻ പാടില്ല. അങ്ങനെ ഒരു സിറ്റുവേഷൻ വന്നപ്പോഴത്തേക്ക് പല കോഴ്സുകളും അക്സെപ്റ്റ് ചെയ്യാതെ പോയി. നമ്മൾ ഇനി വരുന്ന സൗത്ത് സോൺ നാഷണൽ കോൺഫറൻസ് 24-25 തൃശ്ശൂർ ബ്രാഞ്ച് ഓർഗനൈസ് ചെയ്യുന്ന സൗത്ത് സോൺ കോൺഫറൻസിൽ ഓണറി എടുക്കാൻ വേണ്ടി നമ്മൾ ഇൻവിറ്റേഷൻ അയച്ചിട്ട് അതിൽ ആർക്കും അക്സെപ്റ്റൻസ് ഇല്ല. FCGP ഇപ്പം താല്പര്യമില്ലാത്തൊരു കാലഘട്ടത്തിലോട്ട് പോയിക്കൊണ്ടിരിക്കുകയാണ്. അപ്പം ഈ ഒരു കോൺസെപ്റ്റ് നമ്മൾ ചേഞ്ച് ചെയ്ത് അറ്റ്ലീസ്റ്റ് മോഡേൺ മെഡിസിൻ നൽകുന്ന ഒരു ഫെലോഷിപ്പിനോ ഒരു സർട്ടിഫിക്കറ്റിനോ ഒരു വില ഉണ്ടാകുന്ന ഒരു സാഹചര്യം കൂടി വന്നു കഴിഞ്ഞാൽ മാത്രമേ നമ്മളുടെ MBBS ഡിഗ്രി എടുത്ത് അവരെ കുറച്ചുകൂടി ഉയർത്തിക്കൊണ്ടുവരാനുള്ള സാഹചര്യവും കോഴ്സുകളും നമുക്ക് ഓർഗനൈസ് ചെയ്യാൻ പറ്റും. ഈ സ്റ്റേറ്റ് കോൺഫറൻസ് കാലിക്കറ്റ് ബ്രാഞ്ച്, എനിക്ക് വന്ന് കോഴിക്കോട് ബ്രാഞ്ചിൽ നമ്മുടെ പ്രസിഡൻറ്റ് വേണു സാറ് എപ്പോഴും നിരന്തരം ചെയ്തുകൊണ്ടിരുന്ന ഈ സ്റ്റേറ്റ് കോൺഫറൻസ് ഇവിടെ തന്നെ കിട്ടണമെന്നും അതേ കണക്ക് തന്നെ അങ്ങനെയുള്ള ഈ ആഗ്രഹത്തോടു കൂടി ഒരു സ്റ്റേറ്റ് കോൺഫറൻസ് നടത്തുക എന്ന് പറയുന്നത്, അടിച്ചേൽപ്പിച്ച് നടത്തുന്നതും ആഗ്രഹത്തോട് നടത്തുന്നതും തമ്മിൽ രണ്ടും രണ്ടാണ്. അതുകൊണ്ട് തന്നെയാണ് ഈ ടോപ്പിക്കുകൾ ഇന്നിവിടെ സെലക്ട് ചെയ്തേക്കുന്ന ടോപ്പിക്കുകളായാലും അതേ കണക്ക് ഇൻവൈറ്റ് ചെയ്തേക്കുന്ന മെമ്പേഴ്സായാലും തന്നെ വളരെ ഉചിതമായിട്ടുള്ള ഒരു മെമ്പേഴ്സും ടോപ്പിക്കുകളാണ്. ഇതിനെല്ലാത്തിനും ആശംസകളും കൂടി പറഞ്ഞുകൊണ്ട് എൻ്റെ സംസാരം നിർത്തുന്നു. താങ്ക് യു.
Thank you very much, sir. Next we have the formal inauguration of the program by Dr. Samuel Koshi, President IMA Kerala State Branch.
Chair Dr. Benny, State Secretary Dr. Joseph Benavan, Babu sir, Bhaskaran sir, National Vice President Dr. Surendra Babu, Secretary Dr. Narayanan, Dr. Manoj, the senior colleagues, dear friends. Kozhikode branch is doing it again. Last week we have the State Conference of Women Doctors Wing. This week we are having the State Conference of College of General Practitioners. Kozhikode branch under the leadership of Dr. Venu is doing a wonderful job, and I congratulate the Kozhikode branch for doing such a wonderful job throughout the year. At the same time, let me congratulate the CGP office bearers, Dr. Benny, Dr. Manoj and the team for having conducted a series of CMEs throughout the year. They have conducted the zonal meetings of CGP in all the 3 zones. Now we are having the state conference of CGP. As is being already pointed out, the concept of medicine is changing in our country. This is an era of specialization and super specialization. Number of doctors coming out from various medical colleges, from inside the state, outside the state and outside the country, the number is increasing. And now it's supposed that more than 95,000 MBBS graduates are coming out from various medical colleges inside the country itself. So the number of MBBS seats has increased, and now the government is giving priority to increase proportionately the number of PGCs, postgraduate seats also. The problem now here is that, as is already pointed out by Dr. Benny, quackery is being legalized nowadays. What we considered as quackery maybe 5 years or 10 years back are no more quackeries in Kerala or India now. All these quackeries are being considered under the umbrella of mixopathy, and the mixopathy is getting promoted throughout the country. So it is our responsibility to see that the concept of family medicine is getting promoted. The pioneers like Professor Shashidaran sir and others, since many years are saying that this concept has to be promoted and otherwise it is going to be very difficult for our MBBS graduates to continue their work in our country. So it is the time for a change. We have to go back and promote the concept of family medicine, and otherwise, as is being already pointed out rightly by Dr. Benny, the days are not far when the MBBS graduates will not be considered even equivalent to a paramedic. So this concept has to be changed, but it's a very difficult, it's not an easy job, because every graduate after graduating or getting an MBBS degree wants to go for a specialization or super specialization. Because there is no place for an MBBS graduate in Kerala especially. So that thing has to be considered, and I think the CGP has to take the initiative for a change nowadays, because it is a academic wing of IMA, the CGP, who has to promote the concept of family medicine as well as general practice. So that's what I have to say about those things. And again, as far as Kerala State IMA is concerned, we are doing everything possible to strengthen the association as well as to address the various crucial and difficult issues faced by the medical fraternity. The strength of IMA has been increased throughout the year. We have gone to all the 108 branches of IMA to address the members and to tell about the difficulties being faced by the medical fraternity. At the same time, we have gone to all the 30 medical colleges in Kerala. Again, we have conducted 13 district conferences to address the public as well as to address the opinion makers and politicians. We have increased the membership of Kerala State IMA by around 5,000 this year itself, which has not happened in any of the previous years. So we are trying to strengthen the association, because only the voice of a strong association will be heard at the corridors of power. So we want to strengthen the association. At the same time, we are trying to address the major issues being faced by the medical fraternity. We are trying to address the issue of violence against hospitals and doctors. We are trying to address the issue of new laws being introduced, like the Clinical Establishment Act. The most difficult situation faced by the new Consumer Protection Act is being challenged by Kerala State IMA in Supreme Court. So various issues are being addressed to the extent possible by the state IMA. I don't want to tell more about all those things because this is an audience for the academic feast. So we are waiting for the faculties to address you. I know this CGP has been organized in a wonderful way by getting the best faculties as well as the current topics, and you are all eagerly waiting for that. With these few words, let me conclude, and before concluding, let me declare that this annual conference of College of General Practitioners is being inaugurated. Thank you. Jai IMA, Jai Hind.
Thank you, sir. Next, we have the address by the chief guest, Dr. Babu Ravindran. He's the past National Vice President.
Yeah, respected President Dr. Samuel Koshi, Dr. Benny, Dr. Benavan, Dr. Bhaskaran, Dr. Vijay Pradeep Kumar, Dr. Surendra Babu, dignitaries on the dais, respected teachers, senior members of the profession, and my dear friends. Before I talk anything, I would like to remember with gratitude the service rendered by our departed soul, Dr. Vijayan. And I pay homage to him. In the morning, we just went there and paid respect to him. Slowly, we are losing those generation of senior doctors. Whenever we visit Calicut, we used to see those people sitting in the front row. Now, one by one, we are losing. And definitely, it is a loss to the profession and to the Calicut branch in particular. Friends, I congratulate the Calicut branch for taking up the initiative of organizing this state conference of CGP in a very good manner, choosing very relevant topics with very, very senior academicians as speakers. And at the state level, Dr. Benny and Manoj have been doing a very good job, taking the CGP to further heights. I think they have spread the message to all the branches, and almost about 60% of the branches I see, they have got branches of CGP. They are conducting the monthly, regular CME programs. Friends, now, as the apprehension raised by Dr. Benny and our state president, now this is the era of specialization. And we are all becoming specialist and super specialist. And the patient care we are slowly tending to lose the concept of patient care and all those things. So the relevance of CGP, the relevance of family medicine propagated by Dr. Shashi and all for the last so many years, it is more nowadays. Now the half-life of medical knowledge has come down to 1 year or 1.5 years, because if you are not updating it regularly within 1 or 2 years, your knowledge will become 50%, and if you are not updating it for 3 or 4 years, the knowledge will become absolutely zero, and you will be worthless as a practitioner. So the service done by the CGP and AMS is yeoman. But I am extremely sorry to see that the members are not taking it very seriously. Because a branch were the 2,000 members, Calicut, we expect something, more attendance, the members. We expect at least 200 or 300 people, but it's barely 60 or 70. When your total strength is 2,000, it is a poor response from the members. You have to find out the reason for that. It is not for the CME meetings and all. Even for the general body meeting we see in Calicut also, about 50 to 60 people are attending the general body meetings. So what is the purpose of this organization discussing so many things at state level, branch level, district level and all? And if that message is not properly passed to the members, and members are not knowing these programs organized by the association and all, for whom we are functioning like that. So the branch should see that some way you have to motivate members to participate in the branches, so that whatever we discuss in this central working committee or in the state working committee, very, very important matters are being discussed there. So that has to reach the members. If they don't attend the general body meetings, it will not be reaching, and all these attempts by the state and center will be futile. So whatever it may be, I wish more and more people will be joining this thing. One important problem, especially the concern raised by Dr. Benny, that the relevance of MBBS or a general practitioners is losing, is a fact. Now we have to empower the MBBS. The MBBS doctors should be feel proud, and they should be knowledgeable, and they have to be confident. Now they are not confident, they are not feeling proud, they merely think that I am a Sada MBBS. So that concept has to change. Anyone coming out of the MBBS, he should be a proud medical practitioner. MBBS, the quality, the quantity, the confidence, and they have to empower, and they should be able to do. Because our forefathers, senior people, they have been doing, even an MBBS people, a doctor used to do cardiac surgery, neurosurgery, all those things, wonderfully well, accepted by the society. But now what happened to ours? So I accept Dr. Shashidharan's message that the family medicine should be propagated. I think for family medicine practitioners, there should not be any different course. That is my objection. An MBBS doctor coming out of the institution should be a proper family physician. The training should be in such a way that when an MBBS doctor is coming out, he is fully prepared. After house agency, he should be made a fully qualified family physician. For becoming a family physician, after MBBS, you had to undergo another 3 courses. What is the relevance of MBBS? So unless the basic degree is established, the profession will lose its credibility, not only among ourselves, but among the public also. I think we are seeing that. So it is our responsibility to see that an MBBS doctor is made more confident, more knowledgeable, and more empowered. And unless they are empowered, the profession will be losing its peace. That is with this purpose that the CGP is doing, because specialists are becoming more of technicians. They are not, because they are concentrating on certain technology, and they will be excelling that. And so they are properly technicians. We cannot call them doctors. If a cardiac surgery, all bypass, they will be only pointing on bypass, and they will be an excellent bypass technician. That's all. So we have to change. They have to be a doctor, a medical man. For that, the knowledge about the entire medical system should be there. I compliment Shashi for that. Kindly go ahead. I think in one day you will succeed. But the CGP is trying to do that by imparting the knowledge from different speciality to all. And it is where the specialist also should come and attend. The super specialist should come and attend. Then only they will know what are the things happening in the other specialities and other knowledge. I compliment the CGP for doing all those things. I compliment the Calicut branch for taking up the initiative of organizing this conference in a good way. And Calicut, whatever conference they have taken, I think they have done a wonderful job. Dr. Pradeep is there, Dr. Moidu is there, senior doctor is there, so Dr. Badran sir is there. And I think so many people are there to guide the organization of Calicut, and you should feel proud of that. And I wish this conference and deliberation all success, and wish CGP will be able to do much more to the profession. Wish you all the best. Thank you.
Thank you very much, sir. Next, we have the address by the State Secretary, Dr. Joseph Benavan.
Dr. Benny PV, Director of Studies, I am CGP, Kerala State, Dr. Samuel Koshi, State President, are the senior leaders on the dais, off the dais, members of IMA, and members of the CGP. Well, much has been said about the relevance of CGP, and I don't want to dwell much on it. As we always say, the CGP focuses purely on doctors who are closest to the patient, who are closest to the community. And that's the relevance of CGP. And when we talk about CGP, CGP needs to have, we need to focus holistically on each and every specialty, on each and every issue that a family physician or a general practitioner would encounter during the course of his practice. And in this regard, I must say, Kerala State CGP IMA has been exemplary, and they've been doing tremendous job under the leadership of Dr. Benny PV and Dr. Manoj. as was said earlier, during the COVID times, they were relentless. We had a series of weekly CME programs which was focused purely on general practitioners and young doctors. So that was a success story, and then when COVID waned away, we moved on to the physical media. We did have 2 very highly successful zonal meetings, and this in fact at Calicut is a mix of both zonal as well as the state conference. And I just would like to contradict Dr. Benny when he said Dr. Venu was asking, very passionately for it, but he did it under a lot of pressure from the state office, because as we always see, Calicut is one branch we can always rely and depend on if we want something done. So they just rose up to the cause and they stood with the state because we wanted, because we had the 2 other meetings in the zones, and then Calicut was the most apt branch to host the state meet. That's why we are here. So I would like to congratulate Calicut branch for hosting this meeting and all of you for being here. So the legacy of medical doctors and legacy of MBBS will surely be carried forward by CGP alone. So we need to realize that, and the sooner we realize and the firm steps we take in this regard will be that's going to protect MBBS graduates, because not all of us can become super specialists or specialists, but there is always a charm in working close to the community, being with the people, because we've seen it during COVID times, because it was always the family physician or the general practitioner who the patient really depended on as the first point of contact. So once again, I hope CGP will go great heights, and I would like to remind you all, on the 24th and 25th, we have the National South Zone CGP Con, which is being hosted by IMA Kerala State Branch through the Trishur branch, and the venue is great, Adlex Convention Center at Koratti near Rangamali, and I'm sure most of you would have visited there for some wedding function or something. I sincerely request all of you be there, make the event a success, because the selection of speakers from across the 6 states, a lot of thought has been gone into organizing this 2-day event. So please be there, and don't forget the dates. It's 24th and 25th of this month, that is next Saturday and Sunday. Thank you.
Thank you, Secretary Sir. Next I call upon Dr. M. Bhaskaran, a very senior IME leader, to address the audience.
Respected State President Dr. Koshi, Dr. Benny, other dignitaries sitting on the dais, my own teachers and my dear friends. Standing here, I also remember our N. Vijayan sir. He was a very, very lovable person, very lovable personality with a positive attitude. Let his soul rest in peace. At the outset, I congratulate the Kozhikode branch. The President also is sitting here, Secretary, for the very nice arrangements and very nice reception. Along with that, I congratulate the Kerala State branch of IMA CGP for the good function, good CME arranged here. My dear friends, what Dr. Benny and Dr. Bhavirendran said, I also fully agree that it is like that, because nobody is giving importance to the general practitioners. I feel our method of practice or consultation has to change. The primary consultation should be general practice, general practitioner. Only the reference should go to specialist and super specialist. Not that you directly go and meet the super specialist. Then only the general practitioners will get importance. Otherwise, I don't think everyone is giving importance to the specialization of the subject specialist very much in the government also, public also. That is one thing. Secondly, I feel why less members are coming for meetings. I think the doctors are thinking too much personalized thinking and not professionalized thinking. If you think professionally, you should want to get professional knowledge, to impart professional knowledge, to update professional knowledge. Otherwise, you think personally, so you don't want to come for this meeting. These two things are there. I am not taking much time. I express my sincere wishes to this meeting. Hope this meeting will be very great and very useful to all the members coming here.
Thank you, Bhaskaran sir. Ladies and gentlemen, now we have the honoring of one of the most senior most GPs in Kozhikode district, or probably in Kerala itself. I call upon the chief guest, Dr. Babu Ravindran sir, to adorn the Ponnada to Dr. K. Moidu. എല്ലാവരും ഒന്ന് എണീറ്റിക്കുക. He's a very, very senior person.
Friends, it's a great privilege offered to me, and with humility, I honor this great personality, the senior most doctor, the general practitioner of Calicut, our pride. And I think give him a big hand. And
Thank you. All please be seated.
മറ്റ് മഹൽ വ്യക്തികളെ, ഞാൻ വളരെയധികം ഇഷ്ടപ്പെടുകയും സ്നേഹിക്കുകയും ഞങ്ങൾ ഒന്നിച്ച് പ്രവർത്തിക്കുകയും ചെയ്ത നമ്മുടെ എല്ലാം പ്രിയങ്കരനായിരുന്ന ഡോക്ടർ എൻ വിജയൻ്റെ നിര്യാണത്തിൽ ഞാൻ എൻ്റെ ഹാർദവമായ അനുശോചനം രേഖപ്പെടുത്താൻ ആഗ്രഹിക്കുകയാണ്. അദ്ദേഹം മെഡിക്കൽ പ്രൊഫഷന് വഴികാട്ടിയായിരുന്നെന്ന് പറയാതിരിക്കാൻ നിർവാഹമില്ല. ഏതായാലും സർവശക്തനായ ജഗദീഷ് ദൈവം അദ്ദേഹത്തിന് പരലോക ശാന്തിയും സമാധാനവും നൽകുമാറാകട്ടെ എന്ന് ഞാൻ പ്രാർത്ഥിക്കുകയാണ്. എന്നെ സംബന്ധിച്ചിടത്തോളം ഏറ്റവും സന്തോഷകരമായൊരു മുഹൂർത്തമാണിത്. IMA CGPയുടെ ആഭിമുഖ്യത്തിൽ എനിക്ക് ഒരാദരവ് തന്നതിൽ ഞാൻ അത്യന്തം നന്ദിയുള്ളവനാണ്, കൃതാർത്ഥനാണ്. ഞാനിങ്ങനെ ആലോചിക്കുകയായിരുന്നു, എനിക്ക് കഴിഞ്ഞ വർഷം നാഷണൽ IMAയുടെ ബെസ്റ്റ് എൻ്റർപ്രൂണർ അവാർഡ്, എക്സലൻസ് ഇൻ ബെസ്റ്റ് എക്സലൻസ് അവാർഡ് കേന്ദ്ര നേതൃത്വം നൽകുകയുണ്ടായി. നാഷണൽ പ്രസിഡൻറ്റും IMA സെൻട്രൽ കൗൺസിൽ പ്രസിഡൻറ്റും നാഷണൽ പ്രസിഡൻറ്റ് മറ്റേ IMA മെഡിക്കൽ എഡ്യൂക്കേഷൻ്റെ പ്രസിഡന്റ് അടക്കമുള്ളവരുടെ കയ്യിൽ നിന്ന് അവാർഡ് സ്വീകരിക്കാൻ സാധിച്ച എനിക്ക് അതിയായ സന്തോഷമുണ്ടായിരുന്നു. അതേമാതിരി കഴിഞ്ഞ പ്രാവശ്യം ഡോക്ടർ ഉമ്മർ സംസ്ഥാന പ്രസിഡൻ്റായിരുന്ന സമയത്ത് സ്റ്റേറ്റ് IMAയുടെ ഒരു അവാർഡ്, അച്ചീവ്മെൻ്റ് അവാർഡ് എനിക്ക് ലഭിക്കുകയുണ്ടായി. നമ്മുടെ സ്വന്തം ബ്രാഞ്ചിൽ നിന്ന് ഒരു അവാർഡ് ലഭിക്കുക എന്നുള്ളത് അതാണ് ഏറ്റവും സന്തോഷപ്രദമെന്ന് ഇവിടെ പറയാൻ ആഗ്രഹിക്കുകയാണ്. കാരണം അതിന് ഒരുപക്ഷെ IMA CGPയുടെ സംസ്ഥാന കമ്മിറ്റിയും ഡോക്ടർ മറ്റേ നമ്മുടെ ബ്രാഞ്ച് കമ്മിറ്റിയും എല്ലാം കൂടി കൂട്ടായെടുത്ത് ആയിരിക്കണമെന്ന് ഞാൻ മനസ്സിലാക്കുകയാണ്. ഡോക്ടർ വേണുവിനോട് പറയുകയുണ്ടായി, സമയത്തിന് തന്നെ ഡോക്ടർ അവിടെ എത്തിച്ചേരണം എന്നുള്ള ഒരു ആവശ്യം. അതനുസരിച്ചാണ് ഞാനിവിടെ ഈ അവാർഡ് സ്വീകരിക്കാൻ എത്തിയിട്ടുള്ളത്. എന്നെ സംബന്ധിച്ചോളം 62 വർഷമായി കോഴിക്കോട് IMAയുടെ മെമ്പറായി തുടരുന്ന ആളാണ് ഞാൻ. ഇതിൽ IMA കോഴിക്കോട് ബ്രാഞ്ചിൻ്റെ മുൻ പ്രസിഡൻ്റാണ്. IMA CGPയുടെ ഡയറക്ടർ ഓഫ് IMA CGP ആയി ഞാൻ പ്രവർത്തിച്ചിട്ടുണ്ട്. അതെല്ലാം വർഷങ്ങൾക്ക് മുമ്പാണ്. ഒരുപക്ഷെ ഇപ്പോഴത്തെ ഭാരവാഹികൾക്ക് അതിനെപ്പറ്റി വലിയ ഗ്രാഹ്യമുണ്ടാവും തോന്നുന്നില്ല. കോഴിക്കോട് IMA അല്ലെങ്കിൽ സംസ്ഥാന IMA തന്നെ വളരെയധികം സുസ്ഥിരമായ പ്രവർത്തനങ്ങൾ ഡോക്ടർ കമ്മ്യൂണിറ്റിക്ക് മാത്രമല്ല നാട്ടിനാകെ ചെയ്തുകൊണ്ടിരിക്കുന്ന ഒരു സന്ദർഭമാണിത്. ഒരുപാട് നല്ല നല്ല കാര്യങ്ങൾ IMA ആഭിമുഖ്യത്തിൽ ദൈനംദിനം പല ഭാഗങ്ങളിൽ നടക്കുന്നുണ്ടെന്നുള്ള കാര്യം നമുക്ക് അഭിമാനപൂർവ്വം എല്ലാവരോടും പറയാൻ സാധിക്കുന്നൊരു കാര്യമാണ്. ഇവിടെ എന്നെ സംബന്ധിച്ചോളം 1960 കോഴിക്കോട് നഗരത്തിൽ ഒരു ജനറൽ പ്രാക്ടീഷനായി വെറും MBBS ഡിഗ്രി എടുത്ത് വന്ന ആളാണ്. പക്ഷേ അന്നത്തെ കാലഘട്ടത്തിൽ MBBS പാസ്സാകുന്നതിന് മുമ്പായി പലവിധ പലവിധ ചാൻസസും നിർത്തിക്കൊണ്ട് നമ്മളെ ആകർഷിക്കാൻ പലരും ശ്രമിക്കാറുണ്ടായിരുന്നു. അക്കൂട്ടത്തിൽ മിലിറ്ററി സർവീസിൽ ലഫ്റ്റനൻറ്റ് പദവി നൽകിക്കൊണ്ട് ഫൈനൽ ഇയർ മെഡിക്കൽ സ്റ്റുഡൻസിനെ സമീപിച്ചിരുന്ന കാലം ഞാൻ ഓർക്കുകയാണ്. അങ്ങനെ കോഴിക്കോട് നഗരത്തിൽ ഞാൻ എൻ്റെ മന്യനായ ഡോക്ടർ MK മുഹമ്മദ് കാലിക്കറ്റ് നഴ്സിംഗ് ഹോമിൽ ഒരു ഡോക്ടറായി ചേർന്നു. 8 വർഷത്തോളം അവിടെ ഒരു ആർമായി വർക്ക് ചെയ്തു. പക്ഷേ അന്ന് രാവും പകലും ഒരേമാതിരി അത്യധ്വാനം ചെയ്തുകൊണ്ട് എല്ലാ വിധത്തിലുള്ള സേവനങ്ങൾ നടത്താനുള്ള ആരോഗ്യവും മനസ്ഥിതിയും ഉണ്ടായിരുന്നു എനിക്ക്. അതിൻ്റെ പ്രകടനം ഇതിൻ്റെ ഒരു അത് കാരണമായിരിക്കാം 1968 മാവൂർ റോഡിൽ അന്നത്തെ വെസ്റ്റേൺ ഹോസ്പിറ്റൽ നഴ്സിംഗ് ഹോം എന്നുള്ള ഒരു സ്ഥാപനം എനിക്ക് സ്ഥാപിക്കാൻ സാധിച്ചത്. അന്ന് കാടും കുഴിയും മാത്രമായിരുന്ന മാവൂർ റോഡിൻ്റെ ആദ്യത്തെ ഒരു കെട്ടിടം നിർമ്മിക്കാനുള്ള അവസരം എനിക്ക് ലഭിച്ചു എന്നുള്ളത് അത് സർവശക്തനായ ദൈവം തന്ന ഒരു അനുഗ്രഹമാണെന്ന് ഞാൻ ഇവിടെ വിശ്വസിക്കുകയാണ്. വാസ്തവത്തിൽ എന്നെ ഫാദർ ഓഫ് മാവൂർ റോഡ് എന്ന് വിശ്വസിച്ചാൽ അത് അതിശക്തിയായിരിക്കില്ല എന്നുള്ള കാര്യം ഒരു ഞാൻ പറഞ്ഞെന്ന് മാത്രമേ ഉള്ളൂ. അതിനുശേഷമാണ് ഇന്നത്തെ പടർന്ന് പന്തലിച്ച് പിടിക്കുന്ന ഈ സ്ട്രീറ്റ് ഉടലെടുത്തത് എന്നുള്ളത് ഞാൻ ഇവിടെ പറയാൻ ആഗ്രഹമാണ്. കൂടുതൽ സംസാരിക്കുന്നത് ശരിയല്ല, കാരണം ഇതൊരു ആദരവുള്ള മറുപടി പ്രസംഗമാണ്. എല്ലാവിധ ഇവിടെ പറയുകയുണ്ടായി MBBS ഡിഗ്രിക്കാർക്ക് വേണ്ടത്ര പരിഗണന ലഭിക്കാത്തൊരു കാലഘട്ടമാണിതെന്ന്. അത് മാറ്റിയെടുക്കേണ്ടത് നമ്മുടെ എല്ലാവരുടെയും കടമയാണെന്ന് ഞാൻ പ്രത്യേകം പറയാൻ ആഗ്രഹിക്കുകയാണ്. ഒരു MBBS ഡോക്ടർ എന്ന നിലയ്ക്ക് എല്ലാവിധ സ്പെഷ്യാലിറ്റിയിലും പ്രവർത്തിക്കാൻ എനിക്ക് സാധിച്ചിട്ടുണ്ട്. ഇന്നത്തെ വിദ്യാർത്ഥികൾക്കും സാധിക്കും. വർഷം തോറും 150 ഡോക്ടർമാരെ MBBSകാരെ വാർത്തെടുക്കുന്ന ഒരു സ്ഥാപനത്തിൻ്റെ ചെയർമാൻ നിലക്ക് ഞാൻ അവരുടെ പുരോഗമനം ലക്ഷ്യമാക്കി പ്രവർത്തിക്കുന്ന IMA CGPയെ അങ്ങേയറ്റം പ്രവർത്തിക്കാൻ ആഗ്രഹിക്കുകയാണ്. അവർക്ക് എല്ലാവിധ നന്ദിയും പ്രകടിപ്പിച്ചുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ അവസാനിപ്പിക്കുകയാണ്.
Thank you, Moidu sir. Next, I call upon Dr. Samuel Koshi to accept the memento on behalf of IMA Kozhikode from Dr. Benny PV. Thank you, sir. I call upon Dr. Babu Ravindran sir to accept the memento on behalf of IMA Kozhikode from Dr. Joseph Benamin. Thank you. Joseph Benamin sir, I request you to accept this memento from IMA Kozhikode from Dr. Manoj Kumar KT. Thank you, sir. Next we have felicitations. I call upon Dr. Surendra Babu, North Zone Vice President, IMA Kerala State Branch.
esteemed Chair, Director of Studies, IMA Cgp Kerala, Dr. Benny, IMA KSB State President, respected Dr. Samuel Koshi, every dignitary on the dais, off the dais, friends, colleagues, special invitees. Now, it's a very pleasant experience to me to be a part of this IMA Cgp State Conference being conducted, hosted by the largest branch of North Zone, Calicut branch. And I think Calicut branch I have visited the most number of times in my tenure as the state vice president. Now, the oldest academic wing of IMA is IMA Cgp. IMA Cgp, as I know, will be celebrating its Shashthyabda Purti next year. By 2023, it will be completing 63 years of existence. And as our previous speakers have said, IMA Cgp try to inculcate more modern medicine aspects to the general practitioners or the family physicians. I understand that there's a project going on under IMA Cgp to form family physicians club in every branch. I wish all the very best to this venture of IMA Cgp. And moreover, there's an understanding that among senior leaders at least, and many of them, that if the academic programs of IMA branches involves more of basic sciences, basic clinical subjects, other than more than super specialty topics, the attendance will be increasing in the branch meetings. But today, I am very sad to see, as our previous speakers, Dr. Babu Ravindran, Dr. Bhaskaran sir have said, the attendance we should have had a little bit more attendance in this meeting. Anyway, every one of us will try to increase the attendance of branch level meetings, as well as state meetings. I envision IMA Cgp improving its performance, going on to more excellence, and I wish all the very best to Calicut IMA branch. Thank you, everyone. Jai IMA, Jai Hind.
Thank you, sir. I call upon Dr. Narayanan M., North Zone Joint Secretary, IMA Kerala State Branch.
Respected IMA Cgp Director Dr. Benny, our esteemed President Dr. Samuel Koshi, and all other dignitaries on and off the dais, and respected teachers and my dear friends. Today I am very happy to be here, and I was here in the last week also. And IMA Kozhikode, under the leadership of Dr. Venu, Dr. Aningutti, and all others, are ready to organize any meeting, even if it is state level or branch level or district level. They are ready to conduct any meeting. And we are very happy to be here, that is why. So I wish all the best for this program, and thank you all for the coming. Thank you.
Thank you, sir. I call upon Dr. C.P. Mustafa, sir, to hand over the memento to Dr. M. Bhaskaran. Dr. Mustafa is also a very senior GP who works in Calicut Nursing Home. I call upon Dr. Sandhya Kurup to hand over the memento to Dr. Surendra Babu. Ajita madam, could you do the honors, please? Thank you, madam. I call upon Dr. M.G. Vijay Kumar, sir, to hand over the memento to Dr. Narayanan M. Thank you, sir. I call upon Dr. P.K. Shaziran, sir, to hand over the memento to Dr. Pradeep Kumar Viji. Thank you, sir. I call upon Dr. Sushama Anil to hand over the memento to Dr. Ajita PN. Thank you, madam. I call upon Dr. Saj Matthew to hand over the memento to Dr. Aneen and Kuti. Thank you, sir. I call upon Dr. Venugopalan B., President IMA Kozhikode, to hand over the memento to Dr. Manoj Kumar KT. Thank you, sir. And Dr. Venugopalan, sir, please, the memento to Dr. Benny PV. Thank you, sir. Next, we have the vote of thanks by Dr. Sabina, Organizing Secretary, IMA Kerala State Branch.
Good morning, everyone. First of all, it's a great privilege for me for organizing the State CGP conference. As you all know, the group of people who is more close to the public, that is the general practitioners, who see the patient for the first time. So it has more importance that we are facing, general practitioners are facing their first initial problems. Then only it goes to the specialist and the super specialist. So it's a very great thing that IMA CGP is giving more information regarding how to deal with patients actually at the ground level. And I have been a secretary for the last 1 year, and just because of the COVID scenario, we were able to conduct like 12 sessions, online sessions. It covered almost all branches, neurology, psychiatry, surgery, medicine, all which is at a normal, understandable sessions it was, where many of them were benefited, many doubts were cleared. So it's an honor for me that I was able to be part of that. Now let me come to the duty entrusted to me. Respected dignitaries on and off the dais, senior members, and my dear friends. Actually, it is a great honor that all the great IMA leaders have come from so far just to become a part of the State CGP conference. So, first of all, I thank Dr. Benny PV, Director of Studies, CGP IMA KSB, in spite of the busy schedule, to make for the conference. Thank you, sir. I thank Dr. Samuel Koshi, President IMA KSB, for attending this in spite of all the busy schedules. Thank you, sir. Dr. Babu Ravindran, sir, past National Vice President, who was the chief guest. Thank you, sir, for coming to this conference. I thank Dr. Joseph Benevolent, Secretary, IMA KSB, for his enthusiastic attendance in all the conferences and for attending a conference. Thank you, sir. I thank Dr. Bhaskaran, sir, my friend's father also, past National Vice President, for coming all the way from Wayanad. Thank you, sir. I thank Dr. Manoj Kumar KT, Secretary, CGP IMA KSB, for attending this conference. Thank you, sir. I thank Dr. Surendra Babu, North Zone Vice President, IMA KSB. Thank you, sir. Dr. Narayanan M, North Zone Joint Secretary, IMA KSB. Thank you, sir. Dr. K. Moidu, Senior GP and past President, IMA Kozhikode. Thank you, sir. Dr. Pradeep Kumar VG, past President IMA KSB. Thank you, sir. Dr. Ajita PN, State Chairperson, Mission Pink Health. Thank you, Madam. Dr. Aneen N. Kuti, Convener, District Committee. Thank you, sir. And Dr. Venugopalan B, President, IMA Kozhikode branch, who is the main stalwart behind this conference. Thank you, sir, for all the guidance. Then I cannot just stop before thanking Dr. Shamsuddin, Organizing Chairman, IMA CGP Con. It was a great time working with you. Thank you, sir. I thank Dr. Raju Balram, sir, Junior Vice President, for his excellent comparing and always smart performances. Thank you, sir. I thank all the faculties who had rendered their talks, and now there are some interesting sessions to be on. Thank all the faculties for their accepting this and coming in spite of their busy schedule. I thank all the senior members assembled here. I thank all the delegates. I thank the trade and the pharma for supporting our conference in all ways. And I thank all the staff, Santosh, Biju, for making this conference a great success. I thank you all.
Thank you, madam. With that, we come to the end of the inaugural function. We move straight to the Dr. Ramanathan Memorial Oration. I request Dr. Hamsatail, sir, to present the memoirs of Dr. Ramanathan. I was made to understand that Dr. Chitra Ramanathan, daughter of Dr. Ramanathan, is in the audience. Would she please come forward, please? Please come forward, please. And Dr. Krishna Kumar, who is the son-in-law of Dr. Ramanathan. Sir, please come forward. An oration in the memory of your father. 2 words from you, madam.
This idea, dear friends, all senior members, all senior practitioners, my father, Dr. Ramanathan, I think he was one with IMA right from the knowledge, from the days which I knew him to this hall. I think he hasn't spent a single Sunday sitting at home. He's always been here. His heart and soul worked for the IMA right till the end of the, until we told him, please give up the treasurership so that somebody else continues and the organization goes on well. And it's really endearing to see this organization, the Calicut branch, doing so well and so active even now. So I congratulate all the office bearers of the Kozhikode branch who are doing such a great service. And I hope and wish them good luck so that they continue their services for a long time. Thank you.
Chitra madam, I believe you are a student of the 25th batch. Is that right? So, alumni of Calicut Medical College 25th batch, Dr. Chitra, daughter of Ramanathan. Thank you, ma'am, for those. Sir, Krishna Kumar, sir, please introduce yourself to the audience and words about your father-in-law.
I am Dr. Krishna Kumar, consultant physician. I am grateful to IMA for continuing this oration program, and I can picturize Dr. Ramanathan sitting right, my father-in-law sitting right in front, along with all the senior stalwarts. I can picturize him giving his nod rule for this oration, and especially this topic, which is favorite for him. And the speaker is also an apt speaker to give a talk on this. Thank you very much.
Thank you, sir. Dr. Hamsatail, please do the honors.
Good. Respected senior colleagues, my dear colleagues, when Dr. Venu asked me to do this assignment, I looked around to see whether I could find someone who can delegate this for me, because I had to leave the city for some other personal things. But unfortunately, there is nobody who had been peer with Dr. Ramanathan and who can say something about him. Because when in 1974, I had been to these premises. Over those days, the IMA meetings were very formal, frugal, and almost ended with some tea and snacks, where there were Dr. Moidu was there, Dr. Anand Shivan, Dr. C.R. Parasuram, Dr. Captain A.B. Das, Dr. Nedungadi, and to add a feminine touch, there was Dr. Sumadi. Those were the people who were there in that IME meetings. And Dr. Ramanathan was a regular presence. I had never seen him miss a IME meeting, as Dr. Chitra and Dr. Krishnakumar was telling. Because I had heard him saying that he had learnt more medicine from IME meetings than from his clinical studies. Dr. Ramanathan was a versatile personality of varied interests. He was a GP of repute. He drew crowds from as far from Vadagara to Malappuram. And he had been, apart from the native crowd, and he had been a connoisseur of music and arts. He had organized some Tyagaraja music festivals, and he had a lot of hands in philanthropic activities. He had been running a free clinic. Apart from that, he was an avid gardener. He had been the forefront of many horticultural activities. And you name, he was there. So much so that when on a IMA activity, we went to see the mayor. Mayor was very sore that he was almost angry at us not having a public function at the death of Dr. Ramanathan, because he had served the city for more than half a century. Dr. Ramanathan was IMA and I was Dr. Ramanathan. He was the treasurer for a time. As long as he lived, he was the treasurer. That shows the integrity of Dr. Ramanathan. The same, the hall which we are now has been the effort of Dr. Ramanathan, not forgetting the contribution from Dr. Balakrishnan Nair, the Ashoka Hospital founder. Dr. Ramanathan passed out from Stanley in 1951, and he had been a student for PG, but then he broke off because he could not afford the studies. He came down to Calicut and he practiced under the legendary Dr. Narayana Swami in front of that Kottaparambu Hospital. That building is still there near that tip-top furniture, plastics. Dr. Ramanathan had a very other interests as well, and if you talk on Ramanathan, that will be another oration. And I won't eat into the time of PKS, who is, as Dr. Krishnamar said, he is aptly chosen because he is the man who is espousing the cause of family physician, and of which Dr. Ramanathan was a role model. Friends, to you, Dr. PKS.
Thank you, sir. The duty of introducing the orator has been handed over to me. So I will introduce Dr. PKS to all of you. Dr. PKS, as he is fondly known, retired as a professor and head of department of Calicut Medical College. And after his retirement, sir is working as a senior consultant in Astor Mims Hospital and an emeritus professor of Calicut Medical College. He passed out his MBBS with flying colors from University of Calicut and took his MD degree from the Postgraduate Institute of Medical Education and Research, Chandigarh. Recipient of several awards and fellowships, has 95 publications to his credit, has written 3 books, has contributed chapters in various books in medicine and hematology. He has held various positions in various organizations such as the chairman of the PG Board of Studies, Kerala University Health Sciences, editorial board of Indian Journal of Hematology and Transfusion Medicine. He's a PhD research guide for University of Calicut, has held the position of the president of Association of Physicians of India, Kerala chapter, scientific advisory committee member, National Institute of Immunology, Hematology in Bombay. Ladies and gentlemen, a big hand for our own PKS, sir. Welcome, sir. The stage is yours.
Good afternoon to all of you. I'm very happy that this oration is given in memory of Dr. Ramanathan. I dedicate this talk to Dr. Ramanathan and the teachers who taught me clinical medicine, clinical skill. This is the background of the issue. Abnormal is normalized now. I hope you get the meaning of it. If you look at the people around, 90% are overweight. After it now. I'm getting several consultations from patients with a history of loss of weight. And with the difficulty only I convinced that they are normal. Because they think that they are abnormal. This is the situation where we are. Many who come for not gaining weight or weight loss are healthier than the overweight counterparts. And it has become the rule of thumb that the tertiary care centers are used for primary care these days. We are laying on USA for all the aspects on healthcare, including policy making. But one must know that it is the most notorious non-system in the world. NON, non-system in the world, but we rely only on that. And that has destroyed the problem. Okay. Thank you. Very good. So I can quit. So we depend on, for every parameter now we take USA as the standard. For example, BMI, blood pressure, fasting lipid profile. And finally, the USA standards has made the whole world a sick society now. This is a reality that we wake up to. I'll start with one simple case history to illustrate the point of where we are missing the clinical practice these days. This is a male, a swelling on the left parotid region. As usual, because we encourage doctor shopping, he went straight to an ENT doctor and he asked for an FNAC because they think that doing an FNAC will give the diagnosis. And the histopathology neoplasm. Then the enthusiastic pathologist himself searched for secondaries and primaries, and he thought that thyroid is abnormal. He took an FNAC from thyroid, which reported as papillary neoplasm. Then he went to the highest high-end cancer hospital for the treatment of that malignancy in the parotid and the thyroid, based on a clinical impression and a wrong report. And then at the cancer center, repeat aspiration twice was done from the left parotid. Then he developed severe parotitis and swelling. Since he knew me personally, he came to me for an opinion, what to do now. Because I knew him, I could diagnose him just by looking at his history. He is a chronic alcoholic, and this parotid enlargement was simply due to development of cirrhosis. Unfortunately, the left side was a little more bigger than the right side. Anybody with a clinical skill can say that it was just normal, otherwise it's not a malignancy. He had all the features of chronic liver disease, which was not looked at or picked up by the habit of doctor shopping that we have. It's a very sad situation. Clinical skill is all about good history taking and good communication skill. 90% of any diagnosis comes from good history only. Even in I see only referred cases. I don't see patient directly. Most complicated, worked up case with no diagnosis only these days I see. Even in those patients, 90% of my diagnosis come from history only. So that's the importance of history taking. But people are not aware of it. Physical examination is only to look for supportive evidences for the clinical diagnosis that we make. And once we have clinical diagnosis, we shortlist 1 or 2 possibilities at the end of history and physical examination. Then the laboratory tests are done only to differentiate between those 2 possibilities. No laboratory test will give a diagnosis. If at all a laboratory test gives a diagnosis, it's only part of the diagnosis. You will get that 90% of the diagnosis, even the most complicated cases, by good history and physical examination. One must remember that no investigation on earth is 100% specific or sensitive. These days, patients come with a different kind of story. Most patients come and say, "Doctor, I have GERD." Another will say, "I have a polyp in the colon." Another will say, "I have a cyst in the liver." Another will say, "I have a high cholesterol, fibromyalgia. I have a uric acid problem, fatty liver, gallbladder stone." Some patients I get with a history saying that I have low protein CNS. "Doctor, what should I do?" This kind of consultation has become the routine now because health checkup is being done by laboratories now. And another patient will say, "I have a headache, all tests were done, nothing could be found out." But only one test was not done, Mendo scan. That is good history taking. That was not done. That is reality nowadays. This is what happens. History from today's patient is always corrupted. Corrupted by the investigation reports, the opinions, advice from neighbors, similar patients. So finally, the wrong history only we will get. From doctors and also, because of the lack of clinical skill, anyone with a thrombocytopenia without a fever also is now getting investigated for leptoserology, dengue serology. Lepto and dengue are clinical diagnosis only. Thrombocytopenia is incidental. Now for thrombocytopenia, people are asking for leptoserology and dengue serology. This is a common practice now. And I see several patients having PUO without P, having psychogenic fever. What is the point in investigating a PUO without P? Patient says fever, there may not be fever. So one should know whether his complaint is fever. And recently I had 2 patients who had unexplained hyperpigmentation of skin. Skin biopsy was done to find out the cause. Unfortunately, or fortunately for the patient, it was just due to B12 deficiency, vitamin deficiency. You will not get a diagnosis from investigations. Low backache, you will not find a single patient without getting an MRI scan these days. Musculoskeletal pain is a commonest cause. 90% do not even need any of the investigations. Headache, these days invariably get a CT scan. And abdominal pain, everyone will be coming with an ultrasound scan only, but no cause would be found out. Anemia and any abnormality in the blood, people think that a peripherous mean and bone marrow will give a diagnosis. It's not true. Even in hematology, where the most difficult situations to sort out, you will not get any diagnosis unless you have a clinical diagnosis. Urinary symptoms, they undergo cystoscopy. Dyspepsia always gets an endoscopy, upper GI endoscopy. And now there is a special term called non-ulcer dyspepsia. Why should it be there? That term itself is ridiculing the clinical skill. There should not be anything called non-ulcer dyspepsia. Dyspepsia is a simple problem, a motility disorder resulting from decreased intake of vegetables. And that can be found out by just studying the dietary practices. And then you do an endoscopy to say that there is no ulcer. Then you have a new term, non-ulcer dyspepsia. There is no ulcer, patient has dyspepsia. How do you proceed from there? Simple history can. And bleeding PR, patient goes to, with a bleeding PR, first thing done is now colonoscopy. And the colonoscopy detects hemorrhoids. Simple physical examination is enough, history is enough, but it's not done. Arthritis invariably gets joint X-ray, aspiration, MRI scan. TB diagnosis, nobody diagnoses TB without a confirmatory test like AFP, histopathology, or a culture report. When in fact, at least 50% of the patients, you will have to give empirical treatment with a clinical judgment. And because I am seeing a lot of hematology problems, this is one problem. All polycythemias invariably get a JAK2 mutation. I can disclose one study report that we are going to publish. Weight gain and chronic hypoventilation is the commonest cause for secondary hypopolycythemia in India. Weight gain and chronic hypoventilation is the commonest cause for secondary polycythemia in India, which is not recognized. Textbook has written it as Gaisbach polycythemia, something like that, with not knowing what it is. So JAK2 will not give a diagnosis. JAK2 can be false positive. For example, if you do JAK2 mutation study in all the people sitting here, at least one person may be having it as just as a incidental finding. JAK2 is not confirmatory. Butol deficiency is diagnosed only by butol levels. You can find out by good history. Folic acid, patient does not take fruits and raw vegetables. Why do we want a folic acid level? So we are going beyond common sense. Multiple investigations, and maybe it is non-invasive, but I would call it as a living autopsy these days. We are subjecting the patient to a kind of autopsy by doing repeated investigations, a kind of torturing. And we happily use guidelines and criteria for rare diseases, but we do not use criteria for making atypical presentations for common diseases. This is what happens. Technology has overtaken us. MRI, CT scan without use of clinical skill. Ultrasound is required for fatty liver. Anybody with a history of overweight is not in terms of American standards. There are some individuals where the normal BMI is 18. If they put on even 2 kilogram weight, there will be fatty liver. If you put on weight, fat accumulates all over the body. Part of it will be there in the liver. So the only thing you need to find out is whether there is a weight gain or not. If you have weight gain, there will be fatty liver. Why do you need an ultrasound? Ultrasound is not needed to diagnose fatty liver. PET scans are nowadays done to find out diseases routinely. Liver transplantation for NAFLD and alcoholic liver disease. We are not concerned about reducing the weight, stopping alcohol. Robotic surgery being promoted, ignoring human skills. Recently there was a story from USA. The program went wrong and the patient died. Robots are under our control. We should not behave like robots. And the extracorporeal shock lithotripsy for kidney stone, with no interest in prevention of renal stones, is ridiculous. Telemedicine for patient care has become a fashion of the day. It's not possible at all. Rarely it can be used as a stopgap arrangement for follow-up of patients. It will never replace proper consultation. So I would say that clinical skill is all about history and history taking and logical approach. People need scientific, I forgot to, some mistake has come in the heading. People need scientific modern medical approach. We need to change, and proper history taking is the key to that. Good communication skill is at the most important aspect of clinical skill. So I will try to define clinical skill as a combination of several skills. Most important being communication skills, ability to elicit good history and physical science, and the skills to interpret and correlate the findings, and being aware of the common problems, their patterns, and familiarity with the common illnesses. In fact, it is a familiarity that gives you a diagnosis in most of the problems. And the concern for cost effectiveness. And gaining familiarity by working and learning from teachers, patients, and experience from all possible sources. Concern for cost effectiveness, human attitudes, willingness to help and serve, and managing the patients rather than treating. Treating is just prescribing medicines or doing a procedure, but management becomes managing the situation arising from the illness. So all these put together is what is called as clinical skill. Now I'll give a case history to tell what can go wrong if you do not apply clinical skill properly. This was a 53-year-old male who had low-grade fever of 3 months. Pallor was detected and a small axillary lymph node was detected. Spleen tip was palpable, liver was 3 centimeter. Hemoglobin was low, total count showed pancytopenia, and platelet count total count was low, but platelet count on the lower normal side. Peripheral smear reported as bicytopenia, and the bone marrow showed focal infiltration by lymphocytes and plasma cells, and lymph node biopsy confirmed it as follicular lymphoma. Immunophenotyping showed CD20 positive and VCL2 positive, CD3 negative, and he was diagnosed confidently as a follicular lymphoma, and he was admitted for chemotherapy. Incidentally, only I happened to see because the patient was about to be given chemotherapy. That happens sometimes because every patient we may not be seeing. So next day, when I went to see the patient, I just reviewed the history. Never accept a previous diagnosis blindly is the dictum that we have to follow. Whoever it may be, always we have to review the diagnosis. So I just done that, reviewed the history. I found that this man had dryness of mouth, he had hair loss, he had arthralgia, which are not common with non-Hodgkin's lymphoma. That familiarity helped me. ESR was 120 on 1 and repeated was 103. ESR is often considered as a neglected test these days. People don't give importance to ESR. They do CRP only. And there was another finding. There was albumin global reversal. These are not common in non-Hodgkin's lymphoma. So I could not accept that histopathology diagnosis. So just thought of a different diagnosis and sent for ANA and anti-dsDNA. ANA was highly positive, anti-dsDNA borderline, but I was sure that it is not lymphoma. So I just, taking the risk, I started him on azathioprine steroid and he recovered. But meanwhile, I retired and the patient was lost to follow-up. Somebody thought I was wrong. He stopped the treatment with azathioprine and steroid. And then the patient had relapse of symptoms. He comes back to me, found out that I'm in a private hospital. He came there. And this was a picture at that time. You can see the classical lesions of SLE, including oral cavity lesions, confirming that I was right, that it was SLE only, it was not lymphoma. These were the findings: erythematous skin lesions all over the body, palatal lesions. These are very typical of SLE. And these were the investigations at that point of time. Hemoglobin was low, platelet count was low, total count only 1,370, ESR very high, SGPT high, albumin global reversal is there. This time anti-dsDNA was more than 790. So the diagnosis is 100%, and still, because it was diagnosed as lymphoma before, I thought I will rule out a retroviral infection also. It was done, it was negative. So it was SLE relapse. So this is how the diagnosis evolves, not from laboratory. Now another patient, a 16-year-old girl, +2 student, she was brought with bleeding from multiple sides. The mother will say bleeding from eyes, bleeding from ear, every side. And mother claims that she had witnessed it twice. But when the patient was brought, there was no bleeding. This history to be cross-checked with a detective mindset. That's, in fact, history taking is like that of a super intelligent detective. That is what we have to do. And in this patient, physical examination, investigations, APTT, hemogram, everything was normal. She had tiredness, but she looked gloomy while taking history. And I noticed that she had an indifference to the complaint. While she was telling about the bleeding, that concern was not there. That made me think of something else. Then I sent the relatives outside and talked to the patient alone. And I found that she was suffering from a problem of sexual assault from a relative, which she could not tell the mother or father. That was the reason for all these complaints. So these kind of problems you will get only from history. So patient actually told me the diagnosis. So the history taking is in such a way that listen to the patient telling you the diagnosis. That's what history taking really is about. Similar situations every day. Patient's urine culture report showing E. coli, but the patient has no urinary tract infection. Urinary tract infection is diagnosed by history and physical examination, and urine showing pus cells. Then only culture should be done. But even this simple awareness is lacking among the doctors nowadays. They straight away ask for urine culture, and contamination may be giving positive growth. Dengue NS1 positive is not dengue fever if it is not clinically dengue fever. NS1 negative does not rule out dengue fever also. COVID positive does not have COVID. This is recently, 1 week ago, I had a patient who came with acute respiratory distress and high-grade fever. And I found out that he had a pansystolic murmur. My diagnosis was a VST with infected endocarditis, embolizing to the lung with a bronchopneumonia-like presentation. That was my clinical diagnosis. But he said he was there for long, and he also gave a history of trekking and thought of scrub typhus. The reports were in favor of scrub typhus versus infected endocarditis, and I started treatment for infected endocarditis with amoxicillin clavulanic acid, and doxycycline was started because scrub typhus was highly possible, and next day he looked perfectly normal, but the COVID test is positive. This is the situation now. Unnecessarily people are being tortured by doing this COVID testing. And then when I went for rounds, the bystander and patient were wearing masks. I went there to see without mask, and they were asking me, "Doctor, are you not afraid?" I told him, "I examined you without wearing a mask when you came with respiratory distress. Why are you afraid?" This is the situation. People are being scared unnecessarily because of the wrong information that we give. Rheumatoid factor does not mean the patient has rheumatoid arthritis. You have several other causes for it. I can go on giving several such case histories. One case was diagnosed as adenocarcinoma, received chemotherapy, and after a year, the patient came with a recurrent pleural effusion on that side. But it was simply an APLA syndrome with a pulmonary embolism, hemorrhagic effusion. Rabies, one patient who was diagnosed as rabies had actually a cerebral thrombus involving the brainstem. The history which told me that it is different was sudden onset. Rabies will not have a sudden onset. So history is so beautiful in differentiating problems in the patient. And one patient had a history of repeated episodes of typhoid. So that gave me the clue that young female, repeated episodes of typhoid, and ESR was on the higher side. It was SLE. False positive serology is common in SLE. No test is 100% sensitive or 100% specific, but several clinical parameters put together is more specific and sensitive. That's the point we have to learn and teach. Familiarity with the clinical parameters is most important in clinical practice. So the clinical skill is all about our practice as doctors, and we should be interested in wellness. That is why the Ayush people are taking advantage of the situation. We are not showing interest in wellness. We think that we can treat every disease. We are waiting for people to come with the disease, and we project as if we can take out all the diseases with all the modern gadgets. It is not possible. So we should be interested in wellness. If you are interested in a disease, you should also be interested in preventing that disease in the community by several social interventions. Early diagnosis should be our motto, and it's not treatment, it is management. Managing the situation arising from the illness, which includes several issues. Always learn to place clinical diagnosis above laboratory diagnosis. Guiding patient and family throughout the course of illness is our objective. As a friend, philosopher, and guide, sticking to ethical practices, avoiding over-treatment, do no harm is the first priority. We can see several patients undergoing unnecessary institutional treatment with NSAIDs, developing renal involvement and all. So NSAIDs should not be used carelessly. And elective angioplasty, I would say, is mismanaged, misused everywhere. So when we practice clinical, learn to extract information from patients and relatives like a super intelligent detective. It's much more than that. Our job is more important than a detective in extracting history. And then a proper physical examination and depending on lab is comparable to physical torture by police to get evidence. If you start sending investigations repeatedly, some patients or some culprits also, alleged culprits, when they are beaten repeatedly, they will admit, I have stolen this, I have taken this. It's something like that. If you do investigations without history and physical examination and proper interpretation, the results that come out of it is like the culprit who admits wrongly. That's the kind of situation that. Lab alone will never give a complete or correct diagnosis. Wrong diagnosis equivalent to wrong conviction of a culprit. The components of clinical skill or making clinical diagnosis, greatest investigation is history, as I mentioned, 90%. Second best investigation is physical examination. Third is logical interpretation and simple laboratory investigations, looking for supportive evidences only to tie the loose ends. And make a clinical judgment and act immediately. Do not wait for proof to start treatment. But this does not happen in tuberculosis even in India now. Rarely a period of observation also with a masterly inactivity helps us in arriving at a diagnosis. And I don't have to tell about communication skills. It has got several components, verbal, non-verbal. I will not go into that. But the most important is be a good listener. Appropriate body language is important. Showing empathy is important. Never crack jokes at the expense of the patient. Never laugh at hurt the feelings of the patient. Remember that when you are studying the patient, patient is studying you also. This is a very important point to remember. And good communication skill goes with the basic qualities, transparency, honesty, and integrity. If any one of this is lacking, your communication is going to be poor. No, should not have a hidden agenda while evaluating a patient. Always discourage the bystander who volunteers to give history. All records proudly being displayed in the beginning should be discouraged. Now they come with a bundle of reports and they will say that, doctor, all the diagnoses there in that packet. And they will not even tell anything about the history. They will start telling about the laboratory reports. Discourage them gently, but do not ignore. Listen later, even the bystander. But beware of irritating, demanding, and dominating bystanders and patients. We should know how to handle them. Do not ask leading questions. I will not go into that. There is one point we need to know. When you are interviewing a patient, make sure that we and the patient are talking about the same thing. This is a very important point. Never accept diagnosis as told by the patient. Always cross-check. Irrelevant talk we need to identify and discourage. Listen to the bystanders also, but make sure that bystander is reliable or not. Bystander may be the closest relative, but may not be staying with the patient. He may be in USA, came yesterday to look after the mother or father, and you may be listening to the mother. The best person is the person who is staying with the patient. See the patient as a human being, not as a collection of symptoms, signs, and disordered structure and function. Basic tips are these. Do not force the patient to give history in the order we prefer. Listen the way they give it, then rearrange. Specific order only in writing and presenting the case. Encourage the patient to talk. There is no organ-based clinical approach. And for that reason, there is no doctor shopping. Only a doctor who is capable of evaluating the patient in totality should be seeing the patient first. Nobody who claims as a cardiologist or neurologist should see the patient first. This is a dictum followed in all the countries except India, and we are not bothered about it. Patients come with problems, cannot know the headache is due to a neurological problem, they do not know. There is no division in the body into systems. Is there a division in the body? Who made the divisions? It's for our convenience, just to make a uniformity in presentation and recording case history. Is there a division in the body into systems? It's for our convenience only. We should not be dividing ourselves based on organs. And at the end, summarize the history, arrange together all the points got mentally or by writing, think of the possibilities, and while thinking of the possibilities, always think common things are common. Make up your diagnosis, and that is what I said, listen to the patient telling you the diagnosis. At the end of the history, if you have no idea as to what you are suffering from, your history is incomplete. The problem is with the doctor only. It's not with the patient. And you are not going to get much from physical examination. And if in that situation, laboratory will always mislead you. This is the point worth remembering always. And in that kind of a situation, you are not competent to even ask for a laboratory test. Suppose a patient has come with a headache, you do not know what it is, and you could not make up your mind regarding what are the possibilities, at least one or two main possibilities. you are not competent to ask for any laboratory investigations. You should send the patient for a repeat opinion rather than investigating. Lab tests will mislead you very confidently in such situations. So these are the essentials of a clinical skill. Always have a conservationist attitude. Avoid, when possible, all investigations, injections, transfusion, surgery. Our plan is to avoid rather than doing it by plan. Don't be aggressive in treatment. More is not better. First, be aggressive in prevention, but that's very important. Clinical skill is essential to make us useful to society. This is a summary of a good history. Good interview yields accurate history, valid basis for physical examination, better diagnosis. It establishes effective working partnership with the patient, increases patient satisfaction and trust. Patient would reveal very confidential information, including abuse, as I mentioned, sexual abuse, intimate family relations, and better compliance with treatment, and there won't be any complaints and litigation if that is happening. So these are the basic qualities required in doctors, and by design, we can combine all these only in family doctors. And that group of doctors is missing in India. And India is suffering because we have not brought out family doctors. It is it is very late. At least now we have to wake up. And I was talking to Dr. Babu Ravindran that they need a formal training. Without formal training, these days, they will never become good family doctors. When we were students, we actually joined MBBS with the idea of becoming a GP. And we followed every good doctor to learn everything from each doctor. Badran sir is sitting here. When we went, we will learn from Badran sir and everyone, as if we wanted to learn everything about gynecology. When we go to pediatrics, we learn everything from pediatrics. When we go to medicine, we learned everything from physicians, surgeons. So because our objective was to become a GP. But at the end of the training, after completing MBBS house agency, we knew that we cannot do an independent practice, even at that stage. But they had no other choice to become a GP. Slowly they worked and finally became very good GPs in 3-4 years. That was a different period. Now what do the students do? From day one they are focusing on entrance exam. And during house agency also they are focusing on entrance exam. Somehow they finish internship, they straight away go to an entrance coaching center. Whatever little they have learned is spoiled. These students can never become GPs unless you give 3-year intensive training. Some will ask, is it not a repetition of MBBS? Yes, it is a repetition of MBBS, but they need it. So let us not say that MBBS is enough to become a GP these days. And one more thing to justify my point, all over the world, nobody is allowed to do independent practice as a GP without a 3-year training. I have traveled to 24 countries to study the system of GP practice. It's very important to know that every country has it. And students willingly choose to become family doctors in all the countries. And recently, I was in Sweden just before the COVID epidemic. One of the doctors who were my students, listening to me, wanted to become a GP there. The doctor started going to a GP setup. And after 6 months of working there, then the doctor came and told, sir, it is very difficult to become a GP here. I will become a specialist. What is the attitude here? In England also, in 2007 only I was there. I was a guest for the Calicut alumni meeting. 170 doctors and their families came. 168 of them were specialists. 2 of them proudly said, I am a GP. I thought there's something wrong with them. But next day I come to know that they were getting £5,000 a month in 2007. The specialists were getting only £3,500 a month. The government is promoting GPs because they know that they are more important to the people. Our governments do not know this. We are responsible for that lack of information. Let us spread that message also. So medical learning has 3 components. Anyway, this is more technical. I will stop it here. I will go to more important. So diagnosis from investigation is always incomplete. Computers can never replace diagnosis. They can help us. Computers can never replace human clinical skill. There is no final diagnosis from laboratory. Can anything replace history taking and physical examination? Never, never, never. I will repeatedly say it will never. replacing clinical skill with investigations is a disastrous consequence only. But no one palpates abdomen now. No one is palpating abdomen. Even huge spleen is missed these days. XRHS, CT, MRI instead of good history and physical examination has become the order of the day. I had several patients where cerebral thrombosis was diagnosed by good history and physical examination, but MRI did not pick up because thrombus is a dynamic structure. By the time the patient comes, it would have dissolved. So you have to make a clinical diagnosis. So no medical profession without clinical skill, most basic skill. If no clinical skill, you will be missing the forest for the tree. This is what we are now aiming at. Health checkups today think that you just need to sit in front of a computer, like wearing a jacket like this, which will check all your blood pressure, breath analysis, temperature, and biochemistry, EEG, ECG, and finally the computer will give a prescription. This is what we are aiming at. This is a ridiculous approach to modern medicine these days. Actually, we are killing the modern medicine by this. So who would use clinical skill maximally? Internal medicine, general medicine, pediatrician, and that kind of doctors in a hospital setting. But it is a GP or family medicine in the primary care or community setting. This is one thing we need to know. Some general medicine doctors think that when we are here, why should there be a separate family doctors? They are for working in a hospital setting, hospitalist. General surgeon, pediatrician, orthopedician, these people are hospitalist doctors. They should work in a hospital setting. Gynecologist, all including. But a community setting, you need family doctors. They are not going to be mutually competitive. They are mutually supportive only. That kind of thought should be very important. And family doctors are the ones who depend mostly on clinical skill. They know the value of internal medicine doctors also. Some my internal medicine colleagues are opposing the training for program in family medicine, saying that I am against internal medicine now. They did not realize that it is important for them to survive in the long run. So clinical skill is all about practicing medicine as an art using science, working with a detective mindset, empathetic, managing, reforms, need criticizing. When I try to reform the situation by criticizing, there is nobody to accept it. The moment I criticize, Ayush people will come with support. That's another disadvantage here. We cannot criticize our system. Ayush people will come say that we were doing it and you are wrong. Our people will say you are trying to go against the modern medicine. So we cannot criticize our system these days. So let us have internal dialogues. Modern medicine, you should know that it has evolved from all these ancient systems of medicine, like the Persian system, Ayurveda, everything. It has utilized in Greek medicine, everything has been utilized for developing and improving and finalizing the concepts in modern medicine. Why should we go back? We are wasting resources by promoting Ayush. I am very open in telling that, but we cannot talk it outside. They are so powerful. We are trying to go back to the ancient system by discouraging the family doctors and encouraging the Ayush people to proliferate. Ayush people are proliferating in the huge vacuum created by absence of family doctors. This is one reality all IMA doctors should come to know and work for it. So I'll finish with a last case history. First, do no harm is the most important thing. Never make treatment worse than disease. Use clinical skill and clinical judgment. I will just mention about a case of malignant pleural effusion which I happened to treat in the beginning of COVID, the heavy lockdown period. A 35-year-old male medical professional working in another state, he was diagnosed as a malignant pleural effusion during that heavy COVID lockdowns. Many of his colleagues were on quarantine. They were getting excessive duties, hardly got rest and sleep, and he used to sleep hours a day. He meal sometimes due to the heavy duties. After 6 months into this practice, he started experiencing a right-sided chest pain, but he ignored it for 2 days. And then he also had a doubtful evening rise of temperature. There was no other symptoms. And the X-ray detected a right-sided pleural effusion. And look at the diet that he had during this period. He did not consume fish, meat, egg or curd. Obviously no vitamin D, not enough protein. Pulses too were very meager. The protein also was missing, other vitamins were missing. No fruits, vegetables only sparingly once in a while. Most of the time breakfast was just wheat and potato, the puri bhaji. What is puri? What is bhaji? Just carbohydrate. This is a popular breakfast in Kerala. We are not bothered about it. Lunch consisted of rice and one vegetable curry, and sometimes cabbage, sometimes only pulses. This is the kind of diet that we get in hostels, a doctor's hostel. Occasionally only the curry had pulses. Dinner was usually wheat and upma only, with some sugar or something like that. Only carbohydrate, no protein, no vegetables, no fruits. This is the kind of diet our hostels and hotels provide. You ask for vegetables and fruits, they will say we don't have it. With these problems, he got admitted. COVID was tested negative, luckily. If it was tested COVID positive, things would have been entirely different. It was in August 2020. And took an USG thorax and abdomen and a pleural tap was done. The fluid was exudative, CB naught was negative, but AD was 65. Cytology showed numerous atypical lymphoid blasts and other precursors with the macronuclei. And the report was suggestive of malignant pleural effusion, NHL to be ruled out. With this report, he was referred to the highest oncology center there in that state, where he remained admitted in August 2020. You can imagine the plight of that person, August 2020. CT thoracic detected a small lymph node, but an HRCT did not show any lymph node. They were planning PET scan and pleural biopsy, but dates were not given early because of the COVID lockdown and shortage of personnel. If in case he was positive, the story would have been entirely different. Anyway, all this happened without informing his family. His wife and kids were admitted in a COVID care center because of just asymptomatic COVID positive, not having any symptoms. All three being positive but asymptomatic. Neither he nor his family had unimaginable suffering and psychological trauma too. Finally, when the wife and children were discharged from the COVID care center with an asymptomatic positive COVID test. This is a criminal negligence on doctor's side. Asymptomatic COVID positive is not at all an important issue. They would have been managed at home. I don't know who gave that kind of ridiculous advice to the government. The patient traveled in a rented car and reached Calicut in August 2020 because he had no other way. Because no test is done, nothing is happening there. So his own decision, he came over. Because by the time they contacted me, I said, you come over, I will try to help. Anyway, the history was enough for me to make a firm diagnosis of tuberculous pleural effusion. I just ignored the malignant effusion. We should learn to ignore incidentallomas. This is one thing we should learn from clinical practice. After arriving at a clinical impression, you should look for supportive evidences. Do not depend on so-called gold standard laboratory test. So I actually examined this patient without wearing a mask in 2020. Nobody would have done that. I have been seeing patients from that day onwards without wearing a mask most of the time. This patient looked emaciated. He had no pallor, no herpes splenomegaly. He had features of butyl and vitamin D deficiency. Butyl deficiency you can easily find out by the knuckle pigmentation. Vitamin D you can diet history will give, but if it is severe, your Chaustrek sign will be positive. Manto test was not done because people think that it is not a good test. But in this patient, if it is strongly positive, it confirms tuberculosis. So I was confident of that. This was a hemogram. ESR was high, and you can see the high ADA was there. And finally, the findings substantiated the diagnosis of tuberculosis, ignoring the cytological finding. And I started him on ATT, and you can see the reports which came. Where was it? This was an X-ray chest, and this was a strongly positive Manto test. He recovered completely. This is August 2020. So if somebody had believed that malignant pleural effusion report, what could have happened to the patient? If he was COVID positive, what could have happened to the patient? Where is what is happening to our profession? This is a question. So why I was attacked during COVID? I have to tell it here at least now. Because 90% of doctors fail to acquire clinical skill. They fail to understand what I said. This was simply the reason what happened. I was contacted by several senior professors in medicine, saying that you had told something which we wanted to tell. They were confident I was right, but they had no courage to speak it out. Just because I tried to help the people, I was attacked. You don't know the trauma that I had gone through that time. I was compared to Vadakanjiri and Mohanan Vaidyar by some people whom other students respect. And all of them believed, because they also respected those persons. They used their official positions to abuse me. So the doctors with clinical skill all came with support. That is family doctors and internal medicine doctors who know clinical skill. We actually lacked humanness in that. Some people objected because they wanted to take sides for their own personal advantage. That is lack of humanness. It's also a bad quality for doctors. They forgot the objectives of treatment. Cure is possible only sometimes. People have forgotten the objectives of treatment. Once a patient comes as a patient, we have only 3 objectives. Cure sometimes, comfort often, console always. We are not here to stop all diseases, even if you do preventive methods. But once a disease develops, it should be treated as an accident. We are trying to save as if somebody is drowning. We will not succeed in saving all the persons who are drowning. So, the success in treatment is only limited. Cure is possible only sometimes, but comfort you can give by symptomatic treatment, and you can use always consoling words. This is all the objectives of medicine. Anyway, the people who criticized, I won't call them as doctors, because they failed to acquire the qualities of doctors. Asymptomatic COVID positives were tortured as patients during this COVID period. And this I forgot to tell. The most important sense lost is common sense, not taste or smell. The people who lost taste or smell had beta folic acid deficiency. That's why they had problems. It's not due to COVID. I had several patients who are on treatment for post-COVID syndromes. They all had beta folic acid vitamin D deficiency. And the heightened trauma and the stress of facing the problem. So this is what IMA and all the modern medicine doctors should now work for. Let us build a stable health pyramid. And at the base of it, let us also speak about making available all the social determinants of health to every individual to reduce the disease burden. Unless we reduce the disease burden, India has the maximum disease burden in the world. You may name any disease, we are number 1. We are not even number 2. With that kind of disease burden, the treatment machinery, the disease care machinery will not sustain. So let us first work on preventive measures. And that too will happen when there are family doctors, because family doctors are the only group of doctors with interest in wellness, health and wellness. Others will not have it. That is, by nature, their training is meant for that. Only family doctors will have interest in health and wellness. And that is where the Ayush is getting. Speak out health and wellness unscientifically. We can have a team of doctors speaking about health and wellness scientifically, and we will win over the confidence of the people. These people will be close to the hearts of the people. They can get the opinion of the people in favor of modern medicine. Why the hospitals are attacked, doctors are attacked? If the patient had come to the hospital after referral from a GP or a family doctor, they would not have attacked the hospital. Because there will be a mediation by the referring family doctor who is very close to the hearts of the people. So everything that you find is due to absence of family doctors in this society. So let us wake up and do something. The second component of this pyramid is primary care doctors, family doctors. All the doctors sitting in PHCs and CHCs should be trained family doctors. Let us work for that. Thank you for the patient listening. Any questions or comments? Okay, but I don't mind.
Since it's an oration, there is no question, sir. Thank you, sir, for the wonderful talk. I invite Dr. Ajit Bhaskar, State Secretary, PEPS, to hand over the memento to Dr. PKS. Okay. Now let's go to the session 3. I invite the chairpersons, Dr. Bushna, pulmonologist, ICRA Hospital, Dr. Vinod, cardiologist, ICRA Hospital, critical care medicine. He's a teaching experience. He's a senior faculty and guide for DPNB from 2010 onwards. Speaker for Calicut Chess Club and Association of Pulmonology and Critical Care Medicine. Spoke on management of sepsis in All India APPCM held in Thrissur in 2019. He had done sessions in asthma and comorbidities in All Kerala Chest Physicians Meet held in Malappuram in 2019. Over to you, sir.
Thanks for nice words. Respected senior members of the profession, dear friends and chairperson, of course she is my student, and I will be talking on chronic cough. And at par with the inputs I have received from my previous speaker, I will be talking on the clinical skills or clinical inputs and not too much on investigations and treatment. Cough, you know, it's a symptom which make you aware that the patient is suffering from some sort of abnormality. It's a major respiratory symptom and it's a major symptom perceived across the practice of general practitioners. It can give you insight into a diagnosis like a trivial things like common cold or a worse things like carcinoma bronchus. We need to see some definition. The chronic cough is which one lasts for more than 8 weeks. Subacute cough is lasts for more than 3 weeks. It's the 5th most common symptom seen in the outpatient clinics. The patient often presents with cough complications like sleeplessness, hoarseness of voice, pain, etc. This discussion provides a brief review of common causes, evaluation techniques, and treatment of common cough symptoms. The chronic cough physiology. The cough is a result of a reflex phenomenon. The cough receptors are present inside the thorax, inside the bronchial tree, trachea, larynx, pleura, upper part of stomach, inside the paranasal sinuses, nasal mucosa, and inside the ear, pericardium, diaphragm, and stomach. The mechanical and chemical cough receptors are there. Mechanical cough receptors are stimulated by the touch or displacement or the tactile stimulus or a displacement of the organ concerned. Chemical receptors respond to noxious stimulus like chemical gases or fumes. The laryngeal and tracheobronchial receptors respond both to mechanical and chemical stimuluses. There is a sex-related difference in the reflex sensitivity of cough. That is why women are more likely to suffer from cough more than men. The major causes of chronic cough are postnasal drip, asthma, gastroesophageal reflux, chronic bronchitis, bronchiectasis, and there are miscellaneous causes as well. Other causes of chronic cough are post-infectious causes, both bacterial and viral, complication of drug therapy like antihypertensive drugs like AC inhibitors, airway disorders, chronic bronchitis, bronchiectasis, bronchial and pleural neoplasms, foreign bodies. We need to elaborate on that because that is one of the symptoms in pediatric patient with the cough comes to you. You have to suspect a foreign body. Not in all cases, suppose all other causes. Parenchymal lung disorders like ILD, lung abscesses, and chronic infections. Chronic infection is good, tuberculosis as well. Cough and postnasal drip, now it is called UICS, upper airway cough syndrome. Underlying reasons for postnasal drip include allergic non-allergic and vasomotor rhinitis, acute nasopharyngitis and sinusitis. These are ENT causes. The postnasal drip include frequent discharge, a sensation of liquid being trickled down in the back of the throat, and frequent throat clearing may be the only symptom. The physical examination or the examination of the oral cavity shows that there is a cobblestone pattern in the posterior pharyngeal wall, nasopharyngeal mucosa as well. Most of the cases in postnasal drip response to therapy secure the cause. Depending on the cause, like suppose patient is having allergic rhinitis, a nasal spray would do, and an antihistaminic. And suppose the patient has sinusitis, the treatment with an antibiotic and supportive measures will do. Non-pulmonary causes in the ENT perspective are GERD, neurogenic cough after the viral and post-viral and post-bacterial infection, which is caused by vagal neuropathy, asthma and allergy. Asthma included in the ENT diagnosis as well, because this can coexist. What is called a single airway disease. Allergic rhinitis and asthma now being considered as a single airway disease. So in the ENT practice, asthma, allergy, sinusitis and postnasal drip, aspiration due to glottic insufficiency starts from the pediatric age group, and in the elderly, neuromuscular disability might suffer from glottic insufficiency. The use of AC inhibitors and Senger's diverticulum. The post-viral vagoneuropathy is a very important cause of cough that is being perceived in recent times, because after the COVID and we had a flu pandemic, which is now going on in the recent times. It comes with a very severe cough, this intractable cough. This is due to the damage of the vagal nerve branches, and there are aberrant regeneration of the fibers after neuropathy, which may result in vocal cord paresis and other motor and sensory dysfunction. Laryngopharyngeal reflex is often associated with this vagal neuropathy. So this has become a common day occurrence nowadays. The cough variant asthma is a very important differential diagnosis for cough. It occurs in people who had atopic history. It can run during season, may or may not associate with an upper respiratory infection. The pattern of the cough or the aggravation with the triggers and relief with the bronchodilator are the clues to fetch a diagnosis. And you have investigations like pulmonary function test, spirometry, which in most of the times may be normal. In such cases, you need a bronchoprovocation test with cholinergic agents, atropine or methacholine, which clinch a diagnosis with reversibility with a bronchodilator, a SABA, short-acting bronchial agonist. Best ways to confirm cough as a cause of cough variant asthma is to give treatment and see the response. The cough due to GER. The many patient complained the classic symptoms of GER like belching, heartburn in patients who have gastroesophageal infections. But unfortunately, these symptoms are absent in many of the patients. They come with cough only. The cough in GERD is due to aspiration of gastric contents, stimulation of laryngeal receptors, and esophageal tracheobronchial cough reflex exists. This is because of in the developmental stage, the esophagus and trachea shares a common origin from the meson, foregut. They have a common foregut origin. The diagnosis by esophageal pH monitoring and the comparison with the events or the performed with the event markers, and this diagnosis this gives you the diagnosis of gastroesophageal reflux as the cause of cough. But in this case, you need to consider an associated asthma also. Most of the GER can occur with a diagnosis of asthma as well. Respiratory tract infection and chronic cough. The most commonest chronic cough origin is from tuberculosis. You need to consider tuberculosis. Any patient with history of more than 6 weeks or 6 to 8 weeks of cough, you have to mandatorily do an X-ray or mandatorily do sputum AFP. Suppose you think that X-ray is normal, it doesn't show any evidence of tuberculosis, still you can check for, because there is something called endobronchial tuberculosis. The mechanism of cough in chronic infections include upper respiratory secretions, enhanced sensitivity to airway nerves, airway hyperresponsiveness. This is not in analogous with what we call bronchial asthma, but you can have an analogy with bronchoconstriction. What is bronchial hyperresponsiveness is the abnormal response of the bronchial muscles to a stimulus, which includes cold air, stress, or talking, coughing, certain exposure to certain smell and smokes, which all can result in airway hyperresponsiveness. That need not be a case of asthma. The common bacterial organisms are Mycoplasma pneumonia, Chlamydia pneumonia, and Bordetella pertussis, especially Mycoplasma pneumonia and Chlamydia during a monsoon season. Bacterial suppression, large airways like bronchiectasis or empyema or lung abscess can become a cause of chronic cough. Cough and non-asthma eosinophilic bronchitis is a very interesting entity. The patient is having an eosinophilic bronchitis, which you can make sure from taking a bronchial shows the bronchial mucosa embedded with eosinophilic material. But in such function and the diagnosed asthma may be difficult to obtain. This is an entity which is separate from asthma. And suppose you follow up patients, 55% remains symptomatic with a normal lung function, 32% were free of symptoms, and 13% go on developing asthma. Cough and lung cancer. The lung cancer is the most dreaded diagnosis after you analyze a symptom of cough. The cough which originates from nowhere, or suppose the patient had a cough, what we call smoker's cough. If there is a pattern in the cough or frequency or the severity, you have to suspect. For that matter, any smoker who comes with a cough, you need to take an X-ray so that you may be able to pick up diagnosis in the early stages. And we have in our practice seen lot of patients who are non-smokers and young female, even young females, patient age as young as 30-year-old had bronchogenic carcinoma. So, for a chronic cough, an X-ray is not a too expensive tool, and you should make it mandatory. And a hemoptysis which occur in a setup where there is no airway infection, also you have to think about airway malignancies. Now I am going on to the treatment part. Drugs used for the treatment of cough it can be categorized into treatment aimed at the underlying disorders, which is reported to be successful in 95% of cases. Therapy or the cough suppressants, which is limited in cases where cough serves no purpose and you don't have a very diagnosis. There are cough suppressants, centrally acting antitussives, peripheral antitussives, cough expectorants, antihistamines, and bronchodilators. All are being used in conjunction or alone in the treatment of cough. Cough suppressants there are centrally acting antitussives like narcotic substances like codeine, folcodeine, and hydrocodone. Non-narcotic like dextromethorphan, levothyroxine, noscapine, and non-opiates like diphenhydramine and benzoate. The peripheral antitussives are demulcents like Linctus, lozenges, licorice, and inhalation like water or aerosol inhalation, benzoin, menthol, local anesthetics like benzocaine, lignocaine. Cough expectorants are the drug acting reflexively like ipecacuanha, ammonium chloride, potassium iodide, drugs acting directly like potassium iodide and guaifenesin. Mucolytics are acetylcysteine, bromhexine, carbocysteine and methylcysteine. The definition of a mucolytic and expectorant: mucolytic is a mucolytic agent. It's a drug that breaks down the thick mucus, making it thinner and easier to cough out. The very good example is steam inhalation. Another one is DNA is acetylcysteine, etc. N-acetylcysteine. Expectorant is a drug which makes the cough more productive by loosening and liquefying the bronchial secretion. Antitussives are substances that specifically inhibit the or suppresses the action of cough by acting on the cough center. The increases the threshold of the cough center, indirection of the afferent impulses from the periphery to the cough centers, inhibition of conduction along the motor pathways, and which acts on the efferents. Narcotic the better example is codeine, which is an opium alkaloid similar to morphine. A small percent of it is converted into morphine in the body, which accounts for the analgesic activity of the codeine. Codeine, when used carefully or in a indicated cases, a very good antitussive drugs. Usual dose which is being prescribed is 10 ml of that is, but you can manage with even 15 milligram of the codeine. It is useful because the side effects like sedation and constipation are less when used the 15 milligram dose. The mode of action, it directly suppresses the cough center, suppresses the cough for about 6 hours. Others in therapy produces minimum side effects like sedation, nausea, constipation. Higher doses may even lead to respiratory depression. Though you have to use it in patients who have asthma, patients who have COPD, patients who are elderly, and patients who are mentally or challenged with the CNS diseases. Non-narcotic drugs are dextromethorphan. It's a synthetic compound. It's a strong and partial mu agonist. It is almost as effective as codeine, but I don't watch for that. It is less effective than codeine. The control cough spasm by depressing cough center in medulla increases the threshold of coughing. It's good. Advantages are does not have any effect on ciliary activity, no CNS depression, no addiction potential, no constipation. Dosage is 15-30 milligram, 3 or 4 times daily. Toxic doses may cause stupor, ataxia, respiratory depression, convulsion, and even it can lead to death. And that is why this drug is banned in United Arab countries. Gulf countries, this drug is banned. Noscapine is an opium alkaloid which is being used frequently and available. It's a non-narcotic. It is equally effective and less problematic than codeine. Useful in spasmodic cough. Headache and nausea are the usual side effect. Nausea is a major side effect. It is contraindicated in asthmatic patients. Benzoate is a chemically related tetracaine. It is a local anesthetic. It has central effects, but this is useful in people who are having distressing cough despite of being treated with many of the other drugs. Expectorants I already mentioned. They increases the sputum volume by loosening and liquefying bronchial secretion and make the patient get rid of the tenacious sputum. Guaifenesin is a derivative of glycol. It is a synthetic or natural origin. It decreases sputum viscosity, but it can cause nausea. That nausea and gastritis. That is the most important side effect of the guaifenesin. These are not being used now. Mucolytics, I have told that mucolytics are most important mucolytics N-acetylcysteine, and this disrupts the protein binding in the sputum and make it less viscid. Useful in cases like lung abscess, bronchiectasis, where COPD, where the tenacious and thick mucus secretion or the sputum is a bromhexine, previously used, not now being used. It's a derivative of what we call is found in, it's a synthetic analog of what we found in analog, but it's not very useful nowadays. Bronchodilators, of course, where it is indicated, if there is a bronchoconstriction or a bronchial hyperresponsiveness, you have to use bronchodilators with or without a small dose of steroids, which can go a long way in treating and preventing cough in the future times. Special conditions in cough may be useful or useless, but there is no role of antitussidic asthma, young infants, congestive cardiac failure, COPD, tuberculosis, in which there may not be any role for your bronchodilator unless you initiate the treatment for the underlying diseases. The antitussives may be prescribed for dry, unproductive cough that is hazardous or is disturbing sleep, in whooping cough or pertussis. Thank you for a patient listening, and I am any question, and my chairperson is my student, she could assist me. She is DM in pulmonology. Thank you.
Thank you, sir, for the wonderful talk. As sir already described, we have a lot of courses for cough, and evaluating cough is like solving a puzzle. So while evaluating cough, we should have a broad approach for evaluating cough, especially as our previous speaker told, we should properly elicit the history. We should have a proper clinical skill to come to a differential, and then treat the cough accordingly. It's like all cough are not to be treated in the same manner, as it's already discussed. So now the topic is open for discussion.
I have omitted important diagnosis because I wanted to invite questions. This is what is called tropical hysteria. This is a condition which was diagnosed in previous times, now being diagnosed also as a cause of chronic cough. But it is becoming less, maybe due to the vector control, maybe due to the treatment with heterosan. This is a curious condition in which bouts of cough occurs, and the eosinophils are always on the upper side, more than 10 to 14, and get a good response with antiviral drugs like heterosan and anti-worm drugs, anti-helminthic.
Any more questions, please? Okay. I invite Dr. Mustafa CP over the memento to Dr. Sudhir Kumar. I invite Dr. Sandhya to hand over the memento to our chairperson, Dr. Bushna. Now going on to the next session, I invite Dr. Arun Gobi, consultant electrophysiologist and interventional cardiologist, MICC. He's a well-known speaker, especially for us IMA Kozhikode. Already we had an interesting online session with him. I welcome you, sir. I also invite the chairperson, Dr. Vinod, consultant cardiologist, ICRA Hospital.
At the outset,
A warm good afternoon to all, and thanks organizers, especially Sabina, for the opportunity. I understand I'm standing between the hypoglycemic brains and the lunch that is due. So, and this is not a topic I'm pretty sure you would all want your brains put in, because electrocardiogram is a small strip of paper which still actually fascinates us. After years spent in cardiology, we still understand the minuscule of knowledge we have about what information this strip of paper gives in. I'll try to make sense of about the next 30 minutes what a practitioner should be looking at in the ECG. So this would be the format of my talk. We'll go through how a basic electrogram is recorded in, and with some intertwining case histories. So essentially, in a nutshell, electrocardiogram depicts the summated electrical activity of the heart on a strip of paper and gives enormous information on both cardiac and extracardiac disorders. So it looks at where the impulse originates from, through where all the impulses transmit in the heart, and where it finally reaches, and how the electrical activity translates into a mechanical. Any deviation from this leads on to various problems, and all of this information is given by an electrocardiogram. The specialty that I deal with, electrophysiology, we put in catheters inside the heart, again record electrical signals from the heart, which we call electrograms. Finally, we also correlate this information with the surface ECG and understand what is going wrong in various rhythm disorders. So before understanding or before trying to decipher what the ECG gives you, taken properly, you all know that there are the standard limb leads, the augmented and the modified chest leads. Augmented limb leads, again unipolar, measuring electrical activity between one limb and the single central Wilson's terminal, which are unipolar electrodes. And the precordial leads, I think you should have this paper stuck in your ECG room, because each technician should know where the electrodes have to be properly placed before you really start analyzing the ECG that is given to you. So it should be properly taken before you analyze them, because the precordial leads actually give you a cross-sectional information of what is happening on the electrical axis, on the horizontal axis. And in particular scenarios, like in inferior wall MI, if you want to know what is happening with the right ventricle, you can place in additional leads, like this is a V4R which is being placed. You place exactly on the right side, sorry. Okay, so you place exactly the electrodes, the V4 electrodes, on just mirror image of where it is placed on the left side, on the right side of chest. And in a particular situation like an inferior wall MI, if you want to look what is happening on the posterior wall, you have additional leads like V7, V8 or V9, which is placed on the posterior axillary wall, scapular line and interscapular place. So just a case vignette, one of our practitioners referred this case to us, asymptomatic male, 53 years, as PK is told, he thought it's time for a checkup. He took a routine ECG, went to the nearby practitioner, and he was fascinated by what is happening in this ECG. He thought there's something abnormal. He's a symptomatic person. Everything looked okay, but he picked up that everything, you look at lead 1 and lead AVL, everything looks inverted. P, Q, R, S, T, everything is inverted in lead 1 and AVL, and he thought there's something going wrong. And he referred this patient who is asymptomatic, just went for a health checkup for the further cardiac evaluation. A further look at this ECG at our place, this is what is happening. So essentially this was an ECG which was not properly taken. It was essentially a right arm, left arm lead reversal, or what we call a wrongly placed right arm and left arm electrodes. So if you place the right arm and left arm electrodes in the opposite way, you have everything inverted in lead 1 and AVL. So you have P, QRS and T, everything inverted in 1 and AVL, but a normal precordial transition in the precordial leads. And if you ensure that the leads are properly placed in the right arm and left arm were just interchanged, and you can see that it essentially is a normal ECG. So before putting too much of brains on analyzing what is going wrong in the ECG, ensure that it is properly taken. So we send him back saying that everything is fine. So next time our practitioner sends in another ECG, he says, this 31-year-old has come for us. He went for obviously for a job interview and had to have a medical done in, and he comes with this ECG. So he sends this ECG again to us saying that, so see here, I feel it's a lead reversal. I kept again the leads properly again, but it still looks the same. So he sent this ECG again to us, similar ECG, P wave inverted, QRS inverted, lead, but lead T, the T wave is upright in lead 1 and AVL, but P and QRS were inverted in 1 and AVL, and he thought it's lead reversal, but despite putting the leads correct in again, he found the same thing. But what he missed out was on the precordial leads, the information that precordial leads were giving in. You can see that the V1 has a positive R wave, and there is a decline in the R wave amplitude from V1 to V6. So this is essentially a case of dextrocardia. So wherein you have P, QRS, and T wave, which is inverted in lead 1 and AVL, a right axis deviation, but essentially a positive R wave in V1 with a reverse progression of R wave amplitude from V1 to V6. And this is one scenario where a ECG correlation with your surface X-ray would give you, clinch the diagnosis. And if you want to understand what is going wrong in a dextrocardic heart, you should have all your electrodes placed on the right side of the chest. This is another case which was referred to our casualty by another practitioner. This patient, 62-year-old, reactive airway disease, just had exertional dyspnea, but took an ECG, and the practitioner who first found the ECG found something sincerely wrong, and he thought this patient required emergency attention and was referred to a casualty. Patient is otherwise clinically stable. So essentially what was going through in his mind was this looks, all the QRS amplitudes look low. So essentially, by definition, when you say a low voltage complex, it is defined as less than 5 millimeters in the limb leads or less than 10 millimeters in the precordial leads. And when you have such a finding, you think of various possibilities, like why does the QRS voltage go down? It is because of if there's something in the media where transmits the electrical impulses from heart to the electrode. So if you have a person who is morbidly obese, who has significant airway disease, pericardial effusion, all those things can give rise to a low amplitude, or a significant myocardial disease like dilated cardiomyopathy or extensive myocardial ischemia can give rise to low voltage complexes. So our practitioner thought this patient had some of these things and wanted further evaluation, and this patient was referred to us. Look at the ECG again. There are some numbers which are printed at the bottom base of the ECG. These are not just numbers. You need to look at all these things before you decipher the ECG again. So the standardization in this ECG was 1.25 millimeter per millivolt. I don't have a pointer, so that's why I'm not able to show that. It's 1.25 millimeter per millivolt, which is not the standard standardization. The standard standardization should be 10 millimeter per millivolt. And when an ECG is repeated with a standard standardization, this is the ECG of the same person. So all these things, you should take the information that before you decipher what is going abnormal on the ECG, ensure that it is properly, the electrodes are properly placed, the standardization is proper, and then go on analyzing the ECG. And this strip of paper gives a lot of information on the electrical depolarization, on the myocardial health, on the conduction times. And so we all know that we need to understand what each of these waves denote to understand what the pathology is going on. So we all know that the impulse in a normal heart starts from the sinus node. So the electrical impulse starts from the pacemaker of the heart, that is the sinus node. Unfortunately, the sinus node depolarization is not depicted on the ECG. So whether the sinus node is activated or not, you just cannot get any information of that on the ECG. But from the sinus node, the impulse goes to the right atrium and then subsequently to the left atrium, and that is denoted by the P wave. So the first half of P wave denotes electrical depolarization of the right atrium, and the second half of the P wave denotes electrical depolarization of the left atrium. And a normal P wave, for simple terms, remember that it's 2.5 small boxes in height and 2.5 small boxes in width. And it is positive in leads 1, 2, AVF to V2 to V6, and negative in AVR in normal sinus rhythm. So in a person who has a left atrial enlargement, you know that the second half of the P wave should be abnormal, because that second half of the P wave is what is denoting left atrial depolarization. And so typically in such a scenario, the P wave will be broad and notched, what we call P mitral. That indicates the P wave duration would be more than 3 small boxes. So this is the typical P mitral. You have the P wave, which the duration of the P wave is more than 2.5 small boxes. On the other hand, if the right atrium is enlarged, the initial part of the P wave should be abnormal. And so if the initial part of P wave is abnormal, you would be having a P wave which is taller and peaked. That's what is called a P pulmonale. So the P wave amplitude would be more than 2.5 small boxes, as shown in this ECG. So the P wave is peaked. in a P pulmonale or right atrial enlargement, and P wave is broad in a left atrial enlargement or in a P mitral. And when you have both of these, a broad and tall P wave, it indicates biatrial enlargement. So understanding on the P wave, the first half is right atrium, and if the right atrium is enlarged, the P wave has become peaked, and if the second half of the P wave is left atrium, and if the left atrium is enlarged, the P waves become broad. Similarly, the P wave also gives you information on how the atrium is depolarized, like an inverted P wave indicates that the atrium is depolarized from the AV junction. And if the P wave is absent, it indicates either a sinus nodal arrest or a junctional rhythm. From the atrium, the electrical impulse actually reaches the AV node, which is a slowly conducting tissue. And so there is a finite delay in conduction from the atrium to ventricle, which is depicted by the PR segment on the ECG. So the PR interval actually denotes time from the onset of P wave to the beginning of QRS, and normally is 3 to 5 small boxes. So each small box is 40 milliseconds. PR interval is from the beginning of P wave to the beginning of QRS, and it should be 3 to 5 small boxes. Any conduction disease in the AV node will show a prolonged PR interval. It can be because of drugs or electrolyte disturbances. And in a scenario, in a congenital scenario where you have an accessory pathway, which we call a Wolff-Parkinson-White syndrome, normally the only electrical connection between the atrium and ventricle is an AV node. But in some people, they have an accessory pathway connecting the atrium to ventricle, which we call an accessory pathway, a bundle of Kent. These patients have a short PR interval, as shown on the left-hand side. They have a very short PR interval, a slurred upstroke of the QRS because the initial part of depolarization, the myocardium, and a QRS which is wide because the ventricle is activated via both the accessory pathway and the native conduction system. So we have this triad of short PR interval, a slurred upstroke of QRS, which we call the delta wave, and broad QRS, which forms the triad of an entity called as Wolff-Parkinson-White syndrome, which is seen typically in younger individuals. Subsequently, from the AV node, the impulses go through the bundle of His, which is a rapidly conducting tissue. So you see the ventricular depolarization is simultaneous. Right ventricle and left ventricle depolarizes simultaneously. On the other hand, in the atrium, the right atrium depolarizes first, followed by the left atrium. But on the ventricle, the activation happens from the central axis, from the interventricular septum. Simultaneous depolarization of right ventricle and left ventricle, and it happens through rapidly conducting tissue, which is Purkinje system, and that is why you have a QRS which is narrow and sleek for such a large myocardium in the ventricle. And so QRS denotes ventricular depolarization and gives a lot of information on the myocardial health in the LV and RV myocardium, as well as the conduction system. So if you have a QRS duration which is more than 120 milliseconds or 3 small boxes, it indicates that the conduction system is diseased or there is extensive myocardial disease. Similarly, if there is a myocardial pathology like an infarction, it causes an electrical window. Through an infarction or a scar, the electric current does not pass, and it leads to what we call a pathological Q wave. By definition, a pathological Q wave by numericals is a Q wave whose amplitude is more than 1/4 of the parallel R wave amplitude, or more than one small box in width. So if a Q wave is more than one small box in width and is more than 25% of the parallel R wave in the similar lead, it's a pathological Q wave. And it indicates myocardial infarction or an electrical window in the left or right ventricle. Why do QRS sometimes you find suddenly a broad QRS in a person? So a narrow QRS essentially comes because the depolarization of each of the ventricle is simultaneous from the central axis and happens through very rapidly conducting tissue, that is His-Purkinje system. So if you have a conduction system which is diseased, like if the one bundle branch is diseased, then the ventricles get depolarized sequentially. So if the right bundle is diseased, the left ventricle gets depolarized first, and then subsequently the right ventricle gets depolarized, and that leads on to a broad QRS. So that's what typically happens with bundle branch block, like the typical right bundle branch block or the left bundle branch block. Similarly, the QRS also gives you information on the myocardial health. Like a person with right ventricular hypertrophy, since V1 is a right anterior lead, in people with right ventricular hypertrophy, they will have a prominent R in V1 with an R wave amplitude more than 5 millimeters and an R by S ratio being more than 1. In people with, this is an ECG of right ventricular hypertrophy, you can see a very prominent R in V1. Just look at R in V1. If it is more than S wave, it indicates right ventricular hypertrophy. In a people with left ventricular hypertrophy, essentially you are looking at left ventricle ensures maximum amount of myocardium in the heart. And so if people have a left ventricular hypertrophy, the voltages are going to be very prominent. There are many criteria for this. Just remember, look at S in V1 and R in V6. If the sum of both of these is more than 7 small boxes or more than 35 millimeters, it indicates left ventricular hypertrophy. And there are numerous criteria for this. Just look at S in V1 and R in V6. If some of these things make up 7 small boxes, or each of the, if you're looking at smaller boxes, 35 millimeters, that is 35 small boxes, it indicates left ventricular hypertrophy. Essentially, they will have very prominent voltages, and by one look, you can say whether the person has left ventricular hypertrophy or not. After the QRS comes the plateau phase of repolarization, that is the ST segment. This gives a lot of information on the repolarization phase, and the J point denotes the junction between the QRS and the ST segment. And J point ideally has to be isoelectric. So if there's a more than 0.5 millimeter depression or more than 1 millimeter elevation in the ST segment, they are pathological. This is one of the cases referred to us by a practitioner saying that this is a 38-year-old with a lot of ST changes. He was suspecting a coronary syndrome, and he was referred for immediate coronary evaluation, including a troponin. Just look at what drugs he was taking. This person was on a drug called digoxin. And we know that a lot of drugs affect the ventricular repolarization. And what you see on these ECG are all telltale signs of digoxin. Typically, the reverse tick sign. There are numerous things that are seen with digoxin and various other drugs on the ECG. But digoxin actually causes the downsloping ST depression, a flattened or biphasic T waves, a short QT interval, mild PR prolongation, a prominent U wave. The take-home message is various drugs can also have impact on your resurface ECG, and before commenting that these changes are because of ischemia, ensure that they are not on drugs which affect the ventricular repolarization. And after ST segment comes the ventricular repolarization, the rapid ventricular repolarization, that is a T wave, essentially has to be upright in lead 1, 2, V3 to V6. And it also denotes various pathologies, like when you have a tall tended T waves, it may be electrolyte disturbance or myocardial ischemia, or if you have inverted T waves, it might indicate myocardial ischemia. A 16-year-old referred to us with this kind of ECG. History is the person has glomerulonephritis. The junior resident just took an ECG. This is a ECG which should be worrying for any junior resident in pediatrics or in any other place, because this is very typical of hyperkalemia. This is an electrolyte disturbance, if not treated in time, can be fatal. This is a typical sine wave of hyperkalemia. So essentially, one electrolyte disturbance which has a one-on-one correlation with the ECG is hyperkalemia. Normal, as you all know, is less than 5.5. The moment it becomes more than 5.7, you have tall peak T waves. After that, you have a reduction in the P wave amplitude. P waves become absent. QRS starts widening. And once it becomes more than 10, you have ventricular fibrillation and arrest. So essentially, you have, these are the changes of hyperkalemia: peaked T waves, very tall peak T waves, flattened P waves, peaked T waves, flat P waves, prolonged PR interval, ST depression, and a widened QRS with merger of QRS and the T wave, which we call the sine wave or the sine wave of hyperkalemia. So this was another person referred to us with an abnormal ECG. He's asymptomatic. I look at his ECG and taking a history again back, as Dr. Shaziran said, it's always important that a lot of diagnosis clinch on history alone. He was recently started on telmisartan, which is a ARB. And check at his potassium, he had hyperkalemia. So all those tall prominent T waves that he had were typical of hyperkalemia. Hyperkalemia typically causes a narrow-based, pointed, tenting T waves that you see on the left side, while hyperacute ischemia, acute myocardial infarction, can also cause prominent T waves, but they tend to be broader, symmetric, and the QT slightly tends to be longer. So hyperkalemia essentially has prominent T waves which are narrow and peaked, ST segment which goes down, QRS which broadens, P wave which diminishes in amplitude, and PR which prolongs. And finally, you have the sinus wave. And then comes the last part, that is QT interval, which is a combination of both ventricular depolarization and repolarization. The normal duration is somewhere between 360 milliseconds to 440 milliseconds. You need not go by all these numbers. If you have a surface ECG, look at 2 R waves. And if the QT interval, which is from the beginning of QRS to the end of T wave, if the QT interval is more than 50% of the RR interval, it clearly is a sign that the person has a prolonged QT interval. So prolonged QT interval again is a marker of electrical inhomogeneity and can be a front runner of what we call a polymorphic VT, typically known as Torsade depointers. So this is a young kid treated as seizure disorder for many years, never took an ECG, seen by repeated various neurologists. One of the pediatricians had the courtesy to take an ECG, and this is simple long QT syndrome in a young child, which is a congenital channelopathy, which typically presents as recurrent loss of consciousness, which was being treated as seizures. So ECG was a game changer in this kid. Once you had the ECG, it was typically a long QT syndrome. We just had to start beta blockers and no recurrence of syncope after that. U-wave indicates repolarization of Purkinje system and would be prominent in people who have hypokalemia and hypercalcemia. ECG interpretation, essentially, you should always be systematic. Look at the rate, look at the rhythm, go sequentially from P wave, PR interval, and QRS. So you should understand the grid. Each small box on the horizontal axis indicates 40 milliseconds or 0.04 second, and large box indicates 0.2 seconds, while each small box on the vertical axis indicates 0.1 millivolt and one large box indicates 1 millivolt. So if you want to look at heart rate, because this is the first step in an ECG, you go by the rule of 300, look at the number of large boxes between 2 RR intervals, and then there are some numbers you can remember. If there are just 2 large boxes between 2 RR interval, the rate is going to be 150. If you have 3 large boxes, it is 100. 4 large boxes, it is 75, and 5 large boxes, 60. So look at 2 RR intervals, look at the number of large boxes between them, and just divide 300 by that. And remember these numbers, 150, 100, 75, 60, 50, and 43. And that gives you a rough count of the heart rate. But this is possible only in a person who has a regular rhythm like this. So you have, just look at the RR interval, look at large boxes. So here you have 5 large boxes, you have 6 large boxes, and so the heart rate is clearly 50. But if there's an irregular rhythm, this is not possible. In those cases, look at what you call the rhythm strip. So on the baseline of the ECG, you have a rhythm strip which runs for 6 seconds. So just count the number of QRS in the rhythm strip. So this QRS, this is the rhythm strip. So rhythm strip is essentially for 6 seconds. You look at, you count the number of QRS in the rhythm strip. So here you have 7 QRSs, and just multiply it by 10, that gives you the heart rate. And so this is the way you can use it for calculating the heart rate in a person who has a varying RR interval. This is another person who was referred to us with a slow heart rate for an immediate pacemaker implant. 56-year-old asymptomatic, slow heart rate. All ECGs show slow heart rate. But what was missed was actually the paper speed. This ECG was actually recorded at a paper speed of 50 millimeter per second. And that is why the person was wrongly diagnosed as bradycardia. Once the ECG was recorded at the correct speed, you understand that the person essentially has a normal heart rate. These are again nuances on how the ECG is recorded. These are important. These are things which show the importance of these numbers which are denoted on the lower half of the ECG strip that you are looking at. Again, this is a no-brainer which was put as an MCQ question for the practitioners. Which ECG shows the highest heart rate? Essentially, everybody would think that the first ECG shows the highest heart rate, but it's all the same ECG recorded at different speeds. Regularity again is just looking at RR regularity. Sometimes these cases get referred as atrial fibrillation. This was a young guy referred as varying RR interval and referred to us as atrial fibrillation. But essentially you look at the RR variability, it is not significant enough. This is nothing but what we call a typical sinus arrhythmia, where you have an acceleration of heart rate during inspiration and slowing of heart rate during expiration. Typically a physiological thing and nothing abnormal in that. I'll just conclude off before I stop with the most common clinical syndrome that you should all pick up on your general practice, that is looking for ischemia in ECG. So the telltale signs of ischemia are tall, prominent T waves, as I said, hyperacute T waves. Sometimes they may be flattened, and in unstable angina, they may be inverted. You may also find significant ST depression, which as I said, more than 0.5 millimeter ST depression is significant, and more than 1 millimeter ST segment elevation is considered significant. Typically, the first change would be a J point elevation with a prominent hyperacute T wave, which we call the hyperacute T wave of MI. Subsequently, you have the ST segment getting elevated and the T wave getting inverted. And finally, later on, as the MI evolves to an infarct, you have the Q wave, which indicates myocardial necrosis. Again, you also need to look at reciprocal changes on the leads which are opposite to the leads that you're looking at. Like, whenever you're looking at an ischemia or infarction, the anterior leads, you're essentially saying the changes in lead V1 to V4. 1 AVL, V5, V6 indicate lateral leads. 2, 3 AVF indicate inferior leads. So when you have an ST segment elevation in lead 2, 3 and AVF, you're looking at inferior ST elevation MI, and V1 to V4, you are going to look at reciprocal changes. So in a person like this, when you have ST segment elevation in V1 to V4, you are looking essentially at an anterior wall myocardial infarction with an occlusion in the left anterior descending artery. In a person like this, when you have ST segment elevation in 1 AVL, V5, V6, you are essentially looking at a lateral wall MI with an occlusion of probably the left circumflex artery. And in a person like this, when you have ST segment elevation in lead 2, 3 and AVF, you are essentially diagnosing inferior wall MI, and you are looking at either left circumflex or a right coronary artery occlusion. Again, along with left circumflex occlusion, you will have changes in V1, V2 and V3, which indicate posterior wall infarction. So you will generally have reciprocal changes there. So you will have a very prominent R wave in V1, which is actually a surrogate marker of a Q wave in the posterior lead. And you have significant ST depression, which is a mirror image of the ST segment elevation that would be seen in the posterior leads. All inferior wall MI, you should always take the right-sided leads that I said earlier, because 40% of inferior wall myocardial infarctions would have concomitant RV myocardial infarction. And you should always look at the rhythm, whether they have a AV conduction abnormality. This person, referred by again and the practitioner with ST segment elevation, needs immediate angiogram. He's asymptomatic, echo is essentially normal. This is actually a further look at this ECG. We repeated the ECG. So for all ECG changes, always in ischemia, look for serial ECGs. This ECG is after 5 hours, no change in the ST segment elevation. The prominent hyperacute T waves look just the same. This is a benign entity which we call early repolarization abnormality, which has a prominent hyperacute T waves, like a prominent T waves, and a concave ST segment elevation with preserved R wave amplitudes and absence of Q waves. It's a very benign entity, needs no intervention and only reassurance. It's very common in young individuals. On the other hand, this was another lady presented with severe diaphoresis, had breathlessness. ECG for us looks very sinister, but the initial referring practitioner said, looks like having ST depression, but this is an ECG which should be a eye-opener, because if you see extensive ST depression, this is the MI which has maximum mortality. This person, if you look at all the ECGs, there's extensive ST depression across all the leads, and ST segment elevation only in 2 leads, AVR and V1. These are the most sinister leads which can have ST segment elevation, because when you find this pattern, global ST segment depression and ST elevation, AVR and V1, this person has the maximum mortality, because this indicates an acute left main occlusion, and if not treated in time, is 100% fatal. So extensive ST depression sometimes connotes more pathological abnormality than an extensive ST segment elevation, which was seen in this case. So this person was referred to us saying that this person has ST elevation in all the leads. He should be taken for cath immediately. But this is actually, if you look at this ECG, he has extensive ST segment elevation in all the leads, but there is no reciprocal changes. There is a concomitant PR segment elevation. There is actually ST segment elevation in both the anatomical territories, both the inferior and the lateral territories. And there is a telltale sign which is a PR depression. So this is very specific of pericarditis. So extensive ST segment elevation in all leads in different vascular territories is actually a telltale sign of pericarditis, which is a benign entity and does not need any other intervention. This is again an ECG which do not indicate much of pathology, but this ECG, this person had severe angina. Why I am putting up this ECG before I conclude is, this ECG doesn't show much of changes, but a closer look, it will indicate that there is a upsloping ST segment depression in precordial leads and a very prominent T waves. So an upsloping XT segment depression with a prominent T wave is what we call De Winter's T waves, but it's the numerology is not essential. But when you see this upsloping ST segment depression and a very prominent T wave, this is almost like an anterior wall MI. There might not be a ST elevation MI in the anterior leads, but this is a sure shot sign that the proximal LED is occluded. And whenever you find this upsloping ST segment depression with a prominent T wave in V3 and V4, this patient needs to be referred for immediate care because these patients tend to have proximal LED occlusion. And this is the final ECG I'm going to put forth. This person was referred to us for an early implant of an ICD. ICD is an implantable cardiac defibrillator. We implant it for people with ventricular tachycardia or ventricular fibrillation. This ECG was seen by an intensivist in the ICU. This person was monitored in the ICU, and this is the ECG strip he sent to us saying that the person is having repeated runs of ventricular fibrillation. He needs an ICD and was quickly shifted to our center. This was nothing but an artifact. And this is the arrhythmia below down, and this is the artifact above. So how do you differentiate an arrhythmia and artifact? This is very important because this denotes two extreme end of the spectrum. Artifact, typically, as you all go, you go back to clinical medicine, all these ECG changes happen, but the patient is hemodynamically stable, there is no symptoms, there is some association with body movements, there is some instability of the baseline before this happens and after this happens. And the most important sign is if you go back to the ECG, you can actually see the QRS walking through these artifact segments. You can see actually the QRS happening if you see the first lead, you can see the QRS happening exactly, the native QRS happening exactly, running through these so-called ventricular tachycardia strips. So this is important because if you wrongly label this artifact as a ventricular tachycardia and this person gets a device, this is actually it's the biggest crime you can do in our system. So to conclude, ladies and gentlemen, ECG, although a small strip of paper, gives an enormous information on both cardiac and extracardiac disorders. Before deciphering anything on the ECG, first ensure that it is properly taken, properly standardized, taken at the right speed. Go systematic on the ECG, go step by step, look at the rate, look at the rhythm, look at P wave, PR segment, QRS, the QT interval, and the T wave. And before jumping into any diagnosis, as Sashiran sir said, clinical medicine takes the forefront. Always look at the history before you run into any diagnosis based on the ECG alone. Thank you.
Thank you, Arun, for the wonderful talk. I want to highlight one is proper history taking. As you said, before interpreting the ECG, analyze the patient is very important. Otherwise, we may either overdiagnosis or misdiagnose the patient. Number two is seeing the proper calibration and standardization of the ECG and taking the background history of the patient. Suppose the patient is having any valvular heart disease or chronic kidney disease or taking any chronic medications. So that may affect the ECG of the patient. So these points to be taken before interpreting any ECG. Okay. Any questions from?
About the WPW syndrome. So the delta waves are seen in all leads or any lead specifications?
Okay. It all depends. So when a person has a WPW syndrome, so there are two ways the ventricle can get depolarized. It can get depolarized to the native conduction system, and it can get depolarized through the accessory pathway. So an impulse originating from the sinus node reaches both these conduction systems. It reaches the AV node as well as the accessory pathway. So based on where the accessory pathway is, suppose the accessory pathway is on the right side of the heart, like on the tricuspid annulus, the impulse reaches AV node as well as the accessory pathway almost equal time, or sometimes the accessory pathway earlier. So in those cases, you will have a prominent delta wave because most of the impulses might go through the accessory pathway, and you will have a very prominent delta wave which might be seen in all the leads. But if a person has a left-sided accessory pathway, the electrical impulse from the sinus node might reach the AV node earlier and then take a lot more time through the left atrium to reach the accessory pathway on the left lateral side. So the delta wave in those cases might be seen only in V5, V6 and 1 AVL, that is some leads, because the magnitude of pre-excitation might be minimal or inapparent in them. So there are two things. One is location of the accessory pathway. Other is the conduction speed of the accessory pathway. If the accessory pathway is rapidly conducting, much more rapidly conducting than the AV node, most of the QRS would be depolarized from the accessory pathway, and then the delta wave will be really broad and seen in more leads.
Okay, thank you. Two more questions, sir. And RSR pattern is often seen in inferior leads. Does it have any significance? And about the ST segment, you told 0.5 millimeter depression, elevation and 1 centimeter depression are significant. Is it same for all leads or there's lead difference?
Okay, excellent. So RSR is a very benign thing that is seen in many ECG referred to as right bundle branch block. So RSR indicates a notched activation of the right ventricle. So whenever you have an RSR pattern, you look at the QRS duration. So if the QRS duration is less than 100 milliseconds, it is benign. You can reassure them. If the QRS duration is between 100 to 120 milliseconds, it indicates an incomplete right bundle branch block and might be benign, but may be referred. But if the QRS duration is more than 120 milliseconds, this RSR is pathological and definitely needs further evaluation in the form of an echocardiogram to look for structural heart disease. And in the absence of a structural heart disease, you all know that benign right bundle branch block can be seen in a significant proportion of patients. The second question was regarding the magnitude of ST depression. Again, the ST depression, physiologically, you can find ST depression in some leads and in people who have significant left ventricular hypertrophy. So any amount of ST depression that you are connoting should be taken in the clinical context, in the background of the clinical scenario. If a person has significant left ventricular hypertrophy, you might have baseline ST depression, which might be even more than 3 or 4 millimeters, but that doesn't indicate abnormal pathology. In a normal QRS duration, whenever you have an ST depression, which is more than 0.5 millimeter, and the morphology of the ST depression, if it's an upsloping ST depression, it is benign. If it's a horizontal ST depression or a downsloping ST depression, they are pathological and definitely needs further evaluation for ischemia or drugs which can cause that. I'm surprised you were listening and you had
one more question. Suppose if you see an ECG in a asymptomatic patient and showing a pre-excitation pattern, should we investigate further?
Definitely. That's a wonderful question. I'm not very sure how many of the practitioners would have understood what Vinod asked. It's saying that you have a delta wave, person is asymptomatic. This is what we call typically asymptomatic WPW pattern or asymptomatic pre-excitation. This is an important territory in the West because people undergo ECG screening for sports, for jobs, and they find this pre-excitation. Now what to do with them? It's very important that these patients are further evaluated because if you look at all the data that we have, WPW syndrome is an important cause of sudden cardiac death in young individuals. Now the risk of sudden cardiac death is ascertained by where the accessory pathway is, how rapidly it is conducting, and whether an atrial fibrillation can conduct down the accessory pathway. And the fourth important criteria is whether the accessory pathway can cause a supraventricular tachycardia. And all these things can only be ascertained based on an EP study. EP study, as I said earlier, we put in catheters inside the heart. We look at how fast the accessory pathway is conducting. We induce atrial fibrillation in the lab, see how the atrial fibrillation is conducting through the accessory pathway. Because sudden cardiac death in these individuals happen because atrial fibrillation gets conducted through the accessory pathway and reaches the ventricle. In a normal person, when the atrium is fibrillating, the heart rate in the atrium is somewhere between, the atrial cycle length is somewhere between 350 to 500 milliseconds. The AV node is a very sensible structure. It won't transmit impulse at this fast rate from the atrium to ventricle. That is why during atrial fibrillation in a normal person, the absence of WPW, you will find a ventricular rates which is somewhere between 100 to maximum 200. It won't go beyond that because the AV node is a slowly conducting tissue. It has a longer refractory period. So after one impulse is transmitted, wait for some time for the next impulse to transmit. This is not true with an accessory pathway. These are rapidly conducting structures. So an atrial fibrillation in a person with WPW syndrome, when the atrial cycle length is somewhere like 300 or 400 milliseconds, the entire atrial impulse can get transmitted through the accessory pathway, and an atrial fibrillation in no time becomes a ventricular fibrillation, and that is why these people have sudden cardiac death. So whenever you find an asymptomatic WPW pattern, you need to ascertain whether an atrial fibrillation can get conducted through this accessory pathway and whether it can get conducted rapid. If it gets conducted rapidly through this accessory pathway, even in the absence of symptoms, these pathways need to be ablated.
Then likewise, ERS pattern, is it so benign?
Yeah, pretty sure a lot of people might not understand. ERS is early repolarization pattern, which was one of the clinical scenario I said earlier, where you have a young individual, a symptomatic person with a very prominent T waves, a concave ST segment elevation in predominantly infralateral leads. So they are typically referred to us as ST elevation MI because the practitioner initially found ST segment elevation in 2,3 AVF and V5, V6. So ERS was essentially earlier ridiculed as a very benign entity, saying that this is a benign entity, these people can be reassured. It is true that it is benign if you look at a connotation of ST elevation MI. If they are referred as ST elevation MI, you can tell them that there is no ischemia going on. But recently there are a lot of studies which indicate that people having ERS pattern or early repolarization pattern have a 2% risk of sudden cardiac death. Because these people with early repolarization syndromes are prone for what we call idiopathic ventricular fibrillation. So these people have electrical inhomogeneity in the ventricle, which predispose them for ventricular fibrillation, and so a lot of people with unexplained sudden cardiac death in young individuals, one of the reasons that is depicted is what we call J-wave syndromes or early repolarization syndrome. So ERS is not fully benign, but not as malignant as ST elevation MI.
Okay, any more questions from audience?
I'm sure we're eating into their lunchtime and one more speaker is there. So thanks for the opportunity. Thank you.
Okay, thank you, Arun. It's a big topic. It's covered so beautifully. I invite Dr. Ajita Madam to hand over the memento. Sir. I invite Dr. Moina Krishnan, sir, to please give the memento to Dr. Vinod. Now coming over to the last session, but the most important session, I invite the chairpersons, Dr. Raju Balram and Dr. Ajita Madam. I invite our speaker, Dr. Brigadier Aruna Menon, HOD and Senior Consultant, Obstetrics and Gynecology, Maitra Hospital. She is a trained laparoscopic surgeon, has an overall experience of 32 years as a gynecologist and an academician. Welcome, madam.
All right. First of all, I know that lunchtime is, we have encroached into lunchtime, but just consider this as an appetizer. So, ma'am, Dr. Brigadier Aruna Menon, 32 years of illustrious service in the armed forces. You have served every military hospital in the country, I believe. Suratgarh, Delhi Cantonment, Armed Forces Medical College, Command Hospital, Chandigarh, Chennai, and you finally retired as the professor and head of department in AFMC Pune. You have been a guide to a lot of postgraduate students, several papers, national and international, to your credit, an obstetrician par excellence. Laparoscopy is your soft point and strong point also. So, ladies and gentlemen, the moment I got the opportunity to chair this session, I was wondering, what am I going to do, you know? Like, the topic was, what do you call it, pregnancy as a window to future health.
Yeah.
And I was or rather I'm waiting with bated breath to hear you. And because after 25 years in the field, I thought I've seen it all, heard it all. But here is something which is going to be very new. Madam, welcome to the land of the Zamorans and the place where you get fantastic biryani, and the stage is yours.
Thank you, sir. I think with such a fantastic introduction, half my work is already done. Thank you so much, and a very warm good afternoon to all of you, and a very heartfelt thanks to the organizers and to the audience for patiently waiting, because I know we are running late, and so I'll try and keep this to the minimum. Can I just tell, how do I use the control? Yeah. So I bring greetings from Maitra Hospital, besides all those hospitals that I worked in over the last 30 years. And coming to my topic, as Sir just mentioned, it is something that has caught my fancy recently, because after having listened to that wonderful talk on ECG, I feel that pregnancy is possibly like a of life, where it unmasks so many problems that the patient could have, and that is the basis of my topic, where I say that pregnancy is possibly a window to future health. So as we all know, pregnancy brings a lot of metabolic and hormonal adaptations, and that causes one of the biggest stress in a woman's life. It may predispose, or rather expose the genetic predispositions, and also unmask the metabolic susceptibility for further future disease. It's a unique opportunity for us to actually examine a whole subset of the population. We are subjecting them to a stress, like we subject a patient to a treadmill test, to know what the future may hold for this set of the patients. So coming to CVS risks, as we all know, it now comes as one of the most leading causes of female deaths in developed countries. And a key meta-analysis recently showed that the risk of CVD in preeclamptic patients, in patients who have developed preeclampsia, is as high as 3.7 as a relative risk, and of developing hypertension as much as 2.2-fold, and for developing ischemic heart disease and developing stroke. So hypertensive disorders of pregnancy affects as much as 10% of our female population, and they are associated with obesity, CVD, hypercholesteremia, and diabetes. Placental syndromes like infarction and abruption can cause serious risks not only in the long term, but in the short term as well in certain conditions. Diabetes. In our own country, God's own country, diabetes is almost endemic, and gestational diabetes mellitus affects almost 10% of all pregnancies again. And this is associated with almost a 20-fold increased risk of developing type 2 diabetes later in life, and also developing stroke and MI, which is increased as much as 2-fold and 4-fold respectively. So they are also at the risk of developing metabolic syndrome, which is the cause of so much of morbidity in later life. Gestational weight gain is arguably one of the most detrimental consequences of pregnancies, and I'm sure most of the ladies sitting here will endorse that, because excessive weight gain is something that you can't always lose. You can rarely go pregnancy weight unless you do a lot of effort. Any kind of excessive weight gain in the first trimester itself is a risk for developing IGT later in the pregnancy. And if you do not go back the pre-pregnancy weight, so that now acts as the basis for the weight gain in the next pregnancy as well as in later life. So gestational weight gain, which was not given as much importance earlier, now is an indicator that these patients may develop obesity and all the risk factors that go along with it later in life. Liver disease. Undiagnosed liver disease can be exposed during pregnancy and may require long-time surveillance. As most of us do, we screen these patients for liver diseases during pregnancy, and this may actually give us a window to treat these problems as well as identify patients who have liver disease and also to follow them up, especially when they are associated with underlying variant mutations, and warn them of cirrhosis, hepatobiliary malignancies, and gallstones. Renal disease, as we all know, goes hand in hand with most of the complications of pregnancy and preeclampsia. Renal glomerular diseases may present de novo in pregnancy itself. And in addition, preeclampsia rates are much higher in patients with pre-existing renal disease, and anyone who actually has a problem during pregnancy may later on go on to end-stage renal disease. So, what does all this tell us? It means that the development of these disorders during pregnancy can clearly increase the risk of this disease acquisition in later life. Currently, very few interventions are used to actually identify these patients or to significantly affect or follow up these patients in later life. And we do not have any policies in place either where we can actually follow up these patients for the development of risks that are so important in later life. So what can we do? Well, the most important thing is what we are doing here today, that is improve awareness. Improve awareness among patients, among obstetricians, as well as among physicians who are very important for diagnosing or identifying these patients, and develop cost-effective screening and risk assessment tools which can be used to assess these patients once the pregnancy is over and introduce early interventions to prevent the further problems from happening in these patients. So there was a white paper recently as late as 2021, which identified this and said that common pregnancy complications share a lot of risk factors and features in common with cardiovascular disease, including hyperlipidemia, endothelial dysfunction, and lipid deposition in blood vessel walls. A recent review on the topic in the AHA's journal Hypertension recommends that postpartum cardiovascular risks and assessment should be done for all women with these pregnancy complications and in the best possible, to give them best possible long-term outcomes. So our obstetric units should be encouraged to develop clearly defined local protocols concerning postpartum cardiovascular risk screening and in conjunction with the local general practice. So this is the whole point of my talk today, that we should be able to put in place a protocol where the obstetricians in conjunction with the physicians are able to identify these patients, counsel them, and put early interventions in place to prevent later problems in life. So these are some of the countries have been doing this, and I went through a lot of literature. So there are a lot of protocols and algorithms which are being developed. They are no longer guidelines as such. A lot of identifying factors and interventions that are already being developed and put in place. So I feel that as a group, we doctors can do a lot to prevent these problems. First of all, we are being, this subset of population is coming to us with such a lot of problems which can easily be unmasked during pregnancy, and when they are unmasked, these patients should be subjected to early interventions to prevent of problems in later life. So this is another table that is there in place. So if you have any patient who has a hypertensive disorder during pregnancy, they are at risk of developing all these problems, and what we can do is call them back, reassess them, and put in preventive factors like starting them on aspirin, statins, giving them weight management. So I won't go through each and every table which puts in a nutshell what I've been trying to say today. And so if we have these patients with these problems, and we see more and more of those patients nowadays, mainly because we have pregnancies in older mothers, we must identify them and tell them to come back to us for a proper reassessment of these risks. And I feel that at every local level, if we develop these kind of protocols, of risk assessment tools, we would go a long way in preventing severe risks and diseases in later life. So we can contribute to this cause by creating these kind of postpartum risk units, and every patient who has a high-risk medical disorder during pregnancy should be reviewed at 6 months postpartum and assessed for severe risks clinically and biochemically. A lot of risk factors are common for severe and pregnancy disorders, and some countries have already done this and put in screening programs in place, notably Canada, Australia, New Zealand, and India should also follow suit. And with our eminent chairperson sitting on the dais today, it's my request that I think we should look at this as a very potential source of prevention and put in our measures early enough to provide health and wellness to these patients. I think that is, thank you from all of us. And may I please request my team from Maitra to just join me on stage briefly. So we have a team in place, and we have our own Dr. Ajita also as a visiting consultant in the hospital. So from all of them today, let me say a very big thank you. Dr. Sandhya. So, Dr. Sandhya is a gold medalist who has done a lot of good work in North Kerala Hospital, and I'm very glad to have her on our team. Dr. Reshma. Dr. Reshma has been the face of gynecology in Maitra so far. She was a one-woman army who was handling all the patients herself, and her special areas of interest include hysteroscopy. Besides this, she has been in the health services for a period of almost 7 years, and she brings with her the experience gained in the Kerala government services as well. Besides that, we have two young team members, Dr. Netra and Dr. Tanuja. So from all of us today, a very big thank you.
Thank you, Aruna. That was a very well-selected topic for the CGP conference. As you said, we most often lose patients after that, after the delivery is over, and the lifestyle modifications and other minor interventions we should be able to follow. And I think the health system should be more aware of it and should take more actions to for the follow-up and prevention of further diseases.
So we are also planning that. Hopefully we should be able to do start at whatever level you can, but I think if you both can also pitch in, it's something that we can do at the state level as well, because it is a large subset of population whom we can identify with these risk factors, and if we can, put in some kind of preventive action at that level, I think it would help.
And now, because we are having this pregnancy late, most of the pregnancies are coming
later in life.
Later in life, a lot of risk factors are also being diagnosed, like the diabetes complicating pregnancies are very common now. But then they are lost to follow-up. After 6 weeks, we don't see them, and they don't bother to do it also. So we should have some system of following up. I think IMA can, or the health department should work out a system.
That's true. So we can all start at our own level.
If there are any questions from the audience?
Any questions, any comments?
So now what has happened is that the patient has been brought to us. I mean, you can't call a pregnant lady a patient actually. It's
Yes,
a
sir.
physiological condition.
So it's actually just a subset of our population.
Yes, but she has
come to us.
Something has been revealed to us
Yes,
at the time of pregnancy.
That's
a
right.
PIH has come, a renal disorder, all these things have. So we have to have, the point is that you have to have liaison with the other departments.
That's
and
right.
Link up with the, I think counseling is required not only of the patient but of the family members also.
Very true.
Of the family. And then what you do is you tell the family, the husband and the mother-in-law, especially the mother-in-law,
Yes.
that see, the daughter-in-law, the thing is like this. She is prone and you may lose her if you don't take care of her.
That's right.
Some kind of a 6 months follow-up, 1 year follow-up and things like that. That has to be done.
Yeah.
And this has, I think what you have opened up a new avenue in ONG where I think we have to start a program, a national
right.
program.
Yeah, actually I heard of this in some talk itself where a lady had come from Ireland to speak at one of the, and I found it fascinating that none of us have actually thought of it.
Not thought about
so I
that.
think, and it should be in conjunction with all the other specialties like physicians, endocrinologists, cardiologists, so many people who should be involved in identifying them and counseling them
Yes,
thereafter.
and I think, but since when these problems surface at the pregnancy level, it is our duty to see to it that
Absolutely.
they are linked up with the various
Very
physicians, so that we don't lose them up to follow up and things like that.
That's true.
It's very sad because most here I would like to suggest that you start
Yeah, I'm planning to.
Postnatal
reassessment clinic.
exercise classes.
Yes.
I think it's going to be a big hit. It's something which I wanted to do 15 years ago.
Sir.
I've not been able to do it. I have my limitations.
Sir.
But I think probably, madam, if you could, I think you will get a lot of takers for it.
Yeah, we are
postnatal
planning.
exercises.
Yes.
Because they will come. And I have seen a lot of ladies go to various kinds of centers which provide Zumba and aerobics and all those
That's
things.
true.
But if you can start something in an organized manner for ladies, postnatal exercises,
yes, sir.
There are going to be a lot of takers in Calicut also. All the best, ma'am.
Thank you so much.
Thank you, Aruna. I think it is because we have the patient load is very much here. That
Yeah.
is why we are not getting the follow-up of all these cases. But with the improving facilities everywhere, even in the government setup,
We
maybe
can do it.
It should come up. Thank you.
Thank you
and
so
to all
much.
the Maitra team. Team Maitra, of which I am also a small part.
Yes, yes, you are definitely a very big part, and thank you so much for being a part.
Thank you, madam. I welcome Dr. Rabia to please hand over the memento. I invite Dr. Moina Krishnan to hand over the memento to the chairpersons.
After this, we will have an interesting session for a quiz. Mohanashan sir will lead the quiz team. We will gather here for the post-lunch session. Thank you, sir. Oh.
This is round 1. Team A scored plus 10. B scored minus 5. Plus 10. Minus 5. Like that. Just according to whatever he says, just note it down.
Okay. I think it will be better. You also write. Okay. Then it will be you take that. Up and there won't be error.
So cross check.
Cross check. We can cross check. Like this you write. You have to sit here. No, you cannot sit here. There's no
Check, check, hello. Check, check, check.
we can cross check also. Very well. It's round 1, then when it comes to round 2, then only we need to write.
Hello. Check.
You don't have duty, right? Night only. Okay, no problem. Sure, Deepak would have okay. So that is ruled out.
Good afternoon. Before starting the competition, I am inviting Venu sir to give the mementos certificates to the poster presentation winners.
Check, check, hello. Check, check, hello, hello. Check, check, hello.
The third prize goes to Ajnas VV for poster presentation. Give a big clap. Now the first prize for the poster presentation to Binsi Philip of KMCT Medical College. Sorry, MMC Medical College. Binsi Philip, MMC. Third. Second prize on the second prize in the. Thank you, sir.
Hello. Hello.
Second
Hello.
Said Ahmad, Siad Ahmad, second prize. Everyone did wonderfully. It is difficult to, judges have get difficulty to differentiate who is first and who is second. But because of the specific marking system and this scoring system, they did that. Thank you. Thank you so much. Hello.
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 Hello. Hello. Audible? Yes, thank you. So please check your mics. All working? Buzzer alla mics. So as let us start the quiz with the permission of the President. Thank you very much, because when President called me about 2 weeks ago saying we are having an IMA CGP state conference in Calicut, and I have been selected to conduct the quiz program. So I was really happy, and later on came to know that my close friend Venu, the other Venu, had proposed my name as a quiz master. And it is really, I really enjoy conducting quiz because it's very safe to be on this side of the table. So this is the safest part as far as a quiz master is concerned. And now this quiz, please don't worry that this is going to be a tough quiz, because I have specifically made this as a very easy quiz, because even though you are working in various specialities to do your post-graduation courses, the quiz is supposed to be adhering to the basics, because it is for the IMA CGP. I don't know whether you got opportunity to listen to the speakers during the inaugural function, because what is the motto, what is the purpose of this IMA CGP? So we have to adhere to that. So that the motto is to develop basic doctors in India so that we can get rid of quackery in full. So the questions, don't worry, will be very, very easy. I even doubt that it will be 100% scoring quiz round for the history, first time for the probably in the history of quiz. Looking at the participants also, I am really happy. But only thing I would like to mention here is that time that most of us take quizzing seriously, because it's an avenue to learn things, not only medicine, but a lot of other things. So I generally enjoy conducting general quizzes, even though I am a doctor, not a medical quiz. But this being an IMA CGP program, we have made it a medical quiz. But wherever possible, I try to deviate. I had to take a lot of effort in resisting the temptation to deviate from medical to non-medical. But one or two places, I have deviated from medical, but in those also, doctors were involved, but in a different capacity. So let us now start the program. Let us start by introducing the teams. So please introduce yourself.
My name is Dr. Neeraj from Aster MIMS Hospital. I'm doing general medicine, DMB.
Yes.
I'm Dr. Amal Baiju, same from Aster MIMS.
So Amal and Neeraj from Aster MIMS, Calicut, from the Department of Internal Medicine. Yes. Ahmad.
I'm Dr. Ahmad Shaheen from Department of Emergency Medicine, MIMS Calicut.
I am Dr. Deepak from Department of Emergency Medicine.
So the second team, we'll call it Team A and Team B. Team B is a team of scorers, please note. Team B is also from Aster MIMS Calicut, representing the Department of Emergency Medicine. Ahmad and Deepak. Yes.
Dr. Ranjana, Gynecology Department, Baby Memorial Hospital, Calicut.
I'm Dr. Adira, Gynecology Department, Baby Memorial Hospital.
So welcome Adira and Anjana. Ranjana.
Thank you, sir.
They are representing Baby Memorial Hospital, the Department of Obstetrics and Gynecology. Yes.
Dr. Sujata, Department of General Medicine, Government Medical.
Dr. Midun from GMC Kozhikode, the General Medicine Department.
Yes, welcome. So you are representing Medical College, Government Medical College, Calicut and the Department of Internal Medicine, right? Welcome.
Sir, I am Dr. Fasna from Master MIMS Calicut, Department of Family Medicine.
I am Dr. Somna from Master MIMS Calicut, Family Medicine.
So welcome to this quiz program. I am really happy that at least one team from family medicine is here, because this is entirely, the whole business is entirely on family medicine, but we hardly see family physicians around. And welcome again from Aster MIMS Calicut, representing the family medicine department. Let me introduce myself. I am Dr. Mohana Krishnan, basically an ENT surgeon and fascinated in conducting quiz programs. That's enough now. So we will have, because of time constraint, we have only made 4 rounds for this quiz program, 4 rounds. And as now it's a trend, world over, television's over, channels over, you see the buzzing trend. So the quiz primarily will be based on the buzzer, not you first, you second, you third. So generally people fastest fingers first, but I would like to brains first and then come fingers. So there is one round or so without buzzer. I'll tell you as the forwards. So let us now slide advance on tero ningade slide advance on tero onu taru yes USB idile ivide ഇതെന്താ ഇതല്ലേ yes so now we'll go to the rules of the program. We have only 2 rules, as you might have seen. Rule number 1 is the quiz master is always correct and his decision shall be final and binding. And rule number 2, if you have any doubts, see rule number 1. So that ends it. Okay. You probably will think that there is a dispute, but no dispute is allowed. So that is why I enjoy this, because for the next 1 hour, I am the king here. And after that, nothing. So we'll move on. Round 1 is a buzzer round. The rules are fastest brains and hands first. Buzzer will be active only after the quiz master fully reads the question. You should not jump into buzzer, it will not work. So we have Shamin here, who is also an ardent quiz master, and she is part of Quiz Factory, right? Q Factory, very famous quizzing company, and she has, according to our request, based on our request, she has come here to be a part of this quiz program, and she has brought the buzzer system. So welcome Shamin, thank you very much. And now this buzzer is completely controlled by Shamin. So only after the full question is read, it will be active. So there will be 4 choices and right answer is to be selected. It's a multiple choice, right? 10 marks for the correct answer, and since this is the buzzer thing, there will be a minus also. Yourself to answer the question. If the bus team is not able to answer within 10 seconds, reasonable time, let us put it like that, or the answer given is wrong, the buzzer will be active again, and all teams, including the team which has given the wrong answer, can buzz again. Okay, clear alle? Same pattern repeats 3 times. Even after 3 times, nobody is able to answer, the audience gets the chance and also a munch. And the question goes to the audience if no correct answer is obtained even after 3 buzzers. So let us now start. Okay. So buzzer round, question 1. Brom or DOIS, to which condition does this term refer to? Bad breath, caffeine high, food poisoning, stinky feet. Waiting for the buzzers. Nobody? I thought all these are very easy things. Just try your luck. After all, it's only -5, we can compensate later. So shall we pass on to the audience? This is not a good omen. Yes, team, family medicine, you should go first. Press. Yes. Now got one team trapped.
Caffeine high.
Yes, your answer please.
Caffeine high.
Caffeine high, I am afraid, is not the correct answer. So -5 for team E. And then the buzzer is active again. Anybody else trying? Yes, team C.
Feet.
Stinky feet is the correct answer and they get 10 points. Team C gets 10 points and the correct answer is stinky feet. Okay, so congratulations, that's a good beginning. You hesitated initially. Now you get the impetus to go forwards, right? So hands on your buzzer again. 2. Match the following. Things are written on the top, you have to match which is A, which is B, which is C. You have to give me all correct. This, yes, team B.
Cuboid B, calcaneus A, talus D, lateral cuneiform C.
Absolutely correct. Big hand. So I thought it will be an unanswered question. Absolutely correct. And the correct answer is, this is the right match. You did right. Team B? Team B gets 10 points. So that's good going. We go to the next question in this round. That is, this is an audio question. Audio connect cheyana. Just take a break. സാധാരണ ഇതുണ്ട് പിന്നെ അതാണ് ഇതിവിടെ ഉണ്ട് ഹെഡ്ഫോൺ ജാക്കിൽ കുത്തിയാൽ പോരെ ഇത് so by the time they make it, after each rounds we have to announce the scores. Supriya, after completing the rounds. Oh, they're going to exit here. We start. Can you identify this audio track? Yes, team D. Just say what is that? That's all. What is this noise all about?
Ejection systolic murmur.
This is a cardiac murmur. That is what I am expecting from you. Get 10 marks. And there is a question along with this. Then again you can attempt buzzers on hands on your buzzer. There is a bonus question is what type of cardiac murmur is this? Mid systolic, early systolic, diastolic, systolic and diastolic. Yes, team C, team B.
Mid systolic.
I am afraid it's not correct. Yes.
Early systolic.
Early systolic is the right answer. -5 to team B and 10 marks to team E. Early systolic murmur. So move on to the next question in buzzer round. Ready? Polymastia or polythelia are terms used to denote the presence of excess of what on the human body? Yes, we'll take that. Team E.
Nipple.
Correct.
Mastia, breast, thelia.
Nipples is enough. Right. So 10 marks for team E. Family medicine is going ahead. 10 marks for see, the answer is nipples. So this is the last question in the buzzer round, and I am afraid this again is an audio question, but strictly non-medical. Not strictly non-medical, half medical, half non-medical. Team D, which is the movie? Correct. Ayalam Janam Tamil, a movie selected on La Karanam. All major characters are doctors. The story revolves around their professional and personal lives. 10 marks to team B. And we have 2 bonus questions attached to this. So again, go to the buzzers. No negative, don't worry. So try. You get 5 marks, not 10 for this bonus question, but don't worry even if you go wrong. So buzzers, ready? The question is, who is the director of the movie? Yes, team. You are asking me?
Sir, Pradap Potan.
Wrong. Yes?
Laljos.
Laljos is correct. 5 marks to team C. And there is one more bonus in this. Laljos answer. The bonus is that, again, 5 marks, only if you answer all 4 points in it. Otherwise, I will leave it to the audience. They have been a single question. They didn't get a single one. So the movie won 4 Kerala State Awards in 2012, which all 4 ശരിയായിട്ട് പറയുന്നവർക്ക് ഇവിടെ മാർക്കുള്ളൂ, മഞ്ചലിക്ക് മാറും. Nobody? So we'll pass on. Anyone from the audience? One answer. At least one category varna oru manchu kittum. അതാണൊന്നും ഇല്ലാത്തൊരു സാധനം. ആൻസർ കാണാം. ഡയറക്ടർ ഇസ് കറക്റ്റ്. 1 ബെസ്റ്റ് ഡയറക്ടർ അവാർഡ്. ഒരു മഞ്ച്. സന്തോഷം എവിടെ? സന്തോഷിന്റെ കയ്യിലാണ് മഞ്ചുള്ളത്. നോ. ഗോഡ്. കറക്റ്റ്. അതാണ് രണ്ടാമത്തെ. ജനപ്രീതിയും കലാമൂല്യവും ഉള്ളത്. പിന്നെ now I will take the rest to for the quiz master, something for the quiz master. I will show you the answer. Best film with popular appeal and aesthetic value, best director, best actor and best comedian. Test. It's working because somebody else pressed earlier. That's why it's not working. Okay, this is end of round 1. Shall we have the scoring? Mic undo. So now end of round 1. I don't know whether you enjoyed it. So this is just the beginning. So we'll go for more fascinating rounds maybe, but we don't have that much time. Venu has given me only 1 hour. I don't know whether I'll be able to. Since all the other programs are delayed, I am also entitled to get more time. So that is why I initially had 6 rounds. I cut 2 rounds off and made it 4.
Okay.
Yes.
Team A gets 0 points, Team B 5 points, Team C 15 points, Team D 20 points, and Team E 15.
15. എല്ലാം പറഞ്ഞ പോലെയല്ലേ? ഇനി ഡിസ്പ്യൂട്ട് ഒന്നുമില്ലല്ലോ? Okay, shall we move forward? All scorer ready? Round 2 is select your favorite topic from the list that I'll show here, and the buzzer decides who gets the first chance to select the topic. Okay, so hands on buzzer, no negative mark here, and after you select, there will be 4 questions from that topic. All 4 will come to you, and there will be a different scoring system which I will show. This is here. There shall be 5 topics to select from. 4 questions for the correction of the first question, no negative mark. Second question like pono venda ningalku theermanikam. If you don't want to go, you can stop there. Be happy with the points that you get. Allengal you advance, you get more points. But there will be negative marks also. See, 10 points, minus 5, 20, minus 10, and 4th question will get 30 marks, but minus 15 as negative if you go wrong. And I just wanted to tell you that it is not that it is progressively difficult. It is equal, difficulty level is equal for all 4 questions. Okay, so you can take a chance, that's why I am saying. അതല്ലേ 2 ചോദ്യം കഴിഞ്ഞാൽ എനിക്ക് അടുത്ത ചോദ്യങ്ങളെ വേണ്ട എന്ന് പറഞ്ഞ് നിർത്താം, അപ്പോൾ അത് ഓഡിയൻസിന് പോകും. അത് നമുക്ക് ഇവിടെ ഞാൻ പാർലമെന്ററി ആയതുകൊണ്ട് പറയാൻ പറ്റില്ല, വേറെ വാക്കുണ്ട് അത് പറയാനായിട്ട്. അതിവിടെ പറ്റില്ല, അത് ചോദിക്കുന്നതിന് മുമ്പ് പറയണം. Okay. So to select the topic, hands on buzzers, right? So topics. Yes, select your topic, Team E. Select.
Blood smear.
Blood smear. Okay, here we go. We go to the blood smear questions. Okay. So first, no buzzer, you can relax. This is only to them. So first question, 5 marks, no negative marks, and you will get reasonable time to answer. What broad type of anemia does thalassemia fit into? A microcytic hypochromic anemia, macrocytic anemia, nomocytic anemia, megaloblastic anemia. What is your answer?
Microcytic hypochromic anemia.
And the answer is microcytic hypochromic anemia, and you get 5 points for that. Do you want to go to the question? You are taking the second question, you will get 10 marks if you are right, and 5 marks down if you are wrong. Okay.
Yes.
പിന്നെ ചോദ്യം കേട്ട് കഴിഞ്ഞിട്ട്
Not responding.
If not responding also same result. Second question.
Yes.
What type of cell is seen in this image? Teardrop cells, target cells, stomatocytes, schistocytes. Take only reasonable time, otherwise it will go to the audience. Parnolu.
Target.
Target is
cells.
a correct answer. Points. The answer is target cells, and you get points, and that gives you more confidence and dhairyam to go to the third question, right? Pule.
Mark 20.
20 kittum 10 povom. Okay,
yes.
Right?
Yes.
Okay, question number 3. What type of red cell inclusion body is seen in this image? Basophilic stippling, Howell-Jolly bodies, Haynes bodies, Shidak-Higashi inclusions.
Haynes bodies.
Haynes bodies is not the right answer. So you lose 10 points there, minus 10, and it goes to the audience for a munch. Howell-Jolly is the correct answer. Who said that? Yes. ഒരു മഞ്ച് അവിടെ ഒന്നും കൂടി മഞ്ച് കളക്ട് ചെയ്യുന്ന തോന്നുന്നു. Okay, now We are going to the next team. You want to go to the next question? Even if this is wrong, we can question if you want.
Yes.
That is 30 points. That's the spirit. Minus 15. So they want to compensate what they lost now. Okay, shall we go to the next question? Fourth question in your selected topic is hemoglobin H inclusions are golf ball like red cell inclusions that are seen on supravital staining. Which condition do they occur in? Alpha thalassemia, beta thalassemia, sickle cell disease, unstable hemoglobins.
Beta thalassemia.
ഭാഗ്യത്തിൽ ഞാൻ കേട്ടിട്ടില്ല, ഒന്നുകൂടി പറഞ്ഞോളൂ. Yes.
Beta thalassemia.
I'm sorry, family medicine team, you lose 15 points. Anybody from the audience? Alpha is the correct. Alpha thalassemia is the correct, and that is good participation. I really appreciate. We will. Can you just tell them their score? Idu matram. Unfortunately, minus 10 ilana ipo nikkunnathu. There are a lot of opportunity to make up. Okay. Now you can take rest. With the open buzzers are open again to select the topic. Back to the topics. Topically poitla appade buzz idu. Yes. Team B, yes. Which topic?
ECG.
ECG. Okay. Now we will go to the ECG. Right. So are the same. So shall next question. Question number 1 is how many milliseconds does 1 mm or 1 small square on a standard ECG represent? 400 milliseconds, 200, 100, 40. Marks, no negative marks.
40 milliseconds.
40 is the correct answer and you get 5 points. Okay. So next question, shall we?
Yes.
You have to give me.
Yes, sir.
What rhythm is present on the ECG trace below? Sinus rhythm, first degree heart block, second degree heart block, junctional escape rhythm. Yes, that's enough time.
First degree
heart block is the answer and points for that. The answer is first degree heart block. So the next question.
Yes.
20 points and minus 10. Let us not talk about minus 20 points. Okay. So the question is, what rhythm is present in this ECG? Sinus tachycardia.
Atrial flutter.
Pardon?
Atrial flutter.
Absolutely correct. 20 marks to emergency medicine team of Aster MIMS, right? Venu? Score cheyyunnundallo. Atrial flutter. And the last question, 30 marks. Shall we go?
Yes, sir.
30 and minus 15. Which QT correction formula should be used for a patient with a heart rate of 120 beats per minute? Bassett formula, Framingham formula, Robinson formula, Miller formula.
Bassett formula.
There you got wrong. Minus 15. And the answer from the crowd? Anybody from the audience? So Quizmaster will take the munch here. It's a Framingham formula. Bassett formula is normocardiac situation, and Robinson and Miller are for weight assessment formula. Okay. So your session is over. So what is their mark? So you got plus 20. Now 3 teams left to select the topic. Back to the topics. A. Which is your topic?
Function.
Thyroid function. Yes. So we will go to thyroid function questions. So first question definitely we can take without any issue. Globin antibodies are most specific to which disease? Hashimoto's, Graves, atrophic thyroiditis, and post-viral thyroiditis.
Hashimoto's.
5 marks. Hashimoto's is the answer, and you get 5 marks for that. And question, shall we go? 10 marks? Minus varenda. Second question, here it comes. Interpret the following thyroid function test results and say whether it represents primary hyperthyroidism, central hyperthyroidism, subclinical hypothyroidism, primary hypothyroidism. Yes, team A, your choice. Yes, that's right.
Subclinical hypo.
Unfortunately, that is not. You may have to 5 marks minus 5 here. And shall we go to the answer from the audience? Anyone from the audience? Central. Central hyper is correct. 1 munch for you. Third question, shall we go? Which of the following is a symptom of hypothyroidism? Diarrhea, mental sluggishness, tremor, irritability.
Mental sluggishness.
You hit it there, 20 marks for you. And the answer is mental sluggishness. Weakness, lethargy, and mental sluggishness are the symptoms of hypo, and the others are with the hyper. So 20 points. And you are taking a question? Yes? Okay. So question 4 for you. What is the role of thyroglobulin? Assist with thyroid hormone production, transports thyroid hormones, storage of thyroid hormones, assistance in thyroid hormone.
A. Assist with thyroid hormone production.
That is not the right answer, my dear team, internal medicine team from Aster MIMS. It is open to the audience. It is something else. Storage is the correct answer. Storage is the correct answer. And who is getting the munch? Anybody from the audience for the munch? So I'll take it then. Okay. The answer is, so thyroglobin is a storage form of the hormone, right? So we'll go back to the topics. Only 2 teams left. We are cancelling it. And 2 more unnecessary pressing will disqualify you from the question. See, you know the rule number 1, right? So back to topics. Yes, they got it. Which topic?
Analysis.
You have not completed? Only two of you are left. Okay. Urinalysis. So urinalysis question. Ready to go? Which of the following is a cause of glucose in urine? Glomerulonephritis, Fanconi syndrome, urinary tract infection, lupus nephritis. Yes. Department of OBG from BMH. Team C. That is, I am going to pass on the questions quick.
Lupus nephritis.
No negative marks, but it is not correct. Anyone from the audience? Fanconi is the correct answer. Fanconi syndrome is the correct answer. A packet of Santosh. Okay, we'll go. You want to take the second question? 10 marks. Okay. Which of the following causes dark urine? Protein, lipids, porphyria, dehydration. I said dark urine. Yes? Quick, your time. You will get
dehydration.
Dehydration is the correct answer. This is black urine alla dark urine nu njan dark urine, dehydration, they get 10 points. 10 points. So even though you lost 5 there, you did not get 5, you didn't lose 5, now you got 10 points. And shall we go to the third question? Okay. Question 3. What does the term glycosuria refer to? Diabetes mellitus, glucose in urine, glycogen in urine, ethylene glycol in urine.
Glucose in urine.
Glucose in urine. Very easy, 20 marks. So I told you and solved baby's quiz here. 20 marks. 20 marks to team C. And you are boldly, I am sure, will be going for the fourth question. 30 marks. So the fourth question is, which diabetic medication acts by causing excretion of glucose in urine? Metformin, gliclazide, empagliflozin, and pioglitazone. You are taking a little bit more excessive time. They are complaining to me, other teammates. Other teams are complaining. Before they officially lodge a complaint, please answer.
Empagliflozin.
Absolutely correct. And that's really a wonderful answer. And they get 30 points for that. Very highly scoring for the first time. The team from BMH, what is their score? 6-0, 60. You are almost there. But there are a lot of opportunities for others to catch up with you. So don't worry, don't relax. Moyalne pole avanda. Aame moyalne kadele. So now we are back to topics. No more buzzer required and no more selection required. No more selection required, and the topic is chest X-ray. Okay. So we go to the questions. First question you can take easily. What are the fractures seen in this chest X-ray? Right ribs, left ribs, right clavicle, right humerus.
Right ribs.
Ribs. So easy. Takkade parayendadalle. 5 mark, 5 points. Next question. Shall we? So second question, which of the following tends to present as diffuse consolidation rather than localized consolidation? In chest X-ray, I mean. Lobar pneumonia, non-small cell lung cancer, cryptogenic organizing pneumonia, pulmonary edema. I am talking about chest X-ray. Yes? Mithun? Sudha? Sujata?
Pulmonary edema.
Pulmonary edema is the correct answer. All others sound specific lobar pneumonia type. So they get 10 points here. Are you ready for the question? Shakti varallo? Yes. Yes, Midhun. The third question comes here. Very easy question. I am sure you will get this. What deformity is seen in this chest X-ray? Lordosis, kyphosis, scoliosis, ankylosis.
Scoliosis.
Scoliosis, 20 points, and the answer is scoliosis. Can you just tell me without any marks what view is required to detect other deformities? Lateral view is required. In a chest PA, you cannot see the other deformities. So 20 points. 20 points for them, and I am sure they are going to beat BMH by taking the third question, right? Shall we? Fourth question, right? Okay. And the fourth question is, what are Kerleby lines due to? Fluid in the deep septae, thickening of the interlobular septae, fluid within the alveoli, pulmonary scarring. I will give you a clue if you want. The answer is there in the question. That is a good. Yes, ini samayilla.
Thickening of interlobular septum.
You got it through the clue? This is the right answer. What was the clue? B. B is the answer. Thickening of the interlobular septae, 30 points. So what is their score? 65, 5 of you. So now we are over with let me take you to the last of this round. One second. The round in the score. After 2 rounds, we will now get the total score of the teams. Our scoring team is very meticulously calculating the score.
Team A 5 points, Team B 25 points, Team C 75 points, Team D 85 points, Team E 5 points.
So which team is leading? I didn't. Team D is leading with 85 and second position 75, 25. 5 points each. Very good, very good. So there is a good fight going on. So end of round 2, we are entering round 3, and after that we are round. So we will wind up. Okay. Round is called a clue round. There is a different type of marking. Scoring system is different, and the rules are: buzzer is a buzzer round. Identify the famous personality. Clues. The marking system is answer without any clues 20 marks, with 1 clue 15 marks, with 2 clues 10 marks, with 3 clues 5 marks and -5 even if there is no answer after 3 clues. The team can withdraw at any level without any negative marks. The question will be going to the audience and there is no rebuzzing. Manasilayo? Samshayangalundo? Team D, it's not clear to you? Sujata's face is showing that she is sort of desperate. And what about you? Family medicine? All clear? Yes, clear? Shall we go? So hands on your buzzer. Question number 1. You will see the picture. Personality. So you have to press the buzzer to answer the question, start answering the question. Then you will be given the clues, okay, if required. So now let's go to the number 1 question. This is the personality. So I thought everybody will be jumping onto the buzzer. But you have clues coming after this. You will be definitely able to answer this, identify this person. Team B, Arkumenda. There are no negative marks. You can withdraw any time. So why are you hesitating? After this, the clues will come, don't worry. Only thing is that if you don't identify You are not getting 20 points, you are not losing anything. Next, with one clue, if you identify, you get 15 points. After the second clue, if you identify, you get 10 points. And if you don't want to go further, you can say, okay, I am not going further, I won't be able to. Yeah, yes, that's the spirit. So can you identify for 20 points without any clue? So we'll go to the clues. And the clues are, clue number 1, American, all these personalities are doctors, okay. American doctor, born in the year 1920 and died in 2016 following a heart attack at the age of 96. Clue number 1, and if you answer correctly with this clue, you will get 15 points, no negative marks. You are entitled for a one wrong answer, don't worry. Harrison? No, Harrison alla. Don't worry, you can go to the next clue, right? The next clue is invented the flutter valve used for chest drainage, which saved lives of hundreds of soldiers in Vietnam War. $10 points. And you take the next clue, 100% I am sure you will answer with that. Shall we go for the next clue? Proponent of the famous abdominal thrust to save patients with choking. This maneuver is known by his name. Himmlich. It is Henry Judas Himmlich. 5 points to team A. Dr. Henry Judas Himmlich. So that's good going. Okay. So now you understood. You can easily and comfortably press the buzzer. Then only we can go further. Okay. So team A, you can press for the next question also. Okay. It's open for all the 5 teams. Next question is question number 2. The personality here comes. This is the personality. Who is pressing? Who is going for the clues? Take, nothing to lose. Yes, team C, you are bold. So, without clue, are you trying? You are eligible for, entitled for one wrong answer. Nothing will happen. You can try. Venda. Upper first clue. And the clues are, Indian doctor born in 1970, settled in the US, who was awarded Padma Shri in 2014. This is Indian doctor, Padma Shri, and still living. Any hit? Shall we go to the next clue? This is 15 marks and next is for 10 marks. No negatives, don't worry. Specialized in medical oncology and has done significant research in the viral etiology of cancers. His laboratory focuses on discovering new cancer drugs using innovative biological methods. Ready? This is a 10-mark question, no negative marks. You can say one wrong answer, that is also accepted. You can try with one answer. If it is, even if it is wrong, you can go to the next clue. Venda. Next clue. Authored the bestseller and a multiple award winning book, The Gene, and the Pulitzer Prize winning book, The Emperor of All Melodies. I thought most of you would have read that book, The Emperor of Melodies. And who is the author of that book? The Indian doctor, the oncologist. All the clues you got. Shall we throw the question to the audience? Audience includes you also. Anybody? Siddhartha Mukherjee. Siddharth Mukherjee. Who gets? The answer is Siddhartha Mukherjee. And by the way, you should read that book. As young doctors, you should definitely read that Emperor of All Melodies book. Okay, now again, please go to the buzzers. We are going to the third personality. Shall we go to the third personality? Here it comes. Yes, team E. 20 marks. You can try once. You can try, don't worry. Mic on.
Louis Pasteur.
Louis Pasteur, Allah, don't worry. We'll go to the first. First clue is that a physician born in Scotland in 1859 and died at the age of 71 in 1930. കാര്യമായ ഇൻഫർമേഷൻ ഒന്നും അത് കിട്ടില്ല. അടുത്തതിലേക്ക് പോവാം അല്ലേ? ഇനി പക്ഷേ എന്തായാലും നിങ്ങൾ പറയും. Highly acclaimed creator of detective fiction and creator of 2 iconic characters, out of which one is a doctor. Your chance. 10-mark question. Ten marks. ഇനി അധികം ആലോചിച്ചിട്ട് കാര്യം ഉണ്ടാവില്ല. നെക്സ്റ്റ് ക്ലൂ. Try out.
Next clue, negative.
No negative, no negative. You can boldly say one answer.
Next clue.
Next clue. ഇതിൽ പറഞ്ഞിട്ടില്ലെങ്കിൽ എൻ്റെ നെഗറ്റീവും കിട്ടും. Better known through his famous character Sherlock Holmes. And he is a doctor. He was a physician. The author is a physician. William Harvey alla. Anybody? Arthur Conan Doyle. Sherlock Holmes എഴുതിയത്. You get Shabina, you get a munch. So, Sir Arthur Ignatius Conan Doyle, that's the full name. To the fourth personality, number 4. Ready? Team A. Yes. Parayu. Clue veno. 20 marks venda. Okay. Afghan born doctor ana, 1965 born, American physician turned novelist. Afghan born physician turned novelist. 1965 born and still alive. Next clue. His writings carry the fragrance of Afghan history and culture while dealing with most intense of human dispositions. Next clue. Author of the books A Thousand Splendid Suns, The Famous Kite Runner and The Mountains Echoed. No? Mine? Khalid Hussain. Khalid Hussain is the correct answer. You being in the team, management team, you will not get much. She will get much. -5 for team A. So we have one more personality in this round. One more personality. Let us see. Khalid Hussain is the answer, and the next one is this. Yes, team B. Are you trying? Are you attempting at this level? 20 marks. Try. There is no harm. One you can do.
Madam Curie.
Madam Curie, no. We'll go to the first clue, right? An American anesthesiologist born in 1909 and died in 74 at the age of 65. Next clue. Specialized in obstetric anesthesia, she worked to reduce infant mortality. There are words which are linking to her name, especially on the second half of the second clue. Okay, shall we go? Shall we move? Third clue. Okay, right. This work led to a standardized scoring system used to assess a newborn's health after birth, with the result referred to as newborn's Apgar score. Rashaila. Shall we go to the answer? I am throwing this to the open. Open, yes. Virginia Apgar. Who gets that? Raju? Venu, you can take a munch. The Virginia Abgar. അങ്ങനെയാണ് സ്കോർ എന്ന് വന്നത്. അപ്പോൾ സ്കോർ പറഞ്ഞോളൂ അവരുടെ. ഇതിൽ മാത്രം എല്ലാവരുടെയും പറഞ്ഞില്ലേ നമ്മൾ? പറഞ്ഞിട്ടില്ല അല്ലേ? Okay, this round, end of the round, total score after this round. So now while the scorer is calculating the total score, the next round is a different. There is involved. This is a rapid fire round, and with that we are closing the program. Rapid fire round means it is some sort of an identification period. You will be shown images, you just have to say what it is. ചോദ്യങ്ങളും ഒന്നുമില്ല, പക്ഷേ സമയം ഉണ്ട്. There will be 12 questions to be answered in 2 minutes time. Okay, so I need a timer here. You will do the timing. You have a time stopwatch on the phone. Yes, please take it and fix it at 2 minutes. Rules I am coming to. Just wanted to know whether you have the timing. Our scoring team is ready with the timer. So I will go to the rules. The round is called rapid fire round, round 4, and the last round of this session. Before we go into this, we will now listen to the scores. Scorer, are you ready? Yes, please. Mic.
Team A 5 points, Team B 25 points, Team C 75, Team D 85, and Team E 0 point.
Yes, at least some consolation in this round you should get. Okay. So now we are almost ഫൈനലിലേക്ക് കാലെടുത്ത് വെച്ചോ അല്ലെങ്കിൽ വിജയത്തിലേക്ക് കാലെടുത്ത് വെച്ചോ എന്ന സ്ഥിതിയിൽ എത്തി നിൽക്കുന്ന റൗണ്ടാണിത്. ഇനി മാക്സിമം മറ്റേ റൗണ്ടിൽ നിന്ന് നിങ്ങൾക്ക് കിട്ടാവുന്ന പോയിന്റ് നോക്കുകയാണെന്നുണ്ടെങ്കിൽ 24 + 5 29 പോയിന്റ്സ് ആണ് മാക്സിമം കിട്ടാൻ പോകുന്നത് ഈ റൗണ്ടിൽ. അപ്പോൾ നിങ്ങൾക്ക് കാൽക്കുലേറ്റ് ചെയ്യാം ആരെവിടെ എത്തുമോ എന്നുള്ളത്. Okay, the rules are fire round or identification period. There will be 2 questions which is not identification but designate a team member from each team to give the answers. You have to decide who is going to give the answers. So the mic will be with him. Quickly you give the answers, and he can discuss with the teammate if required at the expense of the time. But you will be losing if you discuss. You will lose the time, or you can quickly tell them. There will be 12 questions in each set. 2 marks for a correct answer, 1 minus for a wrong answer, and 0 marks for a past answer without committing. Okay. മുമ്പേ ക്വിസ് കളിച്ചിട്ടുള്ളവർക്ക് ഫെമിലിയർ ആയിട്ടുള്ള റാപ്പിഡ് ഫയർ റൗണ്ടാണ്. ദ ടൈം അലോട്ടഡ് വിൽ ബി 2 minutes and 5 bonus points for attempting all 12 in 2 minutes. Need not be all correct. If you attempt the entire 12, I will give you 5 bonus marks. Okay. Now we will start from Team A. So who is going to answer? Sure. So check your mic. Scorer, timer ready. So time starts now.
Radius.
Correct.
It's CT.
Mark it.
Adipocytes.
Correct. Correct. Specific.
H pylori.
Wrong. Muscle.
Triceps.
What smear? You can pass.
Bone marrow.
It's a peripheral blood smear. What is the diagnosis? Wasting time, you can pass.
Chicken pox.
Chicken pox, correct. What scan?
PET scan.
No, wrong. What is this?
PTA.
Correct. What is the full form of BUN?
Urea nitrogen.
Correct. Last question. Who is the president of IMA Kozhikode branch?
Venugopal.
Venugopal, yes. So that means how many questions correct within time? Okay, then they get 5 bonus points also. Okay. Now we'll quickly go through the answers. Okay. Radius, brain abscess, adipose tissue, you got it correct? You can check if you. Defibrillator, E. coli, Anconius muscles, it's hidden here. Anconius, acute lymphoblastic leukemia, chicken pox, bone densitometry or DEXA scan, pure tone audiogram, blood urea nitrogen, Venugopal. How many points do they get? One, 3, 13 points. And am I going very fast for you? But I can't slow it down. So next, team B, your turn. Sorry. Your time starts. Your time starts now.
Alna.
Alna.
SDH.
Yes.
Born. In.
Very true. Shigella wrong. Which muscle?
Gastrocnemius.
Gas. Correct muscle. Diagnosis.
CML. Psoria.
Wrong.
Next.
Pass.
You have time. What is this? No diagnosis. What is this? You have time. You can go back if you want. The ones.
Next.
Pass. Cytomegalovirus.
Yes, correct. Director of Studies of IMA Cgp. How many seconds left? Oh, enough time. You can go back to the questions. Ortho, OPG is correct.
Sir, thyroid uptake study.
Which, this one? No, that's wrong.
Contact dermatitis.
No, that's again wrong. Only one chance. This you got it wrong. You can go back. Okay, you have finished this. And now by the time you calculate, we'll go to the answers. Ulna. Chronic subdural hematoma, you got it right. Bone. Infusion pump. Salmonella typhi. Gastrocnemius. Acute myeloid leukemia, you said chronic. Eczema. PET scan. OPG. Full form, cytomegalovirus and Dr. Benny PV. Okay. So your scores will come now. And team C, are you ready?
Yes, sir.
No, score? 14.
Team B 14.
Okay. Now team C, ready? Your time starts now. Which board?
Pass.
What diagnosis?
Pass.
What is this?
Cartilage.
I'll give it to you, correct. Which?
Pass.
Which muscle?
Iliasis.
Correct. Pass, correct. Diagnosis.
Pass.
What is this?
Infusion pump.
Wrong. What is the diagnosis?
Herpes.
Correct.
Pass. X-ray KUB showing.
There is only specific name. Pass.
Endoscopic retrograde cholangiopancreatography.
Correct.
Pass.
Pass. You have time. You want to revisit?
Yes.
This you passed. Everything else, this you passed, right? Okay, finish? Yes. We go to the answers. So you can calculate, go to the answers. Scaphoid, you did not answer, you passed that, right? Again, you passed that. It is, I gave you the mark, it is hyaline cartilage. You said only cartilage. Staphylococcus, you did not say this. Staphylococcus aureus. Malaria. Malarial parasites you can see. This is not infusion pump, this is syringe pump. You can see a syringe inside there. Herpes zoster, you got it right. This is gamma scan. And this is IVP, you did not say that, intravenous myelogram. This you got it correct, and you did not say Manoj Kumar. Okay, that is the end of this round for, and their marks? 12, very close. So team D, your round comes now, right? Shall we stop? Your time starts now.
Pass. Hemorrhage, intracranial hemorrhage.
Correct. Give you 2 marks for that.
Columnar epithelium.
Correct. Columnar epithelium.
Ventilator.
Correct. Ventilator. This one?
Pass. Latissimus dorsi.
Latissimus?
Dorsi.
Correct. And diagnosis?
Microcytic hypochromic.
Correct. Diagnosis?
Measles.
Correct. What is this?
Mammogram.
Mammogram, right? And this is?
EMG.
Yes?
E? EMG.
EMG is correct. And IBS?
Irritable bowel syndrome.
Yes, absolutely correct. And it was director of Ima Cgp Kozhikode. Finished. You want to go back? There is nothing to go back. All this you got correct, right? This one you didn't saw.
Streptococci.
Correct. So you got everything else, right? One more is there. First question, yes. Yes. How many seconds do they have? Time up, I'm sorry. So we will go to the answers and see. By the time scorers calculate your score, here comes the answers. Intracerebral hemorrhage, this is actually trapezium. This is trapezium. Simple columnar epithelium, ventilator, streptococci, latissimus dorsi, microcytic hyperchromic anemia, measles, mammogram, EMG, irritable bowel syndrome, and Dr. Shamsuddin. 25. Did they add 5 marks to it bonus? That everybody is getting, right? 1 minute vecha madiyirunnu. Now, team E, your last set 5. Okay?
Yes, sir.
Shall we start? Your time starts now.
Pass. Mass lesion.
That we all know. What is it?
Pass. Pass. Boyle's apparatus. Boyle's machine.
Come on, in which age are you living? Boils are all ancient things. Correct name for this?
Mapleson.
No, anyway, let me see whether I can give it to you or not. We'll keep it on hold. Let us keep it on hold.
H. pylori.
No, wrong. Which muscle?
Temporalis.
Correct. Diagnosis.
Anemia. Atopic dermatitis.
Wrong.
Tinea.
Wrong.
Pass. Heart. CT angiogram. Coronary.
Wrong.
Pass.
This is not CT angiogram in any case.
Methicillin resistant Staphylococcus aureus.
Yes, correct. Ariyo? ഒരു ക്ലൂ കൊടുക്കണം. അതെ, ഒരു ആൺതരി ഒരു പെൺതരി എന്നൊക്കെ പറയില്ലേ, അങ്ങനെ ഒരു പെൺതരി മാത്രമാണ് ഇതില്ലേ. 2 minutes കഴിഞ്ഞു. ക്ലൂ തരണം എന്ന് വിചാരിച്ചാലും ഇനി നടക്കില്ല. നമുക്ക് ആൻസേഴ്സ് കാണാം. റൈറ്റ്? സോ യുവർ ആൻസേഴ്സ് ആർ trapezoid. This is trapezoid. I have not written here. And this is vestibular schwannoma or acoustic neuroma. People say acoustic neuroma also. And this is simple cuboidal epithelium. This is anesthesia workstation. We'll give 1 mark for that. Vibrio cholerae. You made this correct. Temporalis muscle. Sickle cell anemia you scored. Psoriasis. Cyelogram. Have you heard of cyelogram? This is cyelogram. Parotid, salivary gland. This is not CT. This is coronary angiogram. Percutaneous coronary angiogram. MRSA, you got it correct. And Dr. Sabina, she is sitting there. So, end of rapid fire round, and that brings us to the end of the Ima Cgp quiz program. And thank you very much for giving this opportunity and also the time that you spent with us. And I would like to thank you. So, now we will announce the prize winners of the quiz, and President will announce what is a prize. I don't know whether he is going to give you a cash prize or not. I am not aware. Ayya, you are getting cash prize. അതെ അതെ, അപ്പോൾ അവർ വിചാരിക്കുന്ന ഒരു സർട്ടിഫിക്കറ്റ് ഒന്ന് പറഞ്ഞു വിടുന്ന വിചാരിച്ചിരുന്നത്. ഇപ്പോൾ സോ റിസൾട്ട്സ് ഇപ്പോൾ അനൗൺസ് ചെയ്യാം. വേണു പറഞ്ഞോളൂ.
First of all, thank you for joining with us. And I am inviting all of you for IMA in future because all of you are postgraduates and I think you are not at IMA. Any members in this? Oh, great. So I request all of you to join IMA at the earliest, because if you are less than 6 years of your getting the TCMC registration, Kerala State Medical Council registration, you will have a very good offer now. Instead of 23 or 24,000, actually that is a life membership. You will get it around 13 point of, including that to 16,000. Because that's a one-time life membership, and you can entitle other benefits of Indian Medical Association. That is the sole organization for modern medicine doctors. That's you have to understand. Because our, everybody know our in the morning. I think you have not heard the presentations of the speeches of our senior leaders. Our fraternity is facing a lot of challenges, and we have to unite. You have to increase the membership. Then only we can speak boldly to the authorities, that is bureaucrats, about our rights and our privileges. So we have to increase the membership. There are a lot of schemes, professional protection scheme and social security, and there are a lot of schemes are there. Anyway, congratulations to the winners, not yet announced, I think. And we are ready to give a cash prize as an incentive for all of your participation, along with the certificate.
നിങ്ങൾ ഐഡൻറ്റിഫൈ ചെയ്യാത്ത ഹതാശനായ അസിസ്റ്റന്റ് ഡയറക്ടർ ഞാനാണ്. ഇന്ന് രാവിലെ മുതൽ IMAയുടെ ഭാരവാഹികളും മറ്റു മെമ്പർമാരും IMAയുടെ സ്റ്റേക്ക് ഹോൾഡേഴ്സ് എല്ലാവരും ഒന്നിച്ചു ചേർന്ന് അതിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്ത നിങ്ങളും IMAയുടെ സ്റ്റേറ്റ് CGP വളരെ ഉഷാറാക്കി. IMA ഡോക്ടർമാരുടെ ലൈഫിൽ ഓർഗനൈസേഷനാണ്, അക്കാഡമിക് പ്രൊമോട്ടറാണ്, പിന്നെ നിങ്ങളുടെ സോഷ്യൽ സെക്യൂരിറ്റി, പ്രൊഫഷണൽ സെക്യൂരിറ്റി എല്ലാത്തിനും നിൽക്കുന്ന ഒരു സംഘടനയാണ്. അതുകൊണ്ട് പുതിയ ജനറേഷൻ ഡോക്ടേഴ്സിന് എല്ലാവരെയും IMAയിലേക്ക് ക്ഷണിച്ചു കൊടുക്കുന്നു. ഈ IMA CGPക്ക് വന്നതുകൊണ്ട് നിങ്ങൾക്കൊരു 10,000 രൂപയുടെ ഓഫറാണ് ഡോക്ടർ വച്ചിരിക്കുന്നത്. ഇപ്പം മെമ്പറാവുന്ന നിങ്ങൾക്ക് 6 വർഷത്തിന് മുമ്പാണെങ്കിൽ 10,000 രൂപ കുറവാണെന്നാണ് പറഞ്ഞിരിക്കുന്നത്. കപ്പിൾസിനാണെങ്കിൽ വേറെ ഒരു റിഡക്ഷൻ ഉണ്ട്, കപ്പിൾസ് മെമ്പർഷിപ്പ് ആണെങ്കിൽ.
അല്ല ഷംസുദ്ദീൻ, ഇപ്പോൾ പ്രൈസ് മണി കിട്ടി, അതാണ് അപ്പം തന്നെ മെമ്പർഷിപ്പ് എടുക്കാൻ പറയാം.
അതെ അതെ, എന്നാൽ ഞാനും ജോയിൻ ചെയ്യാം കോമ്പറ്റീഷന്. ഓൾ ദി ബെസ്റ്റ് ആൻഡ് ദ വിന്നേഴ്സ്.
So before we announce the winners of this quiz competition, I would like to place on record my gratitude to the IMA CGP and IMA branch, Kozhikode branch, President Venu and Dr. Shamsuddin CGP Secretary for having given me this opportunity, and definitely I'm going to that. And now I have an entire one single family supported for the entire program, that is none other than Venu and Supriya, and thank you Venu and Supriya for the excellent moral as well as physical support. Now I would like to also introduce, as I introduce, I would like to thank here profusely Miss Shamin for having come a long way from Thrissur only for this program to give us the buzzer facility here. So now IMA has decided to acquire a set of buzzers. So Venu has given me a word that we will buy one, and one more thing I request Venu, two Venus here, that we have to now take it up very seriously, especially since Venu is going to be the president for next 1 year. We IMA Kozhikode branch should conduct an annual rolling trophy quiz program for all medical colleges in Kerala. So we should do that, and I will take the initiative. I will be with you to coordinate the program. Instead of waiting for them to come here, we'll all go to their colleges and conduct programs there. Then the participation will be much higher in such cases. So once again, I thank all the light and sound, perfect arrangement. Usually the technology always fails. Sometimes the connection will not come, but everything worked perfectly. Thank you very much. And now we announce the winners of this program. Before we start from the lower end, the reverse order, we have team E from Aster MIMS Family Medicine Department scoring 9 points ultimately in this program. Well done, and I would say they were one of the boldest teams. Yes, absolutely. And next time, this is an impetus for you to come next time. because minus mark or plus mark, I am not bothered, we are going to answer this. That's the spirit. Right. But that spirit led them to this position of 0.9, and then we have the fourth position, that is Team A with 18 points. Again, the Internal Medicine Department from Aster MIMS Calicut. Congratulations, and I thank and invite you for the next program. Let us make it a tough competition for everyone. And the next position is by Team B with 39 points. And congratulations, the Emergency Medicine Department. That is the third position, and we have some prize for that. Please come forward and accept the prize from the President. It is not only the certificate, you can see the President holding an envelope, and there is something serious inside that. I will join you. Yes. Oh, turn this side. Camera's here. Okay, congratulations. Now the second place goes to Team C, the Internal Medicine team from the Medical College Calicut. I'm sorry, the Obstetric Gynecology team from BMH Calicut. Please come forward to receive your second prize, the certificates and the cash. Come here. ഇവിടെയാണ് ക്യാമറ, ഇങ്ങോട്ട് തിരിയണം. And now, ladies and gentlemen, let us give a big hand to Mithun and Sujata, representing Internal Medicine Department of Government Medical College, Calicut. Please come forward. They have won the quiz program this year, this time, with a whopping score of 110. Congratulations. കവറിൽ എത്രയെന്നുള്ള വെളിപ്പെടുത്തണ്ടല്ലോ അല്ലേ? ഒരു ടോക്കൺ മാത്രമാണല്ലോ. Okay. Thank you very much. Over to you, Venu.
And now it's big thanks to Mohanushan sir for conducting this quiz very smoothly, and we have to meet again. Maybe in the next 2-3 months, we will conduct, as sir told, we will conduct a huge round of quiz competition with a final round here itself. Mostly in all the medical, we will try to get all the medical colleges in the same lane. And two things you have to spread. There's a quiz competition. Another is the need of joining IMA. That you have to spread to your friends. Yeah. Definitely, we have to make it like that. IMA members only can participate. And I invite Venu sir to give a memento as a part of appreciation of this simple token of appreciation from our branch.
Thank you, Venu. Thank you. Thank you, sir. Okay, Shamsu. Thanks.
For organizing this scientific program, I personally thank Dr. Venugopal sir. Of course, he's one and only. Of course, we have another Venugopal sir, but still he is a scientific committee chairman, and I, as a token of appreciation, I hand over this moment to him.
Thank you, sir. Shall we close the program? Thank you all.